embryo. Uh, Embryo fetal erythropoiesis. Fetal erythropoiesis occurs in yolk sac, liver, spleen, and bone marrow. Just gotta remember this chart. They do test you on that. Right. So in yolk sac, erythropoiesis occurs in yolk sac between the weeks of 3 and 8. Right, so 3 to 8. That thing right there, the yellow one and the yellow lines. Right before it drops down to 0, the liver, erythropoiesis begins in the liver as well, between 6 weeks to birth. So that one right there, and that's the red one. So 6 weeks to birth. Never mind, that's a different thing. This thing to this thing. Right. So I guess that's not it either. It's this one you look at. So yolk sac is 3 to 8, 6 to birth, and then we have spleen, 10 weeks to 28 weeks, and then we have bone marrow, 18 weeks to adult. Okay. So liver is only up till birth. After birth, it's only bone marrow, right? However, the bone marrow, it starts from 18 weeks, right? So there's a mnemonic: young liver synthesizes blood, yolk, liver, then spleen for a little while, but then bone marrow. Okay, so up till birth, liver, and after birth, it's bone marrow. Then we gotta know what type of hemoglobin is in the fetus. So hemoglobin development, embryogenic globulin, that and epsilon. Not sure what that symbol is, but right there, that and epsilon, right? So those are the embryonic ones. But then after a while, you get fetal hemoglobin. That's alpha 2 and gamma 2, right? So alpha and gamma. Notice how after the rise of alpha, it stays in adult as well. However, for gamma, it goes down after birth, right? And then it decreases. And then in adult hemoglobin, it's going to be alpha 2 majority of the time. It's called HbA1, and the fetal one is called HbF. Okay, so HbA1, you have alpha 2 and beta 2. You have alpha there, and beta has a rise after birth. As gamma is going down, the beta is going up. A good way to remember is this one right here: alpha always, gamma goes and becomes beta. Okay, so alpha's on both, the gamma gets replaced by beta. Fetal hemoglobin has higher affinity for O2. This is an important concept. It's due. Okay, so affinity for O2 due to less avid binding to 2,3-BPG, allowing fetal hemoglobin to extract O2 from maternal hemoglobin, hemoglobin A1 and hemoglobin A2. Across the placenta, hemoglobin alpha 2, A2, that's alpha 2 and delta 2, is a form of adult hemoglobin present in small amounts. Okay, they haven't given you delta, so you just gotta know that there is something called HbA2 instead of A1, and this one still has the alpha, but the beta is replaced by delta. Okay, and why is this? Why does oxygen have more affinity to HbF? It's because that's how the fetus extracts oxygen from maternal circulation. It's easier for them because there's less avid binding to 2,3-BPG. If you remember that whole concept, and oxygen hemoglobin, get rid of that. Okay. Attack. Okay, there you go. This thing. So in oxygen dissociation curve, we looked at the O2 uh, affinity to hemoglobin, right? So that's O2 over there, and that's hemoglobin over here. And we learned about the left shift and the right shift. The right shift is ODC, reflects decrease in hemoglobin affinity for O2. Okay, so this is going to be the maternal one, right? Uh, this one, the maternal one, is going to be easily giving off the oxygen from the hemoglobin because they have increased 2,3 BPG binding. However, in the fetus, there's going to be a left shift. That means their hemoglobin has a higher affinity for O2. Okay, so that's going to be on this side. Why? Because of this. So let me read that. Hold on. So it reflects increase in hemoglobin affinity for oxygen uh, because there's decrease in oxygen unloading at tissue. Physiologically occurs with decrease in O2 needs and pregnancy. Okay, so fetal hemoglobin has a higher O2 affinity than adult hemoglobin and increase in O2 binding due to decreased affinity for 2,3-BPG. Okay, so yeah, the mother has the 2,3, fetus doesn't have that, so that's why oxygen binds to this, because oxygen has decreased affinity for 2,3-BPG, and adult RBCs are gonna have that. Okay, and I forgot what number we were at. Yeah. Okay. So hemoglobin has a higher affinity for O2 due to less avid binding to 2,3-BPG, allowing fetal hemoglobin to extract O2 from maternal hemoglobin. Okay. Adult A1 is alpha 2, beta 2, and fetal is alpha and gamma 2. So there's fetus weeks of development, and this postnatal. We looked at the alpha. It starts from here and all the way. Erythropoiesis happens in the liver in a fetus up till birth. You have gamma, that's during the fetal life, and up to like 6 months you will have hemoglobin fetal hemoglobin until the 6 months postnatally, and you have beta rising after 6 months in a fetus. This is important because in like beta thalassemia or something, the symptoms don't start until the first 6 months of postnatal life, because the fetus or the neonate has alpha and like hemoglobin fetus or fetal hemoglobin until 6 months. So the symptoms of beta thalassemia, don't show up until it starts using the adult hemoglobin. Okay, blood group, ABO classification and RH classification. So RBC, group antigen on RBC surface and antibodies in plasma, and then the clinical relevance. Compatible RBC types to receive and compatible RBC type to donate to. We have group A. Group A has group A antigens on its surface. So it's gonna have antibodies for all the other ones, right? So anti-B basically. And this is class IgM. So it's compatible RBC type to receive group A and O. Okay, O is basically nothing on it, so it's fine to give. Then you have compatible RBC types to donate to. So that's you can give A to another a host who has group A or AB. Um, Similarly, there's group B with group B antigen. So that one has antigen against antibodies against group A. Also IgM class. It's compatible to give to group B and O. Um, to receive from group B and O, and you can donate type group B to group B and AB. Okay, AB it has both kinds, right? Group A and group B antigen on its surface, so it's not going to have any antibodies. So it's compatible RBC type to receive, so it can receive from AB, A, or B, or O, because it doesn't have any antibodies, so you can give any blood to this. So this is going to be universal receiver, right? You have compatible RBC types to donate to. So you can only donate to AB because it does have antigen against B or A in group A and group B, right? So then you have group O. It doesn't have any antigen on its surface. However, a person who carries this does have anti-A and anti-B antibodies, right? And this is going to be IgG predominantly, but there's also IgM class as well. So they can only receive from O, but they can donate to basically everyone, group A, B, AB, or O. So they're considered universal donor. Then you have RH classification. So there's just another type of antigen, right? So RH plus has RH antigen on the cells, or RHD, and the negative one doesn't have any RH on it, so it's none. The one that has RH on it, it's not going to have antibodies against it. However, the one that's negative will have antibody of class IgG, right? So anti-D. This is important. We'll talk about that in somewhere later. So that's what anti-D is. It comes in when you're dealing with a mother who has a OH negative, and she has a fetus, or she's pregnant with a neonate that has positive class RH, that is RH positive, right? So the mother's if the mother's immunoglobulin goes and attaches to any blood cell from the fetus, it's going to figure out that it has this RH, right? So then it's going to make up immunoglobulins to attack to it, right? So usually the first pregnancy is okay because it doesn't get introduced to it until labor. But after labor, the mother's immune cells are going to develop the anti-D. So during the next pregnancy, if they have RH positive child, it's going to attack it, right? Because now the antibodies are going to be circulating, and it's going to meet the blood cell of the fetus, and then it's going to attack it. So that's how you get the erythroblastophytalis or something like that. Okay, so the way we prevent that is if the mother is RH negative, we don't worry about whether the fetus has RH positive or not, because we don't really go in and check the blood type of fetus while they're still in there. So we just give them anti-D during labor. So that what's NTD is going to do, whatever immune cells get introduced to RHD, before immune cells do that, the NTD is gonna go and attach to that, so the immunity doesn't get introduced to any RHD. Right. Cool. Compatible RBC type to receive. So for this one, you can receive both Rh positive or negative. For this one, you can only receive Rh negative. However, you can donate it to both Rh positive and negative. And for Rh positive, you can only donate to Rh positive. Okay. So that's the one I was talking about. We'll read about that. Anti-kill antibody, a complex blood group system with high immunogenicity. Anti-kill antibody, usually immunoglobulin G, of a kill positive pregnant patient may cause hemolytic disease of the newborn when produced following previous sensitization to kill antigen and transferred through the placenta. Okay. Similar concept to the hemolytic disease, right? Irish hemolytic disease, also called erythroblastophetalis. So it sounds the same thing. Okay. Target fetal RBC precursor, less than RBC production, and mature RBCs, increase in hemolysis, resulting in severe fetal anemia. Anti-kill antibodies may also be associated with hemolytic transfusion reactions. Okay. For this, we need to know what this is. For genetic reasons, Cal-positive people, and especially men, are at a high risk for disease called Meckeloid syndrome. People with this condition tend to be fine until they hit middle age, and then various physical and behavioral change kicks in. What is Cal blood type? Complex contains many antigens that are highly immunogenic. These antigens are third most potent after those of ABO, Rh blood group. Okay. The presence of Cal antibody can be detected by maternal blood testing. If they are present, your doc will closely monitor your pregnancy through blood tests and ultrasounds. If your baby appears severely affected, blood transfusions given to your baby while he's still in utero can help prevent harm to baby. Okay. I haven't heard of Cal antibodies until now, so I had to look into that. Okay. Then you have hemolytic disease of the fetus and newborn, also called erythroblastosis fetalis. You have Rh hemolytic disease and ABO hemolytic disease. Okay, so interaction, that's with Rh negative pregnant patient and Rh positive fetus. Mechanism is first pregnancy, patient exposed to fetal blood, often during delivery. You have formation of maternal anti-D immunoglobulin G, right? So subsequent pregnancy, the anti-D IgG crosses placenta. Remember, IgG, G for greets. So IgG first greets the fetus. So IgG crosses placenta, and it attacks fetal and newborn RBCs, which causes hemolysis. Presentation is hydrops fetalis, jaundice shortly after birth, and kernicterus. Kernicterus is bilirubin deposit in the brain, right? So you'll have hydrop fetalis and jaundice shortly after. The treatment is you prevent by administration of anti-D IgG to Rh negative pregnant patients during third trimester and early postpartum period. So you give it during the third trimester and during the early postpartum period. Okay. If fetus Rh positive. Okay. Normally we are not sure if we don't check it, so you just give it anyways. Prevents maternal anti-D IgG production. That's the goal of this. Okay. We have ABO hemolytic disease, type O pregnant patient, type A or B fetus. Right, because type O has antibodies against both anti-A and anti-B. Right. There's pre-existing pregnant patient, anti-A and or anti-B IgG antibodies cross the placenta. Right. So pre-existing pregnant patients antibodies A or B, which is IgG antibodies, they cross the placenta, attack the fetus and newborn RBCs, the fetal and newborn RBCs, and it causes hemolysis. Presentation is mild jaundice in the neonate within 24 hours of birth. Unlike Rh hemolytic disease, it can occur in firstborn babies as well, and is usually less severe though. Okay, treatment is phototherapy or exchange transfusion, because we gotta take care of the bilirubin, right? We don't want it going to the brain and getting deposited there. So what does phototherapy do? It makes it water soluble, so they can pee it out. It doesn't neutralize bilirubin, it just makes it water soluble. Onto anatomy. Hematopoiesis, multipotent stem cell, right? You'll get lymphoid stem cells or myeloid stem cells. With myeloid stem cells, you get the RBCs, which is erythropoiesis, and you get the WBCs. That's your these ones, right? And you get thrombopoiesis or platelets through thrombopoiesis. With lymphoid, you get your immune cells, so B cells to plasma cell, and then plasma cell releases immunoglobulins, right? You have T cells, T helper cells, that's CD4, or cytotoxic T cells, that's CD8 cells, or you can have NK cells, natural killer cells. Cool. The monocytopoiesis is monoblast to monocyte to macrophages, right? This is the one that goes to the tissue. This is how it travels in the blood, and in bone marrow it's monoblast. For granulocytopoiesis, it's when you see granulo, what that means is there are granules in the cells. So it's a granulocyte because there are granules in the cells. Okay. So in bone marrow, it's myeloblast, and also for neutrophils, you get band cells. This is important to know because in some diseases you have increased amount of band cells, and that tells you that they're immature WBCs, right, or at least neutrophils. And if you have more band cells, that means you have immature cells, and if you have more immature cells than mature cells, it's called a left shift. Okay, and this left shift is more different than the left shift in oxygen dissociation curve. That's not the same thing. Okay, so this left shift is because of the blood. Okay. And neutrophils, right? Then you have basophil and eosinophils in the blood. Eosinophil is the one that fights off parasites, and it's also useful for allergies or atopy. And then you have basophil as that. Not really that significant. Then you have megakaryoblast. That's in bone marrow it's megakaryocyte, and in blood it's platelets. And then in erythropoiesis, you have erythroblast, reticulocyte, and erythrocyte. So if they say reticulocyte, it just means immature RBCs, and erythrocyte is mature RBCs. Okay, if you have increased amount of reticulocytes, it just means there's a left shift. Left shifts means there's immature production of the cell, increased immature cells production of the cells. Okay, moving on. Neutrophils. So there's acute inflammatory response cells. They're phagocytic, multi-lobed nucleus, right? So you have like 1, 2, 3, 4, 5. Okay. Specific granules contain leukocyte alkaline phosphatase, that's LAP. You have collagenase, so ACE, it cleaves collagen. Uh, right. And then it also has lysozyme and lactoferrin. You have eosinophilic granules uh, in lysosomes, contains proteinases, again ases, right, cleaves protein. Acid phosphatase, myeloperoxidase, and beta glucuronidase. This is the one that uh, deconjugates bilirubin, right? Yeah, in the bacteria. But you have that in here as well in neutrophils. Okay, inflammatory states. For example, bacterial infection causes neutrophilia and changes in neutrophil morphology, such as left shift. Okay, so when you have that, you will make more neutrophils, which will cause left shift, because since you're making a lot more neutrophil, you'll have more band cells than mature neutrophils, right? So that is a left shift. Toxic granulation, dark blue coarse granules, Dolly bodies. Uh, these are light blue peripheral inclusions, arrow in B. Okay, so this light blue thing. Let's look at more of those. Okay, so these blue things right there are called Dolly bodies. That blue thing right there. Blue, 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 blue. Cool. Blue over there. So those are their Dolly bodies. Okay, so they're light blue. They're peripheral inclusions. Okay, and cytoplasmic vacuoles. Okay, you need to know how to identify neutrophils without them telling you it's a neutrophil. Okay, so they'll tell you that it's a granulocyte, so it's something one of these three, right? And then they'll give you that it has a Dolly body, or there's a light blue peripheral inclusion, right? So that should tell you that. LAP is important because this is specific to neutrophils. The other stuffs you can find in like lysosomes of other cells as well. Okay, and it's phagocytic. Multilobe nucleus. This is important because we'll talk about that later. However, right here, they tell you. So neutrophil chemotactic agents. That's C5A. That was also anaphylactic, right? On C3 and C5A, where C5A is also chemotactic. Then you have interleukin 8. Interleukin 8 was the one that gets recruited by inflammatory interleukins. That was 1, 6, and TNF alpha. So they recruit IL-8 and IL-12. And the anti-inflammatory interleukins were which ones? That was IL-10 and TGF beta. Right. Okay. TNF alpha was the inflammatory one. Okay. LTB4, 5-HETE. These are leukotriene precursors. There's kallikreinin, platelet activating factor, and formylmethionine bacterial protein. Okay, you have hypersegmented neutrophils. This is nucleus that has more than 6 lobes and are seen in vitamin B12 and folate deficiency. Okay, so why does this happen? It's basically because in vitamin B and folate deficiency, what happens? You get a decreased amount of DNA and synthesis and all that stuff, right? So what happens is the mature cells, they don't die off that quick, right? So they'll have a longer life. So the longer life cells, longer mature cells, will start developing more lobes, and that's why you see high amount of lobes on a neutrophil. Okay, and there will be obviously more mature cells than immature cells because there's a deficiency, so it can't make new ones. Okay, so what is left shift? Left shift is increase in neutrophil precursors, for example, band cells and myelocytes in peripheral blood. It reflects state of increased myeloid production, and that's the pathogenesis for myeloid leukemia, uh, right? Chronic myeloid leukemia, because increased production of myeloid cells for a long time. So that's chronic and CML. Okay, reflects states of increased myeloid proliferation. Then you have leukoerythroblastic reaction. That's left shift, accompanied by immature RBCs as well. Okay, so leuko and erythro. So erythro is this. So you get immature is called reticulocytes, right? So immature RBCs. So left shift, accompanied by immature RBCs, suggests bone marrow infiltration. For example, myelofibrosis and metastasis. This is important buzzword kind of thing because that only happens in like 2 or 3 conditions, and this is one of them: myelofibrosis and metastasis. Okay. You have erythrocytes, RBCs. They carry blood, oxygen. Sorry. So carry O2 to tissue and carbon dioxide to lungs. Anucleate and lack organelles. Biconcave. They're anucleate, that means they don't have nucleus, and they lack organelles, and they're biconcave. Okay, with large surface area to volume ratio for rapid gas exchange. Lifespan of approximately 120 days in healthy adults and 60 or 90 days in neonates. Source of energy is glucose. So 90% used in glycolysis, 10% used in HMP shunt. We should know that now because we went over it in biochem. Membranes contain chloride and bicarbonate antiporter. Right, both negative ions. If you have one leaving, the other one will come in. Okay, so that's antiporter, which allow RBCs to export bicarbonate and transport CO2 from the periphery to the lungs for elimination. Erythroid red, cytosol cell. Erythrocytosis equals a condition called polycythemia. What it does is it increases hematocrit, right? Anisocytosis, they're varying in size. Also, increase in hematocrit can also cause increase in blood pressure, right? Because it's increase in viscosity as well now. Anisocytosis equals varying size, and then you have poikilocytosis, that's varying shape. Okay. Any side, I just talk about, like I say this word, the way I pronounce it is just anisocytosis. Right? So that's how you remember this one is meant for size. Any size 2C or cis, right? Or 2C works as well. Any size 2C. So that's varying in size, and then you have poikilocytosis, that's varying shapes. Reticulocyte, immature RBCs reflect erythroid proliferation. Bluish color, polychromasia on right gem sustain of reticulocytes represents residual ribosomal RNA. Okay. So important thing here is that it lacks nucleus. If it lacks nucleus, what does it not have? DNA and all that stuff, I guess. just know that. And it also lacks organelles, so it doesn't have mitochondria. That's what I was going for. And if it doesn't have mitochondria, it can't make its own generate its own electron and ATPs from that stuff, from the precursors for that in mitochondria. So it has to use glucose, and via glycolysis it gets ATP. Okay. And yeah, that's it. It carries O2, CO2, right? It carries oxygen too and CO2 from the tissues. And know what reticulocyte means? It means immature RBCs. And polycythemia, increase in hematocrit. Platelets or thrombocytes. They're involved in primary hemostasis. That means they keep the balance or equilibrium in the blood, right? How? They prevent leaking of blood, basically. So they're also anucleate, small cytoplasmic fragments derived from megakaryocytes. Right there, right? Lifespan of 8 to 10 days. Plates. When activated by endothelial injury, aggregate which other platelets and interact with fibrinogen to form platelet plug. Right, this is the platelet plug that the dextran from the viridins gets attached to. Right, so that's what dextran attaches to, and that's why you have viridins on your heart valves if there's damage there. Viridins is the one with the plaque in the mouth. So when you have dental surgery done or some kind of procedure there, the viridins goes down in your blood, and then it reaches the heart. And when it reaches the heart, there's platelet aggregation anywhere usually near the valves. So it secretes dextran, and dextran attaches to that. Contain dense granules, calcium, ADP, serotonin, histamine. Right? So it carries all of these things. And alpha granules as well. This is one Willebrand VWF fibrinogen, fibronectin, platelet factor 4. Approximately 1/3 of the platelet pool is stored in the spleen. Oh yeah, that's 1 Willebrand factor. VWF. So approximately 1/3 of the platelet pool is stored in the spleen. This is important. Thrombocytopenia or decrease in platelet function results in patagy. This is also important. This is how you know. It's along with this and the bleeding time that you know if it's a clotting factor that's responsible for this, or it's because of 1 Willebrand factor. So these are patagy. There are small little hemorrhages that you see. Okay. So thrombocytopenia or decrease in platelet function, same thing. This is less platelets, or it gets dysfunctional. Results in patagy. There's VWF or 1 Willebrand factor receptor, that's GP1B, and then you have fibrinogen receptor GP2B and 3A. We'll talk about these in the physio. Thrombopoietin stimulates megakaryocyte proliferation, just like erythropoietin. Alpha granules contain 1 Willebrand factor, fibrinogen, fibronectin, and platelet factor 4. Okay. Majority of this we're gonna talk about it again. So just know that it makes platelet plug. It carries cash, calcium, ADP, serotonin, and histamine, and alpha granules. Monocyte, found in blood, differentiate into macrophages and tissue. Large kidney-shaped nucleus, extensive frosted glass cytoplasm. Mono is one, cyte is cell. Macrophages. Okay, so this turns into this. This is an important topic because not really, but you need to know what macrophages are called in different areas of your body. A type of antigen-presenting cell, phagocytosed bacteria, cellular debris, and sentient RBCs. What is sentient? That's just the condition or process of deterioration with age, right? So, mature. Long life in tissue, differentiate from circulating blood monocytes, activated by gamma interferon. Remember the whole chart we had? So, gamma interferon and interleukin 2 activates macrophages and cytotoxic 8 cells, T cells, CD8 cells. Can function as antigen presenting cells via MHC2. Also engages in antibody dependent cellular cytotoxicity. Important cellular component of granulomas for this TB, because even though it can destroy it, it actually walls it off, so that's good. And in sarcoidosis as well, where they may fuse to form giant cells. Okay, and the sarcoidosis is the one that leaks out 1-alpha hydroxylase, which creates increase in vitamin D, activates some vitamin D more, and that causes increase in calcium as well. Okay, common presentation is African immigrant, or usually middle-aged women. Usually that's what the question stem usually involves, that kind of person. Macro, large phage eater. Macrophage naming varies by specific tissue type. For example, Coffer cells in liver, histiocytes, and so this is macrophages in liver are called Coffer cells. These are the ones that filter the blood. Histiocytes and connective tissue, osteoclasts in bone, and you have microglial cells in the brain. Lipid A from bacterial LPS binds CD14 on macrophages to initiate septic shock. Okay, lipid A from bacterial LPS. Remember, it has O antigen, A antigen, lipid A, and there was another one too. There were 3 things, and this was the lethal one, right? The virulent factor. Lipid A from bacterial LPS binds CD14 on macrophages. You have to know that CD14 is the cell surface marker on macrophages to initiate septic shock. Okay. Dendritic cells, highly phagocytic, antigen presenting cells, function as link between innate and adaptive immune system via T cell stimulation. Express MHC class 2 and Fc receptor on surface. Can present exogenous antigen on MHC class 1 as well. So that's called cross presentation. Yeah, eosinophils. It defends against helminthic infections, major basic protein. Okay. How does it work? Usually, the granules that they leak out, they contain all of these things that break down the parasite. Okay, so it's bilobate nucleus packed with large eosinophilic granules of uniform size. Important to differentiate between eosinophil and neutrophil. They'll give you a slide and then you need to know. So neutrophil is purple. It has a purple granule, right, or dark blue coarse granules. Whereas for eosinophils, It has a pinkish color, like you can see, right? With purple bilobic nucleus. Okay, it's packed with large eosinophilic granules of uniform size, highly phagocytic for antigen antibody complexes, produces histaminase, major basic protein, (MBP), a helminthotoxin, eosinophil peroxidase, eosinophilic cationic proteins, and eosinophil derived neurotoxin. Don't know how to remember that. Eosin is pink dye, and philic is loving. Okay, so it loves the pink stain, basically. Causes of eosinophilia: parasite and allergy, right? Like asthma, atopy. So parasite, Pac-Man. So parasite, asthma, chronic adrenal insufficiency, myeloproliferative disorder, allergic processes, neoplasia, and eosinophilic granulomatosis with polyangiitis, type of vasculitis. You have basophil. It mediates allergic response. Dense basophilic granule contains heparin, which is anticoagulant, and histamine, which is vasodilator. Leukotriene synthesized and released on demand. Basophilic stains readily with basic stains. Basophilia is uncommon, but can be a sign of myeloproliferative disorder, particularly CML. Okay, so if you have increase in basophil, it means you have CML. Okay, that's basically what it's significant for. Only it does contain heparin, but they don't test you on that. Mast cells mediate local tissue allergic reactions, contain basophilic granules, originate from same precursor as basophils but are not the same cell type. It can bind the Fc portion of immunoglobulin E to the membrane, activated by tissue trauma, and C3A and C5A. These are the anaphylotoxins. Surface IgE, cross-linking by antigen, so immunoglobulin E receptor aggregation. Degranulation occurs and it releases histamine, heparin, trypsin, and eosinophil chemotatic factors. This is called cross-linking. I think they'll talk about it, but just for an overview. See, this is the cell, and and it has a receptor over there coming in. So this portion right here is the Fc portion, right, of the immunoglobulin. So the Fc portion gets binds to the mast cell, and right, you have that over there, and you have like multiples of this, so all over the body. But then what happens is then it aggregates on one side. Even though it's here, it's going to get pulled over here. It's going to get pulled on this side by the antigens and all that attaching, right? So when all of these get pulled from here, it's not that the receptors, the immunoglobulin move, it's the receptor that moves on the cell. So when the cell, all surface moves all over here, it gets stretched, and when it gets stretched, it's gonna break, right? So when this goes all the way this way, and this cell goes the cell surface goes this way, this is gonna break, and the breakage is the thing that's gonna leak out all of these stuff, and that's called degranulation. Okay. So that's how cross-linking works by antigen. And then, so how does it go like that? Basically, the the antigen comes in and it will attach to the ATP site of this immunoglobulin and also this immunoglobulin. I think we did this in immuno as well, right? So this and this ATP site is going to attach to this on this side and this on this side. Yeah. Okay, I'll try again. Hold on. Check this. Do you see it now? Do you see it? Oh, like you weren't seeing the drawing, is what you're saying. Okay. So basically I was talking about, so you don't, do you see the arrow right here that I'm making? Okay. So the cell, right? And then it has immunoglobulins like this and like this, right? And then when it's so how does degranulation occur? That's what I was explaining. So this Y right here, when the antigen comes in, so this is the antigen, right? So it comes in, the antigen site is going to attach to this for this immunoglobulin, and for this it's going to attach to this as well. So it's going to bring this closer to this, right? And that's how aggregation occurs. That's what IgE receptor aggregation means. So all the receptors are going to get aggregated over there, receptors and IgE, right? So this is going to come over here as well. Whoops. So when all of them move closer together, it's going to stretch the surface of the cell over here. And when that surface gets stretched, right, like that, the surface breaks apart and that leaks out all the stuff, and that's called the degranulation. That's what they mean by degranulation. Okay. So it can bind to Fc portion of the IgE, that's the Fc portion of IgE, to the membrane, that's the cell membrane. It's activated by tissue trauma or C3A and C5A. So when it gets exposed to the allergen, so what happens is the surface IgE cross-links, right? So this is cross-linking when it's attaching to the antigen. So cross-linking by antigen, so IgE receptor aggregation. So all the receptors that it's attached to are going to get, it's going to crowd in one place and stretches the cell surface, so then it gets broken that way. And that's going to cause the degranulation. So what is degranulation? It's the release of histamine, heparin, tryptase, and eosinophil chemotactic factors. It's involved in type 1 hypersensitivity reactions. Chromoline sodium prevents mast cell degranulation. So that's what we use for asthma as well. It's used for asthma prophylaxis. Vancomycin, opioids, and radiocontrast dye can elicit immunoglobulin E independent mast cell degranulation. Okay. That means it can cause degranulation without IgE, without these things. It can cause this from this. Okay. So which ones? That's vancomycin, opioids, and radiocontrast dye. Okay. Mastocytosis, it's rare. Proliferation of mast cells in skin and or extracutaneous organs associated with c-KIT mutations, and increase in serum tryptase, increase in histamine. Okay. Flushing, pruritus, hypotension, abdominal pain, diarrhea, and peptic ulcer. That can lead to all of these things. Out of all this, I think this is the only thing that's important out of this. You need to understand this whole process of degranulation. for mast cells, and that is associated with IgE. Okay. Yeah, I think that's it. Lymphocyte refer to B cell, T cells, and natural killer cells, right? So these are all your lymphoid stem cell precursors, or like not precursor, but that's what it gets made out of, right? So B cell, T cell, and NK cell, plasma cell, T cell, and T cytotoxic cells. How much time do I have? 5 minutes. Okay. Okay, done with that. So B cell and T cell mediate adaptive immunity. NK cells are part of the innate immune response. Round, densely staining nucleus with small amount of pale cytoplasm. That's how you identify them. They don't have much cytoplasm. Natural killer cells, right? Or B cells or T cells, even at that. So most of the time, what they're going to test you on is B cells. So that's what you will be seeing. So you need to know that this is some kind of infection that is initiating the humoral immunity. Okay, natural killer cells, they have CD56 and CD16 markers, so you need to know those two. Important in innate immunity, especially against intracellular pathogen. NK cells are larger than B cells and T cells, with distinct cytoplasmic lytic granules containing porphyrin and gramzymes. This is important. This is how it destroys things. That, when released, act on target cells to induce apoptosis. Distinguish between healthy and infected cells by identifying cell surface proteins induced by stress, malignant transformation, or microbial infections. It induces apoptosis, natural killer, in cells that do not express class 1 MHC. That means any cell that doesn't have class 1 MHC on its cell surface is going to kill it. Okay, and that's how it knows what to kill, and that's why this is part of innate immunity as well. Okay, cell surface molecules, for example, virally infected cells in which the molecules are downregulated. Let's go into BT and plasma after the break.
B cells. So B cells has CD19, CD20, and CD21 on them. It mediates humoral immune response, originate from stem cells in bone marrow, and matures in marrow. Okay. So B for bone marrow, T was for thymus. It migrates to peripheral lymphoid tissue, follicle of lymph nodes, white pulp of spleen, uncapsulated lymphoid tissue. When antigen is encountered, B cell differentiates into plasma cells, right? So when antigen is there, B cell differentiates into plasma cells, which produces the antibodies. And memory cells can function as APCs, antigen presenting cells as well. Okay, T cells. So here we have that. So CD8. We talked about interferon gamma making macrophages, and it's also interleukin 2 that does that. And then macrophages releases interleukin 12, which again activates Th1 to make more or recruit more macrophages. Okay, NK cells has CD16 and 56 on them, and that's cytotoxic. Same thing, interferon gamma and interleukin 2 doing that. We have CD4 going on Th2. These are for eosinophil mast cells and basophils. That's they act on T helper cell 2 type. Right? There's the helper cell, or also your this is the one that activates the B cell kind of thing, right? So you have B cell activation into immunoglobulin E production as well. And interleukin 5, you need to know about that one. It activates eosinophils, and interleukin 10 gets the macrophages. That's the anti-inflammatory one as well, interleukin 10 and tumor growth factor beta. Okay, we have the neutrophil one as well, and this is the anti one, or Treg. Cool. So T cells, CD8 and CD3. So this is the one that acts on MHC1, because 8 times 1 is 8 and 4 times 2 is 8, so that's TH2 or MHC2. That's what it acts on. And then CD3 is on all of them. Okay, all the T cells have CD3. So it mediates cellular immune response, originate from stem cells in the bone marrow, but mature in the thymus. Differentiate into cytotoxic T cells, express CD8, recognizes MHC1, helper T cells. It expresses CD4, recognizes MHC2, and regulatory T cells. CD28, costimulatory signal, necessary for T cell activation. Right. May circulate. Most circulating lymphocytes are T cells, around 80%. Okay. So CD4, MHC, and regulatory T cells, CD28. So let's just go back and review that bit as well. Right there. Right, so this is the costimulatory response. So when MHC2 and T cell receptors bind, so do B7 and CD28. Right. And that's what they're talking about. Okay, so that's what that is. So T cells expresses CD8 and it recognizes MHC1. So CD8 will go to 1, CD4 will go to 2. That's how they attach. Helper T cells, it expresses CD4 and recognizes MHC2. Right, so CD4 recognizes MHC2 and regulatory T cells. So when you're talking about MHC1 or 2, these are on the antigen presenting cells. Okay, so because this receptor doesn't just bind with anything, right? Not all the cells. It only attaches to the cells that have MHC represented on them. Okay, so these are the T helper cells. That's this thing right here, T helper cell with CD4. It has CD40L or this on it. Cool. Okay, so express that, and regulatory T cells. So that's Tregs right there. It prevents autoimmunity, so destruction of your own body cells. And so CD28 is that thing right there. It's the costimulatory signal. So without this happening, this does not activate. So you won't get step 4, activated T cell action without that. Okay, it's necessary for T cell activation. Most circulating lymphocytes are T cells. So T is for thymus. CD4 helper T cells are the primary target of HIV. And right, so that's how we determine if this person has HIV or not. Okay. If it goes below the level of 500, that's when it starts to be a concern. Plasma cells. Plasma cells are derived from B cells. They produce large amount of antibodies specific to a particular antigen. They have a clock phase chromatin distribution and eccentric nucleus, abundant RER. This is important because of multiple myeloma. So that's how you recognize multiple myeloma. They look like a, abundant cytoplasm with a clock face chromatin. Okay. So multiple myeloma, multiple myeloma. Right. So it produces large amount of antibodies specific to particular antigen, clock face chromatin distribution, and eccentric nucleus, abundant RER or uh, rough endoplasmic reticulum, and well-developed Golgi apparatus, or arrow in A, found in bone marrow and normally do not circulate in peripheral blood. Multiple myeloma is a plasma cell dyscrasia. That's an abnormal or disordered state of body or of a bodily part. Right. Onto physio. Hemoglobin electrophoresis. So you have a negative ion here, cathode here, and positive cathode here, and ion here, right? And when you do electrophoresis, you get negative ones going away from cathode and towards anion, and you have positive ones going away from or staying away from anion and closer to the cathode. So the ones in the middle are going to be the ones that are mostly neutral, right? Okay, so during gel electrophoresis, hemoglobin migrates from negatively charged cation to the positively charged anion. Hemoglobin A, that's the one with alpha 2 and gamma goes, beta stays or becomes beta. So alpha and beta 2s, right? So that's hemoglobin A migrates the farthest. So you have the farthest one from cation. Okay, and so all of these have A in them. So this one has A in it, this one has A in it, this one has A, and this one has two A's because it's thicker. So HbA migrates the farthest, followed by HbF, HbS, and HbC. Okay. This is because the missense mutations in the HbS and HbC replace the glutamic acid, which is negatively charged, with valine, which is neutral, right, and lysine, which is positive. So HbC has a positive, and so that would be the positive, and this is the negative one, right? So A, which is negative, alpha 2, so it travels the furthest, right? And then it also has a C, which is neutral, so that will be in the middle. Okay. So again, let's read that one more time. This is because missense mutation in HbS, that's sickle cell hemoglobin, right? And or hemoglobin with sickle cell trait, right? That's what that is. Because if you have two S's, then that becomes sickle cell disease. Okay, so HbS and this glutamic acid with valine. So valine is for HbS. Okay, so the S is this, which is negatively charged, and then you have lysine, which is positively charged. For HbC, so that's lysine over there, so it's neutral, and we have valine, that's over here. Okay. Respectively, making HbC and HbS more positively charged than HbA. Right, so now the positive ones are going to repel the anion as well, right? That's why they're going this way, and this is going this way. Okay, the neutral one was valine. Hold on, yeah, okay, that's HbC. Yes.
So here we have A, which is normal hemoglobin, beta chains, HbA adult. Yeah, okay. So, wow, this is really like screwing with my head. Okay, A, normal hemoglobin beta chain, so that's HbA adult. And then you have fetal hemoglobin with the gamma, so normal hemoglobin with gamma chain, HbF or fetal. So that's this one. You have HbA and you have F over there. How do we know? Because we know that this is F and this is A. This one. And then we have sickle cell hemoglobin, that's beta chain or HbS. Right. S is for sick, so I'm sick of vanilla. So you can remember that valine is with the sickle. That's the mutation that replaces glutamic acid with valine in HbS. Right. And then you have C, which replaces glutamic with lysine. Hemoglobin C, this is beta chain, so HbC. Okay, so you have AA, it's thicker, so two A's, so that's in normal adult. And then you have AF, which is fetal hemoglobin. Right, so it has A and F, alpha and gamma. Then you have sickle trait, that's E and S, which is glutamic acid replaced by valine. And then you have SS, two valines. And then you have AC, which is hemoglobin C trait with A and C. C is lysine, glutamic acid replaced by lysine, which is positively charged. And then you have CC, which is two lysines. Right. And then you have S and C, that's hemoglobin S and C disease, so that's valine and lysine instead of alpha and beta. Okay, so a fat Santa Claus can't get tired to an eye. That's okay, you don't need to remember that. Coombs test. So what is Coombs test? Also called antiglobin test. It detects the presence of antibodies against circulating RBCs. A direct Coombs test, that's anti-hemoglobin G antibody, right? So Coombs reagent added to patient's RBC. Okay, so this is the patient's RBC right here, and it has anti-RBC antibody on it, and then you add the antibody, right? So that's antibody, so anti-antibody you add to it, and then the anti-antibody attaches to the antibody right here, and it causes agglutination, right? If there's no agglutination, that means there is no anti-RBC antibody on it. Okay. So anti-immunoglobulin antibody, Coombs reagent, that's what that is. The anti-antibody added to patient's RBCs. RBCs agglutinate if RBCs are coated with Ig. It's used for autoimmune hemolytic anemia diagnosis. In indirect Coombs test, what do? We have the patient's serum, so we centrifuge it, and then we take the top part of the centrifuge. That's the serum. You take that. Then we take the blood RBCs from the donor, and then we also add the antibodies to it and see if there's agglutination. If there's agglutination, that means there is anti-donor RBC antibody present. Yeah, so anti-RBC is present on the donor, so anti-donor. In the host there is anti-donor RBCs, antibody present. Okay, and if agglutination doesn't occur, that means it's safe to give.
Alright, so indirect homeostasis is normal RBCs added to patient's serum. Okay, so you take the normal RBCs, add it to the patient's serum. So you centrifuge both of the blood. You take the bottom part from the donor and the top part from the patient. Okay, and then you add the Coombs reagent on it. That's the anti-antibody. If serum has anti-RBC surface immunoglobulins, right, then it's gonna attach to it, right, and then the anti-antibody will attach to those, and then it will cause agglutination when Coombs reagent is added. Used for pre-transfusion testing to make sure that it's not gonna react. Okay, so direct is you check directly. It's only 2 steps. You take the blood, you don't have to centrifuge or anything, you just take it, you add the reagent to it, and you have agglutination or not. And the second one, you do it between both the bloods, right? The serum from the host and serum from our blood from the donor. You add the reagent, and this is indirect way of checking the Coombs reaction. Platelet plug formation, primary hemostasis. So let's see if we need this. Okay. Okay. Injury. So first you have the injury on the endothelium. So we're doing platelet plug formation. Okay, this is the primary hemostasis. Hemostasis is maintaining equilibrium in the blood, of the blood, right? So it prevents leakage. So how does it do that? So if there's injury, that's the trigger point, right? There will be endothelial damage. So this is the endothelium right here, and this is the damage. So endothelial damage, transient vasoconstriction via neural stimulation reflex, and endothelin release from damaged cells. So this is the action of endothelin. You need to know that. Endothelin 1 is a potent endogenous vasoconstrictor, okay, and it's inside of the vessel. So, okay, so there is a neural stimulation reflex and endothelin. So both of these things are going to cause this vasoconstriction. So what do they mean by neural stimulation reflex? That's basically sympathetic, right? So sympathetic signals will come in and act on the alpha receptors, and alpha receptors cause vasoconstriction, correct? And sympathetic is the fight or flight response. So that's what that is. So both of these things will then, and endothelin is released from the stem cell. So both of these will cause vasoconstriction. Okay, that's the first thing that happens after endothelial damage. Then it gets exposed. So exposure. Exposed to what? So 1 Willebrand factor binds to the exposed collagen. Okay, so or you can think of it like the injury is exposed to 1 Willebrand factor. Okay, so that's the purple thing right there. Make that bigger. Okay, so 1 Willebrand factor comes in over there, and it gets exposed to this collagen. So 1 Willebrand factor binds to exposed collagen. 1 Willebrand factor is from Whipple pallid bodies. Okay. That's the Whipple pallid body. So it contains the 1 Willebrand factor. It's in the endothelium, right? And this is the collagen. So it gets exposed to the collagen, parts of endothelial cells, and alpha granules of the platelet. Okay. Then third thing that happens is adhesion.
This is platelets bind to one Willebrand factor via GP1B. Okay, that's GP1B. A deficiency of this is going to cause Bernard-Solier syndrome. Okay, so GP1B receptor at the site of infection, site of injury, only specific. Platelets undergo conformational change. Then you have activation at 4A. So this is how what happens here is ADP binding to PS. Oh, sorry, wait. There's more here. Okay, so after it goes through the conformational change, there's platelet release from ADP platelets release ADP. So that's this thing, ADP right there. I guess receptors and calcium. Okay, so platelets release ADP and calcium. It's necessary for the coagulation cascade and thromboxane 2, A2. ADP helps platelets adhere to endothelium, so that's what it helps. So this is all part of 3. So okay. So the release of ADP and calcium will cause activation. ADP binding to P2Y12 receptor induces, so it binds to this ADP, and then that induces this thing right here, the 4B. Okay, so ADP binding to P2Y12 receptor induces GP2B 3A expression on platelet surface. It leads to rapid irreversible platelet aggregation. Okay. So that's GP2B and 3A over there. It's on both platelets, so this is a platelet, this is a platelet as well, right? We looked at thromboxane 2, it gets released as well as ADP and calcium. Okay, and that causes the binding between the fibrinogens. So aggregation happens when fibrinogen binds GP2B and 3A receptors and links the platelets. Balance between pro-aggregation factors and anti-aggregation factors. So pro-aggregation factors are thromboxane E2. It's released by platelets. There's also when there's decrease in blood flow and increase in platelet aggregation. And anti-aggregation factors are PGI2 and NO. Right, that's vasodilation released by endothelial cells as well. Increase in blood flow or decrease in platelet aggregation. So this balance will lead to temporary plug, stops bleeding, unstable and easily dislodged. Okay, and then this will then activate the coagulation cascade, the secondary hemostasis. Okay. Important thing to know here is what platelets release and how platelet get activated and how aggregation gets activated. Okay. So thrombogenesis. Formation of insoluble fibrin mesh. Aspirin irreversibly inhibits cyclogenase, thereby inhibiting thromboxane E2. Okay, so aspirin inhibits COX and thromboxane E2 is made from arachidonic acid. Okay, so aspirin irreversibly, that's important, irreversibly inhibits cyclooxygenase, thereby inhibiting thromboxane E2 synthesis. You have clopidogrel, prasugrel, and ticagrelor, and ticlodipine inhibit ADP, induce expression on GP2B and 3A. Okay. So this thing right here, clopidogrel, prasugrel, ticagrelor, ticlodipine. Okay, they all inhibit this ADP receptor. Then you have abcizimab, eptifitbetid, and tirofibin. they inhibit GP2B and 3A directly. Okay. So emicizumab, epitafib, and tirofibin. You need to know these drugs, especially the first one. So that for this and clopidogrel for this, and you can probably remember prasugrel too. So those for this, and remember this for this inhibitor. Okay. So what does this do? It inhibits the GP2B and 3A, so it inhibits the aggregation, right? And then you have this as well. So you will be asked to differentiate between. No, actually, okay. So the deficiency of this is called Glasman thrombasthenia. Okay, so you'll be asked to differentiate between Glasman and Bernard's Solier syndrome. Okay. You have ristocetin, which activates 1 Willebrand factor to bind to GP1B. Failure of aggregation with ristocetin assay occurs in 1 Willebrand disease. Okay, and Bernard-Solier syndrome. So that's how you differentiate between it. So this activates 1 Willebrand factor to bind to GP1B, right? So that's 1 Willebrand factor attached to the collagenase and GP1B. So failure of aggregation with ristocetin assay occurs in 1 Willebrand disease and Bernard-Solier syndrome. So we give this, and then if there is no aggregation still happening, then you have deficiency of it or deficiency of 1 Willebrand factor, either or. Okay, and yeah, that's it. Desmopressin is important. Why? Because of we read about it in ADH as well. It's a vasopressin. So desmopressin promotes the release of 1 Willebrand factor. Remember, has V1 and V2 effects. So this would be on the V1, I guess. It promotes the release of 1 Willebrand factor and promotes factor 8 from release from endothelial cells. So 1 Willebrand factor is carried by factor 8 as well, so that's easy to remember. And they both reside in the endothelial cells. Factor 8 is a clotting factor, and desmopressin promotes the release of them. 1 Willebrand factor carries protects factor 8. Volkswagen factories make great cars. Okay. So inside the platelet you have 1 Willebrand and fibrinogen. You have arachidonic acid with COX making thromboxane. It has GP2 and 3A. And with fibrinogen it aggregates, right? Over here we have exposed collagen. So 1 Willebrand factor gets released from the Weber palate body. It contains thromboplastin, tissue plasminogen activator, and PGI2 as well. And this gets released, attaches to collagen. The GP1B receptors get attached to 1 Willebrand factor. Deficiency of this is called Bernard-Solier, and then deficiency of 1 Willebrand is called 1 Willebrand disease. Then you have GP2B and 3 insertions when an ADP receptor get triggered, which is inhibited by clopidogrel, prasugrel, and ticlopidine or ticagrelor. Okay. When these get exposed, so does like this platelet one that gets exposed as well, and then the fibrinogen attaches the two, causing aggregation. This is GP2B and 3A. Again, it's inhibited by abexicimab, epitafib, or tirofibin. Thrombomodulin complex. You have protein C and making activated protein C and vascular endothelial cells. Okay, on to coagulation factors. So coagulation and kinase pathway. PT and PTT. So PT is extrinsic. The way I remember it is you play tennis outside, right? Whoops. Play tennis outside, and then you play table tennis inside, right? So that's your PTT. So PT is play tennis outside, so PT monitors extrinsic and common pathway. Okay. What you need to concern yourself with is the extrinsic one. So reflecting activity of factors 1, 2, 5, 7, and 10. But the important one is 7. That's the one you need to remember. Because the other ones don't really matter, because even this one does common pathway. So when you want to differentiate between the two pathways and or which one is functioning or not functioning, you're going to focus on either factor 7 for PT, or if it's PTT, then you're going to factor you know, the ones that are not in the common pathway, or 7. Okay, so PTT monitors intrinsic and common pathway, reflecting activity of all factors except for 7 and 13. Okay, so these are your intrinsic pathways. That's 10, 9, 12, 9, 10, 12, and that's it. That's wrong. Right. Am I confusing it with the... So intrinsic pathway consists of 1, 2, 9, 10, and 12, and 11, sorry, 9, 10, 11, and 12. Okay. And what about the common pathway? That's 10, 5, 1, and 2. Okay, anyways, moving on. So, yeah. Collagen basement membrane activated platelets, they will convert factor 12 to 12A, which you need to convert 11 to 11A. Okay, and why do you need 11A? To convert the 9 to 9A as well. Okay, and the 9A with the 8A, you need both of these to convert 10 to 10A. Okay, and then you have factor 5 coming in, converted as factor 5A. A just means it's activated. Okay, so 5A converting prothrombin to thrombin, so that's 2 to 2A, and thrombin, that's fibrinogen to fibrin monomers. Okay, this has a lot of other stuff in it, so it gets confusing a little. This is the extrinsic pathway, so it has factor 7 coming in, activated factor 7, then converts 10 to 10A as well. See if there's a better one. Help us. Quizlet. Let me see if it's on. Bing. Alright, this one will work. Okay, so you have you're supposed to get to 10A, right? Somehow. So you have 12 to 12A, 11 to 11A. Then it goes to 9 to 9A, and you need 9A for 10 to 10A. Okay. On this side, you have 7 converting to activated 7 because of injury and the extrinsic pathway. Oh no, where did it go? Okay, and then you need that plus the 10A. So you need activated 7 with activated 9 and activated 8 to convert 10 to 10A. Okay, and then 10A with the 5A converts prothrombin to thrombin. So this is where we need to get to, right? Thrombin, and then we can go from thrombin to this. So let's see if that makes sense. So 10, we have 12A, activated 12, activated 11, activated 9. We need 9 plus 8 and 7A coming in, all three of them, to make 10 to 10A, and then 10A mix with 5A, right? 10A and 5A mix prothrombin to thrombin. Let's just write it out a little. So 12 to 12A, that converts 11 to 11A, that converts 9 to 9A, that converts 10 to 10A. But for this, you also need 7A coming in, and also you need 8A coming in as well, right? And then from the 10A, it converts prothrombin, also known as 2, to thrombin, which is 2A, right? And then you need thrombin to convert fibrinogen into fibrin monomers. Okay, so that's how we reach the fibrin monomer. Oh, I missed this one. So when you get thrombin to thrombin, prothrombin to thrombin, you need, with the 10A, you need 5A coming in as well. Okay, so 5A coming in as well for that, and making thrombin. With the fibrin monomers, it does the aggregation, and then the calcium, remember, it gets released from the macrophages and platelets as well, though. Right. So platelet as well, not macrophages. It releases ADP and calcium. Right. Yeah, right there. So that comes in for this and acts on that. You have 13A making fibrin mash, stabilizing the platelet plug. Okay, and thrombin also causes fibrin stabilizing factor to become activated. 13A. Okay. Then we have all of this other jargon. So let's look at that. We have heparin. That's HMWK. That's heparin molecular weight kinogen up there. Not important. What is important, that is that kallikreinin converts, cleaves this into bradykinin, basically, or makes bradykinin out of this. Either way you remember it. And what is bradykinin known for? To increase vasodilation, increase permeability, and increased pain, and this is the one that leads to angioedema if there's no kallikrein. Right? Also, if there's a C1 esterase inhibitor, that will inhibit the kallikrein. Okay, so you won't have bradykinin. So none of this happens. C1 esterase inhibitor also inhibits this 12A and 11A. Okay, this one does. So you get right here, C1 esterase inhibitor deficiency causes hereditary angioedema. You need to know the presentation for this. Not step 2, step 1. Okay. So it inhibits this and this. Right. So this is the what they're going to talk about, and you gotta remember that ACE is the one that breaks down bradykinin. Okay, so if you have ACE inhibitor, that means you don't have anything that breaks down bradykinin. So then it leads to this. So a 23-year-old woman with a past history of multiple allergies leading to facial swelling, presents with marked difficulty in breathing, abdominal pain. So these two are pretty weak. That could be anything. But this is pretty specific. Swelling of the face and neck. Right? The only other thing that would cause this is a kidney disease. Right? On physical exam or allergy, but we are not talking about allergy here. Why? Because there's abdominal pain involved as well. Okay. Face and neck. On physical exam, her extremities are also noted to be markedly swollen. She is immediately sedated for intubation to maintain patency of airway. Chart review reveals newly started ACE inhibitor. So whenever you have some kind of swelling in the face and ACE inhibitor is talked about, you know that ACE is responsible to break down bradykinin, right? So ACE inhibits bradykinin, or it breaks it down. So when you inhibit ACE, what happens? Bradykinin increases, so you have vasodilation because of that. Increased permeability, so interstitial fluid is gonna now seep out into the interstitial interstitial area out of the capillary, and increased pain. Usually there's coughing involved as well, because bradykinin causes coughing. She is given epinephrine, fluids, and fresh frozen plasma. Okay. So symptoms are these: recurrent episodes of angioedema without urticaria, anaphylaxis, which typically has urticaria, angioedema of the face, oropharynx, extremities, or abdomen. Okay. Yeah. Back to this. Okay. We did that, so we know what C1 esterase does. What is this? It's just factor 8 with 1 milligram factor. Okay. Then you have regulatory anticoagulant proteins. Okay. So all of these are clotting factors or coagulating factors, right? So anything that stops this whole cascade is considered anticoagulant, and that's what protein C and S does, right? It's gonna inhibit factor 8, activated factor 8, and factor 5A, activated factor 5, which is required for alongside 10A to convert prothrombin to thrombin. Okay. Then you have other anticoagulants, which are heparin, low molecular weight heparin, a direct thrombin inhibitor as well. So this one directly inhibits thrombin. So these are the coagulants that we use. Okay, so direct thrombin inhibitor is argatroban, bivalirudin,
and dabigatran. Very important, you know these drugs. Uh, Agratroben, so it bans coagulation, or it bans thrombin, TR for thrombin. Um, believe bivalirudin. Okay, it's rude. I don't know how you gonna figure that one. But again, TR for thrombin again. So dabigatran. So these inhibit thrombin. Okay. Why is that important? Because there are other coagulants that act somewhere else as well. So again, low molecular weight heparin also acts on 10A. Heparin acts on 10A. So you have the first two here, low molecular weight heparin are deltiparin and enoxaparin. If they have parin in their name, you know it's low molecular weight heparin. Okay, or heparin by itself as well. Uh, direct 10A inhibitors, for example, epixaban. Okay, it has XA in the name. So direct 10A inhibitors or epixaban. Okay, and you have fondaparinux. Fondaparinux also inhibits 10A. Okay, so you have hemophilia A, deficiency of factor 8, X-linked recessive. You have hemophilia B. They've recently found a cure for this, so that's pretty cool. But this is due to deficiency of factor 9. Okay, so 8, 9, and 11. Hemophilia C is deficiency of 11. This is autosomal recessive. Note, kallikreinin activates bradykinin. Oh, never mind. Yeah, that makes more sense. So it activates bradykinin. Wait, no. So if this is inhibited in C1 esterase, does that mean you don't have bradykinin? I'm kind of confused on that. And ACE inactivates bradykinin. So kallikreinin activates bradykinin and ACE inactivates bradykinin. Okay. So when you see blue hashes, so right there, C1 esterase inhibitor deficiency. Oh, okay. So that's the one. Okay, so if you don't have this, you will have kallikreinin activating bradykinin, and that's how you end up with hereditary angioedema. Makes more sense now. Cool. So basically, this thing inhibits this, so you don't get bradykinin. But if you have C1 esterase inhibitor deficiency, then you end up with a lot of bradykinin. And on top of that, if you give ACE inhibitor, this bradykinin does not get inactivated, so you'll have like a bradykinin storm happening. This one requires calcium and phospholipids, so all of these places, again, platelets give you that anyways, right? Then pink are the ones that are vitamin K dependent factors, so this is important. So you have 9, 7, 10, 2. So 2, 9, 2, 7, 9, 10, and also CNS. Okay, because that's what we talk about here. So 2, 7, 9, 10, CNS. They all require vitamin K. And greens are the cofactors. So activated 8 is cofactor of 9A. Activated 5A is cofactor of 10A. Okay. Activists but not part of coagulation cascade, so that's for this. Okay. So on this side, we also have, so say you have fibrin MASH, right? How do you get rid of it? You get rid of it with plasmin. So how do you get plasmin? You get it from plasminogen, and then you have tissue plasminogen activator, or TPA, right? So TPA is activated by thrombolytics. Thrombolytics are the ones that lyse the thrombosis. So this is basically what they're talking about. So breaking down the MASH.
alteplase and retaplase, streptokinase, and tenecteplase. Okay, everyone that has plase in it, it activates, and also streptokinase. It activates tissue plasminogen activator. Okay, and then what inhibits this? These are antifibrinolytics, so anti-breaking of fibrin. These are aminocaproic acid and tranexamic acid. Uh, Usually, women take this to deal with bleeding during menses. Right. Why? Because they're antifibrinolytics, so they prevent the breaking of clot and increasing bleeding. So that's what that prevents. Plasmin. Plasmin goes into this, and then you end up with fibrin degradation products, and for example D-dimer, and that's the test we do to check for MI, right? Or any kind of, wait, or am I thinking of stroke? Deep vein thrombosis, and yeah, that's the one. Never mind. Not MI, but for like stroke. So that's the one we check for, because this one can cause stroke, right? Uh, and then you have pulmonary embolism as well. So that's what we use it for. First time to have 8 minutes. Okay. Let's try to get this done. So vitamin K dependent coagulation, procoagulation, warfarin, and then here we have anticoagulation part. Okay. So vitamin K deficiency. So you need vitamin K. Why? Because you oxidize vitamin K and activate to activate the clotting factors. Okay, or synthesis of these factors at least. 2, 7, 9, and 10, protein CNS. Warfarin inhibits vitamin K epoxide 1972. What about 10 though? Okay. Reduce vitamin K active goes to oxidized vitamin K, and then with epoxide reductase, it converts to active again. Warfarin does what? It inhibits these. So when you inhibit this, you don't get vitamin K in active form, and then that will not activate the clotting factors and the anti-clotting factor as well. You need gamma glutamyl carboxylase, which is vitamin K dependent, right? So vitamin K, with the help of gamma glutamyl carboxylase activation, creates mature carboxylated clotting factors of 2, 7, 9, 10, and CNS. Okay. So now we have clotting factors and anticoagulants. Okay. Warfarin inhibits vitamin K epoxide reductase. Vitamin K administration can potentially reverse inhibitory effects of warfarin on clotting factor synthesis, which is delayed action. Okay, so when you give vitamin K, it can reverse inhibitory effect for warfarin. It's kind of competitive reaction right there. It is delayed though. Also, if you give fresh frozen plasma or PCC administration, it reverses action of warfarin immediately and can be given with vitamin K in case of severe bleeding. This is important. This is an immediate action, right? So they'll ask you, there's a reaction to warfarin, and what is the antidote for this, or how are you going to prevent this action of this?
The options will have vitamin K, FPP, and some other stuff. So most likely you'll give vitamin K and you'll mistake it because you're looking for something immediate, right? This is good for delayed action, but not for immediate. This is what you give for immediate action. So it's FFP or PCC to reverse the warfarin action, right? In case of severe bleeding. Neonates lack enteric bacteria, which produce vitamin K. Okay, so that's why when you have neonates, the first thing you give them is vitamin K, because they don't have that to prevent internal bleeding. Early administration of vitamin K overcomes neonatal deficiency or coagulopathy. Factor 7 has the shortest half life, and factor 2 has the longest half life. Okay. Antithrombin inhibits thrombin, so that's factor 2A, and factors 8, 9, factors 7, 9, 10, and 11 and 12A. Heparin enhances the activity of antithrombin, and principal targets of antithrombin are thrombin and factor 10A. We looked at those, right? So that's thrombin and 10A right there. So anticoagulants act over there and here. Then factor 5 lane mutation produces factor 5 resistant to inhibition by activated protein C. Okay. And TPA is used clinically as a thrombolytic. We check that out over here, right? TPA. So you have that clotting factor converts fibrinogen to fibrin, and also thrombin, which is 2A, right? Also does that. So when you have thrombin and it has antithrombin on it, the heparin-like molecule will attach to it and causes antithrombin activity. Okay, so it inhibits thrombin and all of these as well. And then you have protein C pathway here, and that is also antithrombin, right? So it attaches directly onto the thrombin. That's what it says. So the C comes right here and it inhibits this, right? So it doesn't allow thrombin action. So thrombin thrombomodulin complex in endothelial cells, protein C and activated protein C. It requires protein S. So with C and S, it requires that. So it cleaves and inactivates 5A and 8A. Okay. Let's take a break and we'll come back and continue talking.
To remember here is that one, that warfarin acts on epoxide reductase and not gamma glutamate carboxylase or vitamin K. Second thing you need to know is that because the factor 2 has a half-life that is longer than most of the things that are here, that so when you give warfarin and inhibits vitamin K, it converts hold on, I'm gonna mute you. Okay. So when warfarin converts inhibits the conversion of vitamin K, what it does is it stops making more of these factors, right? And the shortest one is 7, so that's the first one to go. But then these go before this does. Okay, so since this has the longest half-life, this one is gonna have coagulating factors action actually. So it's gonna cause coagulation before, because now the anticoagulation factor, the one that were causing regulation of coagulation, right? So protein C and S, anticoagulation. These factors die out before the coagulation factor do. So that's why when you give warfarin, chances are you'll go into hypercoagulation state and have necrosis and stuff happening. So to prevent that, we do what is called bridging. And basically what bridging is, we give heparin along with warfarin. Why? Because heparin has the faster action on anticoagulation, faster anticoagulation action than warfarin.
So in the beginning, the heparin will take care of the longer half life of this, and maybe I think 11 as well. Uh, until warfarin can kick in and do its anticoagulation factors action, anticoagulation action. Okay. Another thing you need to know is what factor 5 lane mutation is. It produces a factor 5 resistant to inhibition of activated protein C. Again, protein C is anticoagulating factor. So when you have factor V that does not listen to anticoagulation, you will have hypercoagulable coagulable state, right? So you're gonna make a lot more clots, and then you know that's not good. So factor 5, this, so anticoagulation, this acts on this too, and it prevents overactivity of this. So when you have mutation in activated factor 5, it's not going to listen to anticoagulating factors like C and S. Well, C mostly, because S is just required to function, C to function, right? So yeah, that's what mutation of factor 5 is going to do. So factor 5 lane mutation produces a factor 5 resistant to inhibition by activated protein C. That's mostly what you need to know. You definitely need to know everything on this page. Okay, on to pathology. RBC morphology, acanthocytes. These are the spur cells, and wherever you see this, you can do differential for liver disease or A beta lipoproteinemia or vitamin E deficiency. This one, remember, this is the one that transports fat from the intestine, so you need to know what it looks like. When you have A beta lipoproteinemia, it does not transport fat from the intestinal brush border, so you'll have accumulation of fat on the intestinal brush border, and that's what that looks like. Okay, so that's fat. This is the crypt, and yeah. Okay, vitamin E deficiency and liver disease. These are projection of varying sizes of irregular intervals. Acanthocytes are asymmetric. Okay, you need to know what that looks like when it comes, and don't confuse it with other cells. So that's what it looks like. Okay. All these arrows. Don't confuse it with Burr cells. These are echinocytes. Let's see what that looks like. Okay. Spur cell, Burr cell. Burr looks like birds. If you remember what those, if you don't know what those are, it's these things. These are called burrs. If you go hiking or something, it's usually found there. When you come out, you'll have these stuck to your laces or pants or something like that. Right? So those are burr cells, and the spurs are asymmetric. Okay. Either ways, even if you confuse it and it's liver disease, you'll be okay, because it happens in liver disease as well. End-stage renal disease or pyruvate kinase deficiency as well. No, it's smaller and more uniform projections than acanthocytes. Okay, it's smaller and more projections. It's all over the place, right? All over the cell. Whereas the spur, it was only on some parts of the cell, right? That, and here you have bird that actually looks like birds. Burr cell, acanthocyte. That's a burr cell, that's a acanthocyte. Okay, then you have decrocytes or teardrop cells. This is very important because this is the one that causes happens in myelofibrosis. Okay, what is myelofibrosis? It's the, let's see what this says. Uncommon type of bone marrow cancer that disrupts your body's normal production of blood cells. Okay.
bigger photo for that. Nope, I guess not. So, teardrop cells. Do we see any? I guess that little thing, but no. Ah, right here. So this is a teardrop. That's a teardrop. That's a teardrop. Right. So teardrop cells, or also known as dendrocytes, they happen in bone marrow infiltration. For example, myelofibrosis. So RBCs shed a tear because it's mechanically squeezed out of its home in bone marrow, and that works. And then you have schistocytes, or also known as a helmet cell, because they look like helmets. Okay. Uh, Mahas, for example, DIC. That's macrocytic autoimmune hemolytic anemia. I think. Let's see. Microangiopathic hemolytic anemia. That's what it means. We'll learn about this as well, but it's basically something to do with vessels, I think. Okay, so DIC, TDP, HUS, and HELP syndrome. Mechanical hemolysis. This is the important one. Okay, since it's mechanical hemolysis, for example, heart valve prosthesis. You can think of, you need a hard hat when you go into like factories and stuff. So mechanical hemolysis, you need helmet cell or schistocytes. Okay, so these are fragmented RBCs. Then you have degmocytes or bite cells. We already know about that one. G6PD deficiency, and due to removal of Heinz body by splenic macrophages, they dig them out of bite them of RBCs. Very important. This is how you differentiate between this and some other things. That's what that looks like. And we need to see helmet cells as well. That would be the helmet cell there. This is a helmet cell as well. Okay, that's a helmet cell. That's a helmet cell. Okay, right there, right there, right there, there. They look like helmets, right? So helmet cell, and if you see helmet cell, it's a Maha. So bite cells are called degmocytes because they dig them out. Dig what out? Heinz bodies. Then you have elliptocytes. These are from hereditary elliptocytosis. Easy to remember. Caused by mutation in genes encoding RBC membrane proteins, for example, spectrin. Okay. Then you have spherocytes. This is an important one. Okay, they're smaller than RBCs, and they don't have the central palar region. So these things are spherocytes. This is like a normal RBC right there, right? And you can see compared to that, it's a small one. Okay, spherocyte, normal RBC, smaller than normal RBC. It's small and doesn't have the central palar. Okay, so it's spherocytes, so associated with hereditary spherocytosis and autoimmune hemolytic anemia. Okay, AIHA. It's small spherical cells without central palar, there's decrease in surface area to volume ratio. Okay. Then you have ovelocytes. These are from megaloblastic anemia. Also hypersegmented polymorphonuclear neutrophils. Polymorphonutrophils. You have target cells. Easy to cite them. If you see this, something is wrong with the spleen. That's what it means. Okay? Because they target the spleen. I remember it that way. So HBC disease, asplenia, liver disease, or thalassemia. Okay, halt. Set the hunter to the target. It increases surface area to volume ratio. So basically, what we gain from that is that if the cell, this is a normal cell, not that, but okay, so that's a normal cell. That's that. Okay. And if it gets smaller, that means there's a decrease in surface area to volume ratio, right? And since it's smaller than an RBC, and if it's bigger than RBC, or why do we know it's bigger? Because when it was like this, it had a central pillar, but now the central pillar has another, redness in the middle of the central pillar as well. So it's sort of bigger than that. That's how I remember it. So increase in surface area to volume ratio. And majority of the time you see it in asplenia, so that's how you remember that one. Because for liver disease, they give you other stuff too, like these two right here. For thalassemia, they'll talk about it, but they don't show you a picture of it. But if they do, then you need to know that it's target cell. And HBC disease, they don't show you a picture for that. They talk about electrophoresis instead. So asplenia is where you see the target cells. For sickle cells, you need to know what that looks like. It's in obviously sickle cell anemia. Sickling occurs with low O2 conditions, for example, high altitude and acidosis. Okay. So that is sickling. Where? This thing right here. That. Or that. Or that. Right. That or that. It's named after sickle, and this is what a sickle is, right? So the cells that look like that, and you see target cells here, right? Why? Because what does sickle cell do? It causes sequestration in the spleen, so pathologic asplenia, right? Oops. To this. So what does this mean, or when does it happen? It can happen in sickle cell disease or with low O2 conditions, for example high altitude or even acidosis. Okay. Now we're going to talk about RBC inclusions, so things inside or around it. RBC. So bone marrow, if you find iron granules in bone marrow, this is what it's going to look like. Very important, because this is how you diagnose these sideroblastic anemia, or for example lead poisoning, right? So they might say there was a kid in the peripheral smear. They found these cells, and he belongs to low income society or something like that, like poverty stricken society. And back then the paint used to be lead paint, so this kid has lead poisoning. That's how you figure that out. And questions done like that. So this is what it looks like. Let's look at a few more pictures for that. Okay. Okay. Okay, so that thing right there, that over there, that over there, that over there, and that over there. Okay, so it's perinuclear mitochondria with excess iron, forming rings and ringed sideroblasts. It requires Persian blue stain to be visualized. Okay, it requires Persian blue stain. There was another place we looked at that, right? Whoops. Haven't read that yet. Yeah, right here. So hemochromatosis, that's where we came across Persian blue stain. So Persian blue stain for hemochromatosis and for sideroblastic anemia. So very important. Also, it's associated with this, right? So we'll read about that too. They recently started testing you on this as well. So you gotta remember, chronic alcohol overuse also causes iron granules accumulation, or in the mitochondria. Okay, peripheral smears, Hal-Jolly bodies are those. They're functional hyposplenia, for example, sickle cell disease. So asplenia, basophilic nuclear remnant. It does not contain iron. Okay, so it's basically just nucleus remnant. Remember how RBCs don't have nucleus in them, so when it goes through the spleen, it filters that out, so it takes out the Hal-Jolly bodies. But now if you have those ending up in the bloodstream and in your peripheral smear, that means the spleen is not doing its job, right? So that means there's either a functional hyposplenia, or there's no spleen, or there's some kind of sequestration causing hyposplenia. Okay, so basophilic nuclear remnants and does not contain iron, usually removed by splenic macrophages. Right? So if you have them, that means the spleen is not functionally doing its job. What do they look like? That. Cool. Then you have basophilic stippling. These are seen in sideroblastic anemia and thalassemia. Sideroblastic anemia and thalassemia. These are basophilic ribosomal precipitates. So this time, instead of nuclear, it's about the ribosomes. Okay, like that. It looks like granules, doesn't it? Granules. All that. Cool. Again, does not contain iron. Neither does this. Then you have Peppenheimer bodies, sideroblastic anemia, Basophilic granules. This one contains iron. Okay, they're clumped together instead of how we saw the other ones. Okay, so clumped together, and there are always going to be two or more. Whereas Haljali was just one nucleus, right? So, like that, they're clumped together. And if they're spread apart diffusely, it's going to be ribosome. That does not contain iron. Neither do this. But this one does contain iron. It's basophilic granule. Okay. And last one, Heinz body. It's in G6PD. Remember, this is how you get bite cell when this gets bitten or digged out because of why dig? It's called dig because of digmocytes. Okay, so they eat it and then that causes bite cells. So it's G6PD deficiency. It's denatured and precipitated hemoglobin. It contains iron as well. Phagocytic removal of Heinz body leads to bite cells. It requires supravital stain, for example, crystal violet, to be visualized. Okay. Anemias. This is the most important thing you need to know about anemias, because this is basically how you can answer all the questions. When it's dealing with anemia, they will give you MCV levels, and then you can just differentiate from there. Okay, so say you have an MCV that's less than 80, so say 70 or something, right? So it's going to be microcytic. Between 80 to 100, that's normocytic, and more than 100 is going to be your megaloblastic or macrocytic. Okay, so for microcytic, you remember TAO, T for thalassemia, A for anemia of chronic disease, I for iron deficiency or late, and L is for lead poisoning. Okay, so hemoglobin affected, defective globin chain. Okay, so beta or alpha chains, alpha globin or beta globin, right? Because you need two alphas and two betas to make adult hemoglobin, remember? So a problem in that will cause thalassemia, and thalassemia leads to microcytic anemia. If there's defect in heme synthesis, right? Let's look at heme synthesis real quick. Okay, so that's heme synthesis. Right, glycine plus succinyl coenzyme A with ALA, prophylinogen, and hydro whatever this is, and this. Important thing to remember for this is that this bit is in the mitochondria. Okay, so and so is this. So in first step, mitochondria, and final 3 steps. So these 3 steps and this step is in the mitochondria. Okay. Then ALA dehydratase is inhibited by lead. Okay. And so is ferrochelatase. It's inhibited by lead. RBC lose mitochondria near the end of life. So 120 days or 4 months. Okay, so RBC does have mitochondria, but it loses it at near the end of its life. Okay, what is that? No heme near, so production. Okay, so there's no heme production near the end. Okay, we'll talk about that later in patho. And treatment is glucose downregulates CYP 450 LS synthesis. So anywhere defective heme synthesis, so anemia of chronic disease, iron deficiency, or lead poisoning. Okay, so tail. Then you have normocytic, MCV 80 to 100, non-hemolytic and hemolytic. So they'll give you if the
if they're low immature cells, so ratio is lower compared to mature cells, or they'll tell you that the ratio of immature cell is higher than the mature RBCs, right? So that's what reticulocyte count means. So if they tell you that it's low reticulo or high reticulo, this is how you differentiate between normocytic. So they give you, or they'll just tell you it's normocytic anemia, and then you have to figure out if it's hemolytic or non-hemolytic. So for non-hemolytic, which is low reticulocyte index, has a low reticulocyte index. It's in iron deficiency, early stages, anemia of chronic disease again, aplastic anemia. Very easy to figure out if it's aplastic if they give you a slide because it looks like fat cells in bone marrow. Chronic kidney disease. Okay, so this gets what does this do? It sequesters iron, right? And that's why you see it here as well. So it sequesters iron, causing non-hemolytic anemia. Aplastic, again, same thing. It doesn't make any new RBCs. Anemia of chronic disease. Okay, that's the one I was talking about. Sorry. So in chronic kidney disease, it's just that there's no EPO production. So erythropoietin comes from the paraventricular capillaries around the tubules, or peritubular capillaries. I think that's how they call it. Okay, and iron deficiency is early. What about hemolytic? That means it does make new cells, and a lot of them compared to the mature ones. That means the mature ones are dying out. And this one is trying to keep up with by replacing them. So it could be intrinsic or extrinsic factors, right? So intrinsic factors are factors affecting the cells from the inside, right? So one thing is membrane defects, another is enzyme deficiency, and you can have also hemoglobinopathies. Okay, so these are all the factors that are related to the inside of the cells. So membrane defects, it can affect from hereditary spherocytosis or paroxysmal nocturnal hemoglobinuria, enzyme deficiencies, G6PD deficiency or pyruvate kinase deficiency, or you can have hemoglobinopathies, sickle cell anemia, and HPC disease. Extrinsic causes are autoimmune, microangiopathic, macroangiopathic, and infections. Okay, so these are all the causes outside of the cell. So it could be because of autoimmune hemolytic anemia. It could be because the vessels it's going through. I think that's what that is. Let me check. Microvascular disease and disease of the microvessels, small blood vessels in the microcirculation. It can be contrasted. Okay, yeah. So it's intravascular hemolysis caused by excessive shear and turbulence in the circulation. So that was micro, and then there's macro. RBCs are damaged in systemic circulation due to force delivered in the large caliber vessels. So macro is just big vessels, and micro is small vessels. Okay, and then you have infections affecting the thing. Then you have macrocytic anemia, right? So that's MCV more than 100. It will, and subcategories are megaloblastic and non-megaloblastic. Megaloblastic is the DNA is affected, right? And the formation or synthesis of DNA, and you require vitamin B12 and folate for that. Okay, remember that whole thing. And purine and pyrimidine, this area right here, you require that to make DNA, and this thing requires B12 and dihydrofolate reductase, and THF, trihydrofolate, right? Or tetrahydrofolate. So it requires that, and you can end up with orotic aciduria. That's from this thing, UMP synthase deficiency. Right, it says UMP synthase. It's impaired in orotic aciduria. Okay. Defective DNA repair. That's Fanconi anemia. Okay. What is this? We'll read about it in renal, but real quick, let's just check that out too. It's a rare disease passed down in families. It results in decreased production of all types of blood cells. Oh wait, I was thinking of something else when I said renal. Is that called Fanconi syndrome? Okay, I confused the two. So Fanconi syndrome is in renal, and Fanconi anemia is here. Okay, so decreased production of all types of blood cells. Cool. So defective DNA repair. So that's Fanconi. And then you have non-megaloblastic anemia. So if you have macrocytic, however, they're not megaloblastic, it's going to be this diamond black fan anemia. So basically they'll tell you if there's PMNs. If there are PMNs, then it's going to be one of these. If there are no PMNs but the MCV is more, then it's going to be non-megaloblastic. Okay, so diamond black fan anemia, liver disease, and chronic alcohol overuse. Remember this one because that's special to this. And then you have liver disease, that's okay. And then you have black fan diamond anemia. Need to know about what that is. It primarily affects the bone marrow. People with this condition have physical something. That's what they have. They look like. Right? They have short stature and all that stuff. We'll read about that too. Okay, so reticulocyte production index. You need to know this because this is how to differentiate. What do you differentiate? It'll come to me. Also called corrected reticulocyte count. Right, so if there's a decrease in blood volume or something like that, how do you differentiate that it's decrease in blood volume, or is it that you have low reticulocyte count, or like anemia, right? So this is how you figure it out. It's also called corrected reticulocyte count. It's used to correct falsely elevated reticulocyte count in anemias. Okay. So how do you get falsely elevated reticulocyte in anemia? It could be due to dehydration or loss of, mostly like that, dehydration, right? Or why? Because you have water again, or like serum, right? That's serum, and then you have red cells here. Okay. So when compared to this, when the water is decreased, right, now it seems like that there is more reticulocyte compared to when the water was, or the serum was this much, right? So when you decrease the serum and this stays the same, you can't really figure out if it's anemia or it's something else, right? So then you gotta do this formula to do a corrected reticulocyte count. Okay, so it's used to correct falsely elevated reticulocyte count in anemia, measure appropriate bone marrow response to anemic conditions, effective erythropoiesis. Okay, so that's how you know if the bone marrow is keeping up with the demand or not. High reticulocyte production index, more than 3, indicates compensatory RBC productions. Low reticulocyte production index, which is less than 2, indicates inadequate response to correct anemia. So it's calculated by this formula.
they'll give you this, and they'll give you either this or they might just give you this, and then they give you, and you know what this should be. So then, or some one or the other, somehow they'll give you all the information, and then they'll just ask one of those things. Okay, you can figure it out from there. Normal hematocrit is like 15, I think. Okay, never mind. So normal hematocrit for men range from 41 to 50, and for women it's 36 to 48. Okay, so if it's less than that, that number will go on top, and then you put 50 here, and then you divide it, and then you divide that by the maturation time, and then you multiply it by reticulocyte count, or percentage reticulocyte, right? It's percentage that they'll give, so you have to put it in decimal form. Okay. Microcytic hypochromic anemias. So MCV less than 80. So this is your tail. Right. So iron deficiency and anemia. Decrease in iron due to chronic bleeding, for example, GI loss or menorrhagia. Malnutrition, absorption disorder, GI surgery, for example, gastrectomy, or increase in demand, for example, pregnancy. They all lead to decrease in final step and heme synthesis. This is the final step. Right. Heme synthesis. Okay. Labs, what will you see? You'll see that iron is decreased, and the total iron binding capacity is increased because you have whatever contains iron normally. This is iron. Since iron is not available anymore to be here, you take that out, so this capacity is there, so it's increased. Decrease in ferritin. So ferritin is the form in which iron is transferred, I think. Let me just make sure. Protein inside your cell that stores iron. Okay, I was thinking of transferritin. Okay, so this is the amount that's stored. So ferritin is the storage of iron. So since there's decrease in iron, all the storage is going to be used up. So now there's the storage is running empty as well. Increase in free erythrocyte protoporphyrin. Okay. Increase in RDW. What is RDW? Oh, okay. Red cell distribution. And decrease in reticulocyte index. Okay, that's this one right there. Microcytosis and hypochromasia, so increase in central pallor. You get that. So it's going to be microcytic and increase in the pallor. Symptoms. Why? Because what gives the red color? It's iron or hemoglobin, and then since it's anemia, you're decreasing hemoglobin as well because of decrease in iron, because heme is not being made anymore. Okay. Symptoms: fatigue, conjunctival pallor. That's B. There. And pica. This is important too. They tell you that this person is craving wall chips or ice or something like that, and that is pica syndrome. So pica is persistent craving and compulsive eating of non-food substance, right? And you can also have spoon nails or koilonychia. May manifest as glossitis, cheilosis, Plummer-Vinson disease, that's the triad of iron deficiency anemia, esophageal webs, and dysphagia. Right. typical. MCV less than 80. They'll give you other stuff for iron deficiency. Mostly they'll show you something like this photo, and then you can figure it out from that. Alpha thalassemia and beta thalassemia. Remember, if normal hemoglobin has A2, so 2 A's, and beta 2, right? Normal adult hemoglobin. Okay, so 2 A's and 2 B's is what you're supposed to have, but instead of that, if that changes, you'll have either of these thalassemias. So, okay. Alpha globin chain deletion on chromosomal 16, important. Decrease in alpha globin synthesis may have a cis deletion, that's deletion occur on same chromosome, or trans deletion, that's deletions occur on separate chromosomes. Okay. A normal is AAAA, often increase in RBC count, in contrast to iron deficiency anemia, where you have decrease in RBCs, but here you have increase in RBCs. Okay, so number of alpha globin genes deleted, and disease and clinical outcome. So you can have AA and AA, right? Or you can have, like this or this or this. So if you have 3 A's, right, only one, then that's called thalassemia minor, or minima, sorry. So only one is deleted. That's called minima. No anemia, silent carrier. Okay, and 2, if you have A blank, that's trans, because trans is on both, and if it's deletion on the same side, it's going to be cis, right? So that is also alpha thalassemia minor. Mild microcytic hypochromic anemia. Cis deletion may worsen with outcome for the carrier's offspring. Right? This can be dangerous for the offspring though. And then 3, because if it's coming from mother and the father, and say the father also has this or this, that turns dangerous for the thing, right? Because as long as you have one, it's going to function because of the 2-hit hypothesis kind of thing. Okay, but if the mother one has blanks and then father one is like 1 blank and 1 alpha, that's bad for the offspring. Okay, so 3, hemoglobin H disease, HBH, excess beta globin forms B4. Okay. Moderate to severe microcytic hypochromic anemia. And then there's the 4th kind, that's called the Bart's disease, or hemoglobin Bart's disease. No alpha globin, excess gamma globin forms gamma 4. Hydra fetalis, incompatible for life. Okay. This is the one they usually test you on, beta thalassemia. There's a point mutation in the splice site, or the Kozak consensus sequence promoter on chromosome 11, so it leads to a decrease in beta globin synthesis, or beta positive, or absent in beta globin synthesis, that's BO or beta 0. Increased prevalence in people of Mediterranean descent. So you have number of beta globin genes mutated, disease, and clinical outcome. Okay, here you have both. So this is decrease in beta globin synthesis. Okay, so this is on chromosome 11, this is on 16. 11, right? So if there's decrease in the globin synthesis, that's B plus, right? So you have a normal one and B plus, or normal one and one that does not make any gene. Then the disease is beta thalassemia minor. Clinical outcome is mild microcytic anemia. All of these are going to be microcytic anemia, so because it's MCV less than 80.
And then you have increase in hemoglobin A2. Okay. Then number 2, both decreased, or one is decreased and one doesn't even make it. That kind of gene, then that is thalassemia intermedia, sorry, and variable anemia. Outcome is variable anemia, ranging from mild asymptomatic to severe transfusion dependent one. Okay, and then you have one that does not make it. This is called the Cooley anemia, beta thalassemia major. Severe microcytic anemia with target cells and increase in anisopoikilocytosis that's varying size and shape, requiring blood transfusion, increase in risk of secondary hemochromatosis, marrow expansion. It's called the crew cut on skull X-ray, leading to skeletal deformities, extramedullary hematopoiesis, and you get HSM. What's HSM? Hematology. Okay. Wow. So annoying. Increased risk of parvo B19 induced aplastic crisis. Okay. Important to know. They usually say that the patient had infection a few days ago, and then the mother also had the infection or something like that, and then the patient started having this aplastic crisis or something like that. This increase in HbF and HbA2 becomes symptomatic after 6 months when HbF or fetal hemoglobin declines, because fetal hemoglobin is protective. So chronic hemolysis leads to pigmented gallstones because of bilirubin. Okay. Important thing, I already talked about that, so remember that now. The crew cut on X-ray, it's easy to point out because it looks like haircut. Okay. So that's what it looks like. Left. Okay. And here you have one that's decreases the synthesis of beta and HBS, or one that doesn't make beta and HBS as well. So this is sickle cell beta thalassemia. This is mild to moderate sickle cell disease, depending on whether there is decrease in beta or HBS, or absent and HBS, beta globin synthesis. Normally they'll give you the electrophoresis for these, and or they'll just ask you what it can be if this person has this, and one that's where the gene that makes beta chain is improperly been folded, or something like that. Why do you get this? You get that because of marrow expansion and extramedullary hematopoiesis as well. Okay. So what happens is normally it happens in bone marrow, right? But since there are skeletal deformities, it starts happening in like other places like the liver or the spleen or the sternum, I think, as well. So those are the site for hepatosplenomegaly. Okay, and I don't remember right now why you get the crew cut image. They'll come to me. Okay. Microcytic. Let's finish microcytic and then we'll talk about macro in the next one. Okay, so microcytic hypochromic anemia continued. Lead poisoning. Lead
inhibits ferrochelatase and HLA dehydratase, right? So HLA dehydratase and ferrochelatase get inhibited. Okay, decrease in heme synthesis and increase in RBC protoporphyrin. Why protoporphyrin? Because if it can't go through heme, you have buildup of this. Okay. Also inhibits rRNA degradation, ribosomal RNA degradation. RBCs retain aggregates of rRNA, so you get basophilic stippling. Remember, that's the one with the ribosomes, I think. No. Yeah, ribosomes. Okay. Okay. Symptoms of lead poisoning are lead lines on gingiva. They're usually explained as blue lines or blue pigmentation on the gums or something like that. And on metaphysis of long bones on X-ray. Right. You should know what these look like in a picture if they're given. Okay. So that kind of bluish line, right? Or something like that, the blue line right there. Okay. Lead lines on gingiva and on metaphysis of long bones. So like that. Burn lines on X-ray. Not burn line, but just lines. Encephalopathy and erythrocyte basophilic stippling, abdominal colic and sideroblastic anemia, drops, wrist and foot drops. Treatment is, so this is important, this is going to be in the question step right here, and maybe this. And they'll tell you that the patient comes from a home that was built in 19 something, and back then they used lead paint, so there's lead poisoning and that's why he's suffering from seizures and all that stuff, or something like that. He's not paying attention or has a hard time listening to commands or something like that. Okay, treatment: chelation with succimer, EDTA, and dimercaprol. Right. This is also used for the copper, I think, along with lead. Exposure risk includes in old houses built before 1978. Okay, there it is. With chipped paint, so children, and workplace adults. Workplace for adults. Sideroblastic anemia causes genetic, for example, X-linked defect in ALA synthase anemia. Again, that ALA synthase right here. Okay, so X-linked defect in ALA synthase gene, acquired myeloblastic, could be myelodysplastic syndrome, and reversible alcohol is most common. Also, lead poisoning, vitamin B6 deficiency, copper deficiency, and drugs. For example, isoniazid or linezolid. This is a big gun antibiotic, right? Lab findings: increase in iron, normal, or decrease in. Okay, so you'll have increase in iron because it's not being used up to make heme, right? So normal or decreased total iron binding capacity, because it's going to be all used up, and the stores with iron is going to be increased as well, so ferritin is increased. Ringed sideroblasts with iron lane or Persian blue stained mitochondria, that's the fancy one, right? This one, or that thing right there. Peripheral blood smear, basophilic stippling on RBCs. Some acquired variants may be normocytic or microcytic. Treatment is pyridoxine B6 cofactor for ELE synthase. That's the treatment. And then interpretation of iron studies. Interpretation of iron studies. We are looking at iron deficiency, chronic disease, hemochromatosis, and pregnancy or OCPUs. We have serum iron. In iron deficiency, it's going to be decreased, right?
Transferrin or total iron binding capacity is going to increase, right? Because we don't have iron, so total iron binding capacity is going to increase. The storage is going to be empty because it's iron deficiency, so there's no iron, it's ran out. And transferrin saturation, that's serum iron, that's this, over total iron binding capacity, right? So there's a bigger number at the bottom and small number at the top, so the ratio is going to be decreased. Chronic disease, so anemia of chronic disease, serum iron is going to be decreased. Transferrin or total iron binding capacity. In chronic disease, our body sequesters iron, and it reduces the transfer of it, so it's going to be decreased. Okay, this is evolutionary reasoning. Pathogens are circulating iron to thrive, so the body has adapted a system in which iron is stored within the cells of the body and prevents pathogens from acquiring circulating iron. The iron storage, ferritin, is going to be increased, and transferrin saturation, decrease in here and decrease in this, so it's going to be the same, so no change, or decreased. Okay, why decrease? Because it could be that there's a little bit of transferrin left, or total iron binding capacity, compared to the amount of serum. Hemochromatosis, serum iron is increased because that's what hemochromatosis is. Then transferrin or total iron binding capacity, that's decreased because all of them are taken up by iron. Ferritin is going to be increased because there's an increased amount of serum iron. And now you have bigger number on top and small number at bottom, so it's going to increase. Pregnancy or OCPUs, serum iron is going to decrease because the demand for iron increases, so I guess it decreases, or no change. Okay. Transferrin or total iron binding capacity, if there's no change in this, there's not going to be a change in this. Okay, there's increase in that. Okay. And then ferritin, I have no idea, but since serum iron is not changed, I'm guessing the ferritin is going to be used up because demand is high, right? So it's going to be okay, no change. And then no change, no, and increase at the bottom, so decrease of this. Okay, at least I got one right. Okay, so no change in serum iron and no change in ferritin in pregnancy or OCPs, but increase in total iron binding capacity. And okay, so transferrin transports iron in blood. Then you have TIBC. This indirectly measures transferrin. Then ferritin is primary iron storage protein of body. And okay. Macrocytic anemias, that's MCV more than 100. Okay, so megaloblastic anemia, impaired DNA synthesis, it leads to maturation of nucleus and of precursor cells in bone marrow, delayed relative to maturation of cytoplasm, causes vitamin B12 deficiency, folate deficiency, or medication, for example, hydroxyurea, phentoin, methotrexate, or sulfa drugs. All of these cause megaloblastic anemia. Finding is RBC macrocytosis, hypersegmented neutrophils, and glossitis. Folate deficiency causes are malnutrition, for example, chronic alcohol overuse, malabsorption, drugs, for example, methotrexate, trimethorphan, phenytoin. Remember the drugs that inhibit purine synthesis.
or pyrimidine synthesis. So these drugs. Okay, so pyrimethylene is not in here, but that too. Okay, increase. So what do you have? You have increase in homocysteine, normal methylmalonic acid. No neurologic symptoms versus B12, right? So we did that as well. So this was the difference between them. Right, so B12 has hyperpigmented PMNs, right? And so does vitamin B9, but neurologic symptoms is only on vitamin B12 and vitamin E. You get megaloblastic anemias, right, in both B12 and B9. Homocysteine increases in here, and methylmalonic acid increases for this, but it's normal here, right? And for this one, you get hemolytic anemia, not megaloblastic. So what does that mean about that? So we look at amino acid metabolism. Okay, so homocysteine right here. You require B12, so in B12 deficiency, homocysteine won't convert to methionine, right? So that's why there's a deficiency over there. Then you get homocysteine buildup. Okay. And for B9, it was skipping on the reason for that one. Okay, so this one right here, you have methionine becoming methionine from homocysteine, right? And there's a folate cycle. Right. So if you right. So this is why. So if you have folate deficiency, it's not gonna convert to 5-methyl trihydrofolate, and that's a coenzyme, I guess, and you need that along with methionine synthase to make methionine. Okay. So if you don't have that, it's not gonna make methionine. So you will have buildup of homocysteine, and that's why you need folate. And so in folate deficiency you'll have that. Okay, so increase in homocysteine, normal methylmalonic acid. Okay, so that's back to this. So methylmalonic acid is right there. So if it converts into this, that will convert into this cysteine and keep going and keep going. Okay, you'll have buildup of this in B12 deficiency because you need B12 to convert from methylmalonyl coenzyme A to succinyl coenzyme A. However, if it's a deficiency of folate, you won't have a buildup of this because you still have B12 going into succinyl coenzyme A into the citric cycle. Vitamin B12 cobalamin deficiency, it causes pernicious anemia, malabsorption, for example Crohn's disease, right? Because Crohn's disease it's going to affect the lining on the ileum, and that's where vitamin B12 with intrinsic factor gets absorbed. So if you have Crohn's disease, that's not going to happen, and you end up with vitamin B12 deficiency there. Pancreatic insufficiency, gastrectomy, insufficient intake, for example veganism, diphyllobothrium latum or fish tapeworm. Increase in homocysteine, increase in methylmalonic acid, we saw why. Neurologic symptoms, reversible dementia, subacute combined
degeneration due to involvement of B12 in fatty acid pathway and myelin synthesis. This is why you get neurologic symptoms. So you have spinal cerebellar tract, lateral cortical spinal tract. So that's the motor, that's the sensory. This is also sensory from the limbs. Dorsal column dysfunction. Folate supplementation and vitamin B12 deficiency can correct the anemia but worsen neurologic symptoms. Uh, sorry. Historically diagnosed with the Schilling's test, a test that determines if the cause is dietary insufficiency or malabsorption. So, we learn about that later. We are looking into Schilling test. So what is that? So historically diagnosed with the Schilling test, a test that determines if the cause is dietary insufficiency versus malabsorption. Anemia secondary to insufficient intake may take several years to develop due to liver's ability to store B12. It apparently stores for like 3 years compared to folate deficiency, which takes weeks to months to develop because you have like 3 months of storage for folate. Orotic aciduria is the inability to convert orotic acid to UMP, de novo pyrimidine synthesis pathway, right? We talked about that. Pyrimidine, where'd it go? Right, so it's not able to go from orotic acid to UMP, so it has deficiency in this UMP synthase, or it's impaired in orotic aciduria. Okay, so orotic aciduria, inability to convert orotic acid to UMP, de novo pyrimidine synthesis pathway because of defect in UMP synthase. Autosomal recessive it presents in children as failure to thrive, developmental delay, and megaloblastic anemia, refractory to folate and vitamin B12. There is no aminomia versus ornithine transcarbamylase deficiency, right, where you have increase in orotic acid with hyperaminomia. I'm having such a hard time saying that, but you get it. Basically, what it's saying is that you know how there's carbamide phosphate here. It comes from urea cycle, right? So deficiency of ornithine transcarbamylase will cause buildup of carbamyl phosphate and ammonia, right? And this carbamyl phosphate will then go into here and make more orotic acid, right? Increase amount of this, and so you have increased amount of this and ammonia, and that's how you know that the deficiency is in urea cycle in ornithine transcarbamylase, right? So deficiency increases ammonia and orotic acid. But in here, if the deficiency is this, it's there's not going to be a buildup of ammonia, right? And then you have thymidine synthase. It also requires so in folate deficiency, thymine reduces apoptosis. Okay, so de novo pyrimidine synthesis pathway because of defect in UMP synthase. Autosomal recessive presents in children as failure to thrive, developmental delay, and megaloblastic anemia, refractory to folate and B12. Orotic acid in urine, you'll find that. Treatment is uridine monophosphate or uridine triacetate to bypass mutated enzyme. This is important. They'll ask you which amino acid becomes essential in orotic aciduria or something like that. It's going to be uridine. Okay, so uridine monophosphate or triacetate to bypass the mutated enzyme. Non-megaloblastic anemia,
These are macrocytic anemia in which DNA synthesis is normal, causes chronic alcohol overuse or liver disease. RBC macrocytosis without hypersegmented neutrophils. Right. So they're big, but they don't have the hypersegmented neutrophils. Okay. PMNs or whatever. Diamond blackfan anemia. This is a congenital form of pure red cell aplasia versus Fanconi anemia, which causes pancytopenia. Right. So this only affects the red cells, not all the other ones. Whereas Fanconi anemia does it for everything: thrombocytopenia, leukocytopenia, and erythrocytopenia. Rapid onset anemia within first year of life due to intrinsic defect in erythroid progenitor cells. Increased percentage fetal hemoglobin, but decrease in total hemoglobin. There's short stature, craniofacial abnormalities, and upper extremity malformations. Triphalangeal thumb in up to 50% of cases. We looked at that, but once again, so you remember what that is. So there's short stature, craniofacial abnormalities, right? And upper limb, so you know, this one doesn't have like a normal thumb. Okay, or there are four over there. So those are upper extremity malformations. Triphalangeal thumb. Right, that's what that was. In up to 50% of the cases. Normocytic normochromic anemia. This is normocytic chromic anemia are classified as non-hemolytic or hemolytic. Right. The hemolytic anemias are further classified according to. Let's look at this. So we are talking about this now. So normocytic normochromic, so normal size and normal color anemia are classified as non-hemolytic and hemolytic. The hemolytic anemias are further classified according to the cause of the hemolysis. It could be intrinsic versus extrinsic to the RBC, and by the location of hemolysis. Right, it could be intravascular or extravascular. That's this and this. So hemolysis can lead to increase in LDH, reticulocytes, unconjugated bilirubin, pigmented gallstones, and urobilinogen in urine. Intravascular hemolysis findings are decrease in haptoglobin. Why? Because what does haptoglobin do? It binds to hemoglobin, right? So now if you have hemolytic anemia, there are so many hemoglobins flowing around, and all the haptoglobins are gonna get busy with them, right? So the amount of free haptoglobin you have is going to be decreased. Okay, you already have haptoglobin in your bloodstream, so it's not that it's going to make more haptoglobin, so don't think that's going to increase. It's just that the available haptoglobin decreases now during hemolytic anemia. Okay, so increase in cystiocytes and on blood smears. Okay, this were the helmet cells. Right, just gotta make sure. Yeah, so schistocytes are the helmet cells. Okay. Characteristic hemoglobinuria, hemosideриnuria, and urobilinogen in urine. Notable cause of mechanical hemolysis. So mechanical hemolysis, you need helmet when you go to mechanical sites. For example, prosthetic valves, paroxysmal nocturnal hemoglobinuria, and microangiopathic hemolytic anemia. So these are all your intravascular causes, and then you have extravascular causes, Mechanism: macrophages in spleen clear RBCs. Findings are splenomegaly, spherocytes, and peripheral smear, most commonly due to hereditary spherocytosis and autoimmune hemolytic anemia. No hemoglobinuria, hemosideриnuria. Okay, so you won't have it in there. Why? Because it's outside of the vessel, so it's not going to get filtered out by the blood. So you won't see it in the urine, because it comes from the kidney, right? So it can present with urobilinogen in urine, though. Okay. Non-hemolytic normocytic anemia, anemia of chronic disease. So inflammation, for example, interleukin 6 increases hepcidin. Hepcidin increases, then it's gonna inhibit the release. It's gonna inhibit the ferroportin, right? So let me bring up the photo or diagram for that. This diagram. Okay, so increase in hepcidin released by the liver. It binds to the ferroportin on the intestinal mucosal cells and macrophages, right? So this is macrophage intestinal cell. There's ferroportin right there. It's a port for iron to go out of, and then it gets transported by transferrin. So it stops all of this. So why? Because it's a anemia of chronic disease. That's why. It binds to ferroportin on intestinal mucosal cells and macrophages, thus inhibiting iron transport. This leads to decrease in release of iron from the macrophages and decrease in iron absorption from gut. Why? Because we read over here, it's a evolutionary reasoning. Pathogens use circulating iron to thrive. So the body has adapted a system in which iron is stored within the cell of the body, and it prevents pathogens from acquiring circulating iron, thus inhibiting its growth. So associated with conditions such as chronic infection, neoplastic disorder, chronic kidney disease, and autoimmune disease, for example SLE and rheumatoid arthritis. Okay, so what will you have? You'll have decrease in serum iron, right? Decrease in transferrin, right, or total iron binding capacity, but you'll have increase in the storage of iron because it's getting sequestered in the enterocyte and macrophages. Normocytic, but can become microcytic, right? So that's why this is in early stages it's going to be normocytic, but in late stages it's going to be microcytic. Treatment is address underlying cause of inflammation or judicious use of blood transfusion. Consider erythropoiesis stimulating agents such as EPO, for example in chronic kidney disease. Okay, you have aplastic anemia, failure or destruction of hematopoietic stem cells, right? It's the one that shows it looks like fat cells in the thing, okay, in the bone marrow. So failure of destruction of hematopoietic stem cells causes reducing volume from inside diaphysis. Radiation, viral agents, for example EBV, HIV, hepatitis, viruses. Fanconi anemia. Okay, so it can be caused by radiation or viral agents, Epstein-Barr virus, HIV, or hepatitis virus. Okay, majority of time it's going to be this. Fanconi anemia, it's autosomal recessive DNA repair defect, so pancytopenia, right? That's the one that causes it. Bone marrow failure, normocytic or macrocytic on CBC. It could be idiopathic immune-mediated primary stem cell defect, may follow acute hepatitis. It can happen because of drugs, for example benzene, chloramphenicol, alkylating agent, antimetabolites.
decrease in reticulocyte count, increase in EPO. Pancytopenia, right? So you have EPO because you don't have blood cells, so your kidneys are gonna secrete more EPO to do that. However, it's not gonna make any, so you won't even have the immature cells because it's not making any RBCs. Pancytopenia characterized by anemia, leukopenia, and thrombocytopenia. Right. So anemia, leukopenia, and thrombocytopenia versus aplastic crisis, which causes anemia only. Right. So it was up here somewhere. I was talking about that. I forgot where I was talking about it, but anyways. Normal cell morphology, but hypocellular bone marrow with fatty infiltration. So it's fat cells in the bone marrow. It's easy to figure out. They'll give you a photo like this or a slide like this, and you gotta figure out that it's aplastic anemia. You can also understand it from low WBC count, low platelet count, and low RBC counts with decreased reticulocyte count after you do a reticulocyte corrected index. Symptoms: fatigue, malaise, pallor, purpura, mucosal bleeding, patagy, infection. Treatment is withdrawal of offending agent, immunosuppressive regime, for example, anti-thymocyte globulin or cyclosporin. Cyclosporin is the one that acts on calciurenin, I think. We'll check that. Bone marrow allograft, RBC, platelet transfusion, and bone marrow stimulation, for example, GM, CSF. So 429. Right, so it's a calciurenin inhibitor, right, and that's the one that blocks interleukin 2. Okay. On to intrinsic hemolytic anemias. So same thing, normocytic, but hereditary spherocytosis, primarily autosomal dominant, defect in proteins interacting with RBC membrane, so skeleton and plasma membrane. For example, ankyrin band 3, protein 4.2 spectrin. Any of these. It's small, round RBCs with no central pallor. There's decrease in surface area or dehydration, increase in MCHC, premature removal by spleen, extravascular hemolysis. Okay, so outside of the vessels. Findings are splenomegaly, pigmented gallstones, aplastic crisis, parvovirus B19 infection. Labs are decreased mean fluorescence of RBCs in eosin 5 mm binding test, increased fragility and osmotic fragility test. They'll give you this, that they did an osmotic fragility test and there was an increase on it or positive for it. RBC hemolysis with exposure to hypertonic solution, normal to decreased MCV with abundance of RBCs. Treatment is splenotomy. Paroxysmal nocturnal hemoglobinuria, hemopoietic stem cell mutation, increase in complement mediated intravascular hemolysis, especially at night. It's acquired PIGA mutation, right? It's the one where it attacks its own cells, or the DAF factor, right? So impaired GPI anchor synthesis for decaying accelerating factor, DEF, or CD55, and membrane inhibitor of reactive lysis or MERO, CD59, which protect RBC membrane from complement. Okay, so basically the complement system doesn't activate against your own cells because your own cells have these on it, so they prevent that. But when
there's a defect of this, right? So impaired GPI anchor that attaches to this or this, it's going to start attacking your own cells, and that's why you get hemolysis during the night. We came across this in biochem right here, right? Defect in PICA gene prevents the formation of GPI anchors for complement inhibitors. So complements that get inhibited by these, so such as decay accelerating death or death factor. So these come in attached to complement inhibitor or GPI, sorry, and membrane inhibitor over here. It causes complement mediated intravascular hemolysis, causes decrease in haptoglobin and dark urine. That just means there is hemolytic anemia. Can cause atypical venous thrombosis, Budd-Chiari syndrome, portal vein, cerebral or dermal. Okay. So triad, there's going to be Coombe negative hemolytic anemia, mainly intravascular. So you won't have any immunoglobulins present there, so you won't have a positive result because there are no antibodies involved in there. So Coombe negative hemolytic anemia, mainly intravascular. Pancytopenia, venous thrombosis, for example, Budd-Chiari syndrome. Pink red urine in morning, associated with aplastic anemia, acute leukemias. Labs are going to be CD55-59 negative RBCs on flow cytometry. Treatment is eculizumab, targets terminal complement proteins for C5. C5 to C9 is the MAC complex. C6PD deficiency. So that's G6PD deficiency, X-linked recessive G6PD defect, decreases NADPH. This is from the HMP shunt. This one again. Okay, so X-linked recessive G6PD deficiency, that's glucose 6-phosphatase dehydrogenase deficiency. So if you don't have that, you won't have NADPH, right? And NADPH is used for glutathione reduction, fatty acid synthesis, cholesterol synthesis, and all that stuff, right? So there's reduced glutathione, increase in RBC susceptibility to oxidative stress, right? For example, sulfur drugs, antimalarials, or fava beans, and this causes hemolysis. Causes extravascular and intravascular hemolysis. Back pain, hemoglobinuria, or a few days after oxidative stress. Lab finding will be decreased. G6PD activity may be falsely normal during acute hemolysis. Blood smear shows RBCs with Heinz body and white cells. Okay. So let's look at that. Okay, you see white cells, and some of them you see Heinz body right there. Right, two single ones. You see white cells over there. Okay. Then you have pyruvate kinase deficiency. Okay, that is over this. Okay, so pyruvate kinase is right there, and that's the
deficiency. So it causes hemolytic anemia, increase in BPG, and no Heinz body. Okay. So since it can't make ATP here, it's gonna go through this to make the single ATP over there. And that's it. Okay. So autosomal recessive, pyruvate kinase defect, increase in ATP, rigid RBCs lead to extravascular hemolysis. Increased level of 2,3-BPG. What does this do? It decreases the hemoglobin affinity for O2. Right. So hemolytic anemia in a newborn. Labs are going to show blood smears, show burst cells. Burst cells for pyruvate kinase deficiency. Right. So burst cells. No Heinz body. And increased BPG and hemolytic anemia. So you gotta differentiate between this and G6PD when it comes down to it. They have similar signs and symptoms, right? So you'll have Heinz body here, but not Heinz body here. Okay, no Heinz body there. So sickle cell anemia, there is a point mutation in B hemoglobin gene, single amino acid substitution, glutamic acid to valine, because you're sick of vanilla. Mutant hemoglobin A is turned HBS. Causes extravascular and intravascular hemolysis. Pathogenesis: low O2, high altitude or acidosis. Precipitates sickling. Deoxygenated hemoglobin S polymerizes, which causes anemia and vaso-occlusive disease. Newborns are initially asymptomatic because of increase in fetal hemoglobin. Right, so that takes care of it. This is curative in sickle cell anemia, and there's decrease in HBS. Heterozygous sickle cell trait. So heterozygous, that's one good allele and one mutated allele. Sickle cell trait have resistance to malaria. Okay, sickle cells are crescent-shaped RBCs, causing crew cut on skull X-ray due to marrow expansion from the increase in erythropoiesis, also seen in thalassemia. Complications are aplastic crisis, transient arrest of erythropoiesis due to parvovirus B19, autosplenectomy, so you'll see Hal Jolly bodies, increased risk of infection by encapsulated organism, for example as pneumonia. Important. This is the reason why, if a person has recurrent infection who have sickle cell anemia, it's because their spleen stopped working. Okay, so splenic infarct, sequestration crisis, salmonella osteomyelitis, painful vaso-occlusive crisis, dactylitis. This is painful swelling of hand, feet. There's prepism. There's acute chest syndrome, respiratory distress, no pulmonary infiltrates on CXR or chest X-ray. Common cause of death: avascular necrosis, stroke, sickling and renal medulla, so decrease in oxygen saturation or partial pressure in oxygen, leads to renal papillary necrosis, and this causes hematuria. Hemoglobin electrophoresis, there will be decreased amount of adult or HbA, increase in HbF, and increase in HbS. Important thing, it's because of this symptoms don't arise until 6 months after birth. Treatment: hydroxyurea. Increase. Why? Because it increases fetal hemoglobin and hydration. We have HBC disease, glutamic acid to lysine or lysine, mutation in beta globin, causes extravascular hemolysis. Hemoglobin SC, one of each mutant gene, milder than HBSS. Blood smear in homozygotes will show hemoglobin crystals inside RBCs or target cells. last page. Extrinsic hemolytic anemias, description and findings. Hemolytic anemia, autoimmune hemolytic anemia. Sorry. Okay, you have a normocytic anemia that is usually idiopathic and Coombs positive because there are immunoglobulins involved. Two types. There's warm and there's cold. These both are highly important, high yield. So warm AIHA, chronic anemia in which primarily IgG causes extravascular hemolysis. It's seen in SLE and CLL. Important to remember that. And with certain drugs, for example, beta lactams or alpha methyl-dopa. Warm weather is good. Okay, so it's seen in SLE and CLL, or when they go on their treatment that requires B-lactams or alpha methyl-dopa. We have cold AIHA, that's acute anemia in which primarily immunoglobulin M is involved, plus complement cause RBC agglutination and extravascular hemolysis upon exposure to cold. It leads to painful blue fingers and toes. It's seen in CLL, mycoplasma, pneumonia infection, and infectious mononucleosis. Right, that's Epstein-Barr virus that does that, and mycoplasma pneumonia is the one with the walking pneumonia, and CLL. So if they give you that a hint that it's one of these infections, and they have blue or cold fingers, they're testing you about this, so you need to know about that. Okay. Spherocytosis and agglutinated RBC. Like that. That's agglutination right there. On peripheral blood smear, warm AIHA treatment is steroids, rituximab, splenectomy if refractory. There's cold AIHA treatment is cold avoidance and rituximab. You have microangiopathic hemolytic anemia. These are RBCs are damaged when passing through obstructed or narrow vessels. Causes are intravascular hemolysis, right? So when they pass through obstructed or narrow vessels. It's seen in DIC, TTP, HUS, SLE, HELP syndrome, or hypertensive emergency. Schistocytes or helmet cells are seen on peripheral blood smears due to mechanical destruction. Schisto is to split of RBCs. Then you have macroangiopathic hemolytic anemia. These are since micro is about narrowed vessel, the macro is about mechanical stuff. So prosthetic heart valves and aortic stenosis may also cause hemolytic anemia secondary to mechanical destruction of the RBCs. Schistocytes on peripheral blood smears. Hemolytic anemia due to infection, increased destruction on RBCs, for example, malaria and babesia. Okay, why? Because this is how it gets rid of schizone and merozoites, right? And how it spreads it into the bloodstream. Okay, leukopenias. Neutropenia is just absolute neutrophil count lower than 1500. Severe infection typical when it's less than 500. Okay. Causes are sepsis, post-infection, drugs including chemotherapy, aplastic anemia, SLE, radiation, and congenital. Lymphopenia is again same thing if it's less than 1500 or less than 3000 in children. HIV, DiGeorge syndrome, SCIDS, SLE, glucocorticoids, radiation, sepsis, post-operative. All of this can cause decrease in lymphocytes, so cause lymphopenia. And you have eosinopenia, absolute eosinophil count less than 30. It happens in Cushing syndrome and due to glucocorticoids. Why glucocorticoids? So glucocorticoids cause neutrophilia. However, even though it causes neutrophilia, it doesn't really let the neutrophils go to the site of infection and do its thing there. Okay, so despite causing eosinophilia, and lymphopenia, it causes neutrophilia. Okay, so glucocorticoids decrease activation of neutrophils adhesions molecules, and this is why I can't go into this, uh, the membrane or epithelium, and then go through that whole rolling migration and transmigration phase to go to the site of the inflammation or infection, because it can attach to the wall. So this impairs the migration out of the vasculature to site of inflammation. In contrast, glucocorticoid sequesters eosinophils in lymph nodes and causes apoptosis of lymphocytes. Okay, so in contrast, glucocorticoid sequesters eosinophils in lymph nodes and causes apoptosis of lymphocytes. And we'll continue the rest later. I'll just go over the neutrophil bit. I'll look for that because I know I have it in right. So this thing, migration, rolling, activation, tight adhesion, and transmigration. So this adhesion that's happening right here with the p-selectin and e-selectin, it's not going to happen when corticosteroids is around here. So that's not going to happen. So if that doesn't happen, there won't be tight adhesion. If that's not there, then there's no transmigration with the PCAN. And if that doesn't happen, then there's no migration to the site of inflammation. Right? That's why, even though glucocorticoids causes neutrophilia, it doesn't let it go to the site of inflammation. And we'll continue
with heme synthesis and porphyrias and lead poisoning. The porphyrias are hereditary and or acquired conditions of defective heme synthesis that lead to the accumulation of heme precursors. Lead inhibits specific enzymes needed in heme synthesis, leading to a similar condition. Okay, so we have lead poisoning. You see these ribosomes, was it? Let me check. It's the stippling. Basophilic stippling, which are ribosomal precipitates. It does not contain iron. And you have this as well. That's in sideroblastic anemia. Okay, so lead poisoning. Affected enzymes are phyllochelitase, right there, and Ella dehydratase, right there. Accumulated substance, you'll have protoporphyrin and ALI, or aminolevulinic acid, in the blood. Presenting symptoms are microcytic anemia, basophilic stippling in peripheral smears, like that. It's ringed sideroblast in bone marrow. This is found in bone marrow, right? GI and kidney diseases. Children exposure to lead paint leads to mental deterioration. So you'll have in the question stem, it's going to say that the person belongs to a low economic society or something like that, or comes from a house that was built in like 1970s or something, and paint back then was used, had lead in it. So that's how that happens. Adults, environmental exposure, for example, batteries, ammunition, it will lead to headache, memory loss, and demyelination, peripheral neuropathy. Okay. So we have that there too. Let's look at this one and then we'll look at that one.
So acute intermittent porphyria, that's this thing right here. So porphyrin, uh, propobilinogen deaminase, autosomal dominant mutation. It's also known as hydroxymethylabine synthase. Okay. So what's gonna happen here is you'll have buildup of profobilinogen and Ella, right? So this and this, both of them. And symptoms are painful abdomen, port wine colored pee, polyneuropathy, psychological disturbances precipitated by factors that increase Ella synthase. For example, drugs, cytochrome P450 inducers, alcohol, and starvation. Treatment is hemin, and glucose. This is the treatment for this, hemin and glucose. Okay, see this? Here it says autosomal dominant, late onset, episodic, variable expression, anxiety, confusion, paranoia, acute abdominal pain, no photosensitivity, port wine urine in some patients, and never give barbiturates. Okay. The question stem's going to have this, that the person suffers from acute abdominal pain, and that he has a port wine urine. So you don't know what that looks like. Okay. So red like wine, I guess. Okay. Uh, that's basically it. Acute abdomen pain, port wine colored pee, and some kind of psychological disturbances that he's suffering from. Okay. It's precipitated by factors that increase Ella synthesis or synthase, so like drugs or alcohol. So it probably happened after he drank some alcohol. Okay, and then this one is the vampire one. So, okay, let's read that. So porphyria cutanea tarda, it happens when there's a deficiency of uro, porphyrinogen decarboxylase, right there. So you'll have buildup of uroporphyrin, tea-colored urine. Okay, and you have blistering, cutaneous photosensitivity, and hyperpigmentation. So they're afraid of the light, and when they go into light, they'll have hyperpigmentation like that. Okay, most common porphyria exacerbated with alcohol consumption. Causes are familial hepatitis C. Treatment is phlebotomy, sun avoidance, and anti-malarials. For example, hydroxychloroquine. Okay, here we have that. Porphyria cutanea tarda. Right. So cutanea is skin. So you can remember that with this, that they're afraid of the sun. And okay, most common porphyria, autosomal dominant, late onset, photosensitivity, inflammation, blistering, shearing of skin in areas exposed to sunlight, hyperpigmentation, exacerbated by alcohol, and red-brown to deep red urine. Okay, so you have to remember which deficiencies these belong to. This one is because of profobilinogen deaminase. Okay, and you have cutanea tarda because of uroporphyrinogen decarboxylase. U and D, that's like you die when you come across a vampire. Okay, so UD, maybe remember that way, and then you have PD. I don't know how you would remember that.
PD for PPD, because you do a PPD test on the. No, that won't work either. That's the skin one. How you gonna remember acute abdominal pain is related to porphobilinogen deaminase. Okay, you figured out. Treatment is glucose. It down regulates cytochrome P450 L synthase. Okay, that's why that's the treatment there. And hemin. Dextrose, RBC lose mitochondria near the end of life, 120 days per or 4 months. So no heme production near the end. Okay, so it goes from here, succinyl coenzyme A plus glycine. You have pyridoxine there, synthase. This is the rate limiting step. And glucose and hemin inhibits this process. Sideroblastic anemia extent also reduces or inhibits this process. Yeah, amino levulinic acid, lead poisoning, inhibiting hydratase, and porphobilinogen, going to hydroxymethylbilane. Right. So the important thing here is that it's now in the cytoplasm. So this step, the first step, happens inside of the mitochondria, and the transport from mitochondria to cytoplasm is inhibited in lead poisoning. So again, no heme synthesis because of that. Then you have propofol-bilinogen. That's you need the PD for that, and if you have this, it's going to inhibit this. Okay. So acute intermittent porphyria, and that's it inhibits this thing because it's the deficiency of this, I guess. Hydroxymethylbilane will lead to uroporphyrinogen 3, and that's UD, because you die if you come across a vampire. Porphyria cutanea tarda. Okay, so you get the P first and then the U second. Okay. So if you go from down to up, it's going to be U and P, so it goes up that way. I guess that works. So you encounter U before P if you're going from down here to up there. So U comes before P. It's important because they'll give you all of these names and you'll get confused which one's which. Okay, and then proporphyrinogen 3. And then this last step is back in the mitochondria. Protoporphyrin with the iron and ferrochelatase codeine. This phase is also inhibited by lead poisoning. Okay, so L-dehydratase and ferrochelatase, they both are inhibited by lead. Okay, on to iron poisoning. There's acute and chronic. In acute, the finding is high mortality rate associated with accidental ingestion by children. Adult iron tablets may look like candy. Mechanism is cell death due to formation of free radicals and peroxidation of membrane lipids. Symptoms and signs: abdominal pain, vomiting, GI bleeding, radiopaque pill seen on X-ray, may progress to anionic metabolic acidosis and multi-organ failure, leads to scarring and GI obstruction. Okay. Then you have treatment, which is chelation, the ones that have Fe in it, right, for iron. Deferoxamine and Deferesirox. They'll have to do. And gastric lavage. Chronic is seen in patients with primary hereditary or secondary for example, chronic blood transfusion or for thalassemia or sickle cell disease, and also hemochromatosis. Why transfusion? Because then when it gets ruptured or something, the RBCs, it's gonna leak out the iron, Fe, and that's eventually there'll be a buildup over time because it's not gonna get, excreted out of the body, so it's gonna settle somewhere in the tissue. Symptoms and signs are joint pain, cirrhosis, cardiomyopathy, diabetes mellitus, and skin pigmentation. Bronze diabetes, that's what it's called, and hypogonadism. Those tell you that the person has a bronze skin, or yeah, that's how they describe it. Treatment is phlebotomy, patients without anemia or chelation. Coagulation disorders, uh, PT, INR, and PTT. Right, so PT was play tennis, and you play tennis outside, so this is the one for extrinsic factors. Test function of common and extrinsic pathway. Factors are 1, 2, 5, 7, and 10. Okay. The main one is 7, right? Because these are the common pathways. So 7. So defect, which includes increase in PT. So yeah, okay. And INR, this is international normalized ratio. Patient with PT, patient PT divided by control PT, the normal one. If you get 1, that's normal. If you get more than 1, it's prolonged. Why won't you have less than 1? Because the clotting time is not going to be less than what normal clotting time is, right? So this number can only get bigger or stay the same as control. Because so most common test used to follow patients on warfarin, which prolongs INR, right? So it's an anticoagulant, right? So the whole point of it is to prolong the INR. Then you have PTT. This is play table tennis. So you play table tennis indoors or inside. Test functions of common and intrinsic pathway. So inside is intrinsic. All factors except 7 and 13, right? So it's going to be your intrinsic pathway or the common pathway that has a problem if you have increase in PT. Defect will lead to increase in PTT. Okay. So in a question stem, you'll have they'll give you a PT, they'll give you PTT or APTT. That's apparent PTT. So then if it's more than normal, you have the lab values, you can just look at those. If it's more than that, that means there's a defect in that pathway. So you could have normal PT and abnormal PTT. That means the extrinsic pathway is normal, it's the intrinsic pathway somewhere that there is a problem. Or vice versa, and if you have problem in factor 7, then you have normal PTT and this. If you have problem in both of them, then it's the whole coagulation cascade that has a problem, right? Coagulation disorders can be due to clotting factor deficiencies or acquired factor inhibitors, most commonly against factor 8. So that's where it's going to get confusing. If it's whether it's factor 8 that's responsible for this, or there's something problem with the thrombocytes. Okay, so the only way you differentiate between the two is you look at these, and these are going to be normal if the problem is with thrombocytes. Okay, and for that you also look at the bleeding time. They'll give you that. Okay, so coagulation disorder can be due to clotting factor deficiencies or acquired factor inhibitors, most commonly against factor 8. Diagnosed with a mixing study in which normal plasma is added to patient's plasma. Okay, so that's how you diagnose this. You put a normal plasma in the patient's plasma. So the clotting factor deficiency should correct the PTT, and PT returns to within the appropriate normal range, whereas factor inhibitors will not correct it. Okay, so if there is an inhibitor, it's not going to correct it. So disorder in hemophilia A, B, and or C, you'll have increase in PTT because this is a deficiency of either 8, 9, or 11, right? And they're all all parts of intrinsic and common pathway, right? So intrinsic is big table tendency inside. Mechanism common. Intrinsic pathway coagulation defect, increase in PTT. A is a deficiency factor 8. X-linked recessive, pronounced hemophilia A. B is deficiency of factor 9, X-linked recessive again. And then you have C, which is a deficiency of factor 11. This is autosomal recessive. For these, they're going to tell you that there's hemarthros, right? Or they chipped their tooth or they broke their tooth and they can't stop bleeding, or hemarthros. So what is hemarthros? It's hemorrhage in hemophilia. So hemarthrosis is bleeding into joints, for example knee. And how do you know that it's that? It's because it's going to be unilateral. Okay, and this is like a buzzword. If you have this bleeding into joints, for example E, or you have bleeding after trauma or surgery like dental procedures, these are the ones that they use in the question stems. So if you have this, it's going to be hemophilia. Okay, with the easy bruising, that's a low weight because that happens in like Ehlers-Danlos, scurvy, and all that stuff too. So that's going to be weak. You can't diagnose just based on this. But if you have this or this, you can be sure that it's hemophilia. Treatment is desmopressin, factor 8 concentrate, emicizumab A, factor 9 concentrate, and factor 11 concentrate, right, for C, 9 for B, and emicizumab for A. Why desmopressin? Remember, it has an action on the vessels as well, and endothelial cells contain what? They contain the von Willebrand factors, right? So, and von Willebrand factor does what? It protects factor 8, right? So, that vitamin K deficiency, PT increases, and PTT increases, right? Because it was 2, 7, 9, 10 CNS that requires vitamin K, and that's what warfarin inhibits via which one? Epoxide. Which epoxide was it? Epoxide reductase, right? So it inactivates 2, 7, 9, 10 CNS, right? Okay, so when you have vitamin K deficiency, PT increases because of factor 7, and this increases because of factors 2, 9, 10 CNS. Okay, general coagulation defect, bleeding time normal, decrease activity of factor 2, 7, 9, 10, protein C and S. Okay, bleeding disorders. These are the bleeding disorders. We went over them a little. Let me just bring that down so we can get it while we do this. Okay, so Bernard-Solier syndrome, that's deficiency of GP1B, right? So platelet can't bind to the exposed collagen, right? So the bleeding time is going to increase, right? And platelet count is going to decrease, right? Uh, oh yeah, I forgot this. So platelet disorders, all platelet disorders have increased bleeding time. This is important. So if you have normal PT and PTT, but increase in bleeding, that means clotting factors and your coagulation cascade is okay. It's the platelets that have a problem. That's why you're bleeding. Because why does there are two reasons a bleeding can happen, right? One, the clot is not being made, or second, there is no fibrin mash happening. No platelet aggregation happening there at the place, right? So, how do you differentiate between the two? So this is how you do it: increase in bleeding time, mucous membrane bleeding, and micro hemorrhages. So you get petechiae. If you have petechiae, it's usually because of platelets, right? Because it's not keeping up with that. And mucous membrane bleeding, that's also similar to this one. Easy bruising, or bleeding in the gums, like scurvy. And microhemorrhages, petechiae. This also happens in scurvy, right? Because vitamin C is required for collagen, and then collagen is not, doing its thing over here at the subendothelial collagen, so that's why it's bleeding. Okay. Platelet count is usually low, but may be normal in qualitative disorders. Okay. So you have Bernard-Soulier syndrome. So you have decrease in platelet count and increase in BT. Notes: autosomal recessive defect in adhesion, decrease in GP1B, which decreases platelet to 1 Willebrand factor adhesion. Labs are abnormal ristocidin test, right? That's how you figure that out. Important to remember this because this will come up. Big platelets. Okay, so Bernard is the one with the big platelet attaching to the 1 Willebrand factor. 1 Willebrand factor attaches to the collagen. Okay. Then you have Glanzmann thrombasthenia. Okay, you have the platelets here, but what you don't have is the attachment or the platelet aggregation, right? Because GP2B and 3A are involved in platelet aggregation. So deficiency of this receptor is called Glanzmann thrombasthenia. Okay. Notes are autosomal recessive defect in aggregation, decrease in GP2B and 3A. There is decrease in integrin alpha 2B and beta 3. This leads to decrease in platelet to platelet aggregation and defective platelet plug formation. Labs are blood smear shows no platelet clumping. So you're gonna add your factors and everything, and there's still not going to be any aggregation. So that's your Glanzmann thrombasthenia. The difference between these two is that platelet count decreases, and it could decrease in this one, and it's normal in this one, but it could be normal in this one too. So there's really no way of differentiating between these two without doing some kind of lab test. Or they might just tell you that the receptors they have are able to attach to 1 Willebrand but not to each other. So then that also tells you what it is. Okay, and then there's immune thrombocytopenia, where you do have decrease in platelet count and increase in bleeding time. Destruction of platelets in spleen. Destruction of platelets in spleen. Okay. Anti-GP2B and 3A antibodies leads to splenic macrophages, phagocytose, and platelets. Sorry. Splenic macrophages phagocytize the platelets, may be idiopathic or secondary to autoimmune disorder, for example, SLE. Viral illness, for example, HIV and hepatitis C virus. Malignancy, for example, chronic lymphoid leukemia or drug reactions. Okay, labs are, this is how you figure out. So there will be increase in megakaryocytes on bone marrow biopsy, decrease in platelet count. Treatment is glucocorticoids, IVIG, rituximab, TPO, receptor agonists, for example, eltrombopag and romuplastin. So here you have eltrombo, so you know it's something to do with clotting or plugging, and then you have PL for platelets, or splenectomy for refractory ITP. For this, they'll give you some kind of indication that it's something to do with antibodies or immune response. They'll give you that there is splenomegaly, right? Because it's going into hyperaction. SLE is a malar butterfly rash on the face, usually in middle-aged women. And then you have HIV, hepatitis C, malignancy. Okay, or drug reaction. Cool. You can have uremic platelet dysfunction, where the platelet count doesn't change, but there's increase in bleeding time. In patients with renal failure, uremic toxins accumulate and interfere with platelet adhesion. Okay, so there's a problem over here. Thrombotic microangiopathies. So that's disorders overlap significantly in symptomatology. May resemble DIC but do not exhibit lab findings or of a consumptive coagulopathy. So increase in PT, increase in PTT, and decrease in fibrinogen. As etiology does not involve widespread clotting factor activation. Okay, so you won't have bleeding through the pores, eyes, nose, and the holes. So it seems like DIC, but it's not. Okay. In DIC, you have these findings as well. Okay, so TTP, or thrombotic thrombocytopenic purpura. Epidemio is typically in females. Patho is inhibition of deficiency of ADAM TS13, a 1 Willebrand factor metalloprotease. This is important, okay, because so this is what it does, right? So it comes in, it breaks this thing, 1 Willebrand factor multimer, right? And then that's how you get that released into the bloodstream. This is normal. This is how it functions. But now that if you don't have this, what's going to happen? Severe deficiency of NMTS, uncleaved 1 Willebrand multimer, right? And then you have free-flowing VWF platelet thrombus. It's attached to it, right? The platelets are attached to this instead of going at the site and attaching to that. Because why do we need VWF? One, it protects factor VIII, and second, it attaches to the exposed collagen, right? So if it's not exposed to the collagen, then platelet can aggregate there. So it aggregates on wherever this is. So now it's just aggregating at these places, and that's why it seems like thrombosis, coagulation, consumption, coagulopathy, right? Or DIC, disseminated intravascular coagulation, but it's because of this why you're getting increase in PT and PTT. So inhibition of deficiency of 8 ADAMTS13, a 1 milligram factor metalloprotease, it leads to decrease in degradation of 1 milligram factor multimer. It leads to increase in large 1 milligram factor multimers. There's increase in platelet adhesion and aggregation. Microthrombi formation. Presentation is triad of thrombocytopenia, decrease in platelets, microangiopathic hemolytic anemia, leads to decrease in hemoglobin, cytosis, increase in LDH, acute kidney injury. Okay, this is what you will see. So in the question stem, so what they'll say is the person has decrease in platelets, right? So thrombocytopenia. They have some kind of hemolytic anemia, so they'll tell you that it's decrease in hemoglobin, or there's increased amount of bilirubin, unconjugated bilirubin found in the blood, or in the urine. Urine gets dark after leaving it still, right? So something like that, that will indicate that there's hemolytic anemia, and they'll either give you increase in creatinine or BUN levels, or just tell you that this person has kidney injury or something to do with kidney, right? Some kind of problem with kidney. So something wrong with kidney with thrombocytopenia and anemia, hemolytic anemia, is going to be thrombotic thrombocytopenic purpura. Okay, so in this one you'll have this, plus you'll have fever and neurologic symptoms. So if there's fever and neurologic symptoms, it's thrombotic thrombocytopenic purpura. Okay, the labs are going to be normal PT and PTT. It helps distinguish TP and HUS. Okay, so coagulation pathway is not activated from, so it will help you differentiate this with DIC. Okay, coagulation pathway is activated in DIC. Okay. Okay. Okay, so I guess you'll have normal PT and PTT for this, because it's right, of course, because it's not a problem with coagulation cascade. So that's why you have normal this. Because when we do it in a lab, you don't worry about 1 milligram factors stuck somewhere else, right? So it'll give you normal PT and PTT. But for DIC, you'll have coagulation pathway activated, so that's why you increase that. And that's how you differentiate between DIC and this. Also for DIC, they'll tell you that they're bleeding from the intravascular sites and everywhere else, eyes, nose, and all that stuff. Treatment is plasma exchange, glucocorticoids, and rituximab. And then you have HUS, or hemolytic uremic syndrome. This is typically in children, so that's also how you can figure it out. If you remember that this only happens in children, this can happen in typically females or adults. Pathophysiology, predominantly caused by Shiga-toxin producing E. coli, STC, right? Or ETEC, right? That's what it was. ETEC infection. Serotype is 0157 by 87, which causes profound endothelial dysfunction. Let's quickly look at the mechanism for that. Right, ETEC right there. So it was GS and activating adenylate cyclase, increase in CMP, increases this chlorine secretion in gut, right, NH2O. Okay, and then you have There's also one with right here. Okay. E-Tech. So E-Tech was this. That's not the one. It was E-Heck. Okay, that's the one. E-Heck is the one that I was looking for. So this is the one that causes HUS, right? So triad of anemia, thrombocytopenia, acute injury, uh, kidney injury due to microthrombi forming on damaged endothelium, mechanical hemolysis with schistocytes on peripheral blood smear, platelet consumption, and decrease in renal blood flow. Okay, it happens via undercooked meat, raw leaf vegetables. Dysentery happens. Toxin alone causes necrosis and inflammation. Does not ferment sorbitol versus other E. coli. EHEC associated with hemorrhage, hamburgers, and that. Okay, back to this. So, how do you differentiate between this and this? This one's gonna have triad plus the bloody diarrhea, right? Whereas this one had fever and neurologic symptoms. The labs are going to be normal for PT and PTT, which is going to help you differentiate between this and DIC, and treatment is just supportive care. Okay. Then mixed platelet and coagulation disorder. Okay. Von Willebrand disease, PCBT. That's bleeding time will increase, right? So for von Willebrand, you have increase in bleeding time, but your extrinsic factor is going to be normal. It could affect your intrinsic factors. So intrinsic factor coagulation defect. Why? Because remember this one protects what? Factor 8. Factor 8 is part of PTT, right? So intrinsic pathway coagulation defect. Decrease in von Willebrand factor increases PTT because von Willebrand factor carries or protects factor 8. So defect in platelet plug formation. Decrease in von Willebrand factor leads to defect in platelet to von Willebrand adhesion. Most are autosomal dominant, mild, but most common inherited bleeding disorder. No platelet aggregation with ristocidin cofactor assay. Treatment is desmopressin, which releases von Willebrand factor stored in endothelium. DIC, this is the main one where you'll have bleeding from all the sites. Let's see if there's a photo of that. They had an episode on House for this. Like that. That's what it looks like. They're bleeding from everywhere. Right? From the mouth, the nose, the eyes, the puncture sites, and all that. Okay. Is a rare but serious condition that causes abnormal blood clotting throughout the body's blood vessels. Cool. Okay. So you have platelet count is going to be decreased in this. You have increasing bleeding time because of that, and because of the coagulation factors, you have increase in intrinsic and extrinsic defect in intrinsic and extrinsic factors. It's a widespread clotting factor activation, thromboembolic state with excessive clotting factor consumption, increase in thrombosis, increase in hemorrhages. Right? So basically, what's happening is you have a vessel right here, right? So beginning, normally you have wear and tear happening on your vessels all the time, right? So there'll be, say, a damage here. Okay, so that is going to cause activation of stuff, your coagulation factors and all that stuff, right? So that gets used up here. Then say this has happened somewhere else as well, right? So there's like over here and like over here. So whatever clot was already formed here, the fibrin mash, that gets break down and goes to the new one, right? And so this one is gonna start bleeding again, right? And then like, or go through that and upwards, and this one goes bleeding again as well. So it's because this one opened up to take care of this one. So there's a widespread clotting factor activation. It's gonna, you know, everywhere the clotting is gonna start happening and everything. Eventually, it's gonna run out of clotting factors. Okay. So thromboembolic state with excessive clotting factor consumption. So if it once it uses up all the clotting factors, you're gonna have ones that cannot be clotted, right? And that's how you end up with DAC. Okay. So that will increase thrombosis. Okay, because you have clotting somewhere else, right? Because there's a widespread clot happening, so everywhere. And now eventually this is gonna get broken off from there and go somewhere else in a smaller vessel. Branch, and then cause injury there as well. So because of this, it's going to cause hemorrhages as well. Okay, so thrombosis and increase in hemorrhages, for example, blood oozing from puncture sites. Okay, maybe acute, life-threatening, or chronic if clotting factor production can compensate for consumption. So if clotting factors are compensating, then it's going to be a chronic condition, right? Because it's trying to keep up. But if it can't, then it's going to be acute, which is life threatening. The causes are heat stroke, snake bites, sepsis, trauma, obstetric complications, acute pancreatitis, malignancy, nephrotic syndrome, transfusion, right? So stop making new thrombi. Okay. Labs are schistocytes, right? That's the one with the helmet cells. Increase in fibrin degradation. Products are D-dimer and decrease in fibrinogen and decrease in factor 5 and factor 8. Okay. Factor 5 is a regulator, right? I guess regulated by anticoagulants, factor C and S. So there'll be decrease of that, and then also factor 8. There'll be increase in fibrin degradation products, so D-dimer will increase, right? Because it's getting broken down, clot is getting broken down, so it can be used up somewhere else, or it just goes into, thrombus by itself gets split and then gets stuck at places like this. Okay, and this is going to be a microvascular injury, right? So that's why you get schistocytes. Hereditary thrombophilias, autosomal dominant disorders resulting in hypercoagulable state, increase in tendency to develop thrombosis, disease and description. Antithrombin deficiency has no direct effect on the PTT, or thrombin time, but diminishes the increase in PTT,
following standard heparin doses. Okay. So there. Okay. So antithrombin deficiency. So something that doesn't stop it. So it has no direct effect on PT and PTT or thrombin time, but diminishes the increase in PTT. Right. Following standard heparin dosing. Okay. So, because that's what this one acts on, right? It acts on antithrombin. If you remember. Right here. So when you give heparin, the heparin-like molecule attaches to the antithrombin, and then the antithrombin then combines to the thrombin to stop its effect. But since there is no antithrombin, heparin can't attach to anything. Right, so it has no direct effect on PT, PTT, or thrombin time, but diminishes the increase in PTT following standard heparin dosing. It can also be acquired in renal failure or nephrotic syndrome. It leads to antithrombin loss in urine. So it's not that you have deficiency, it's just that you lost it and now you have a deficiency of that because of that in urine. It leads to decrease in inhibition of factors 2A and 10A. So that's thrombin and the coagulation factor 10 activated 10. Okay, then you have factor 5 latent. This is the one where it's mutated, so it doesn't listen to CNS. Right, so production of mutant factor 5, guanine gets replaced by adenine DNA point mutation, so it leads to ARG506G1N mutation. Don't need to remember that. Near the cleavage site. That is resistant to degradation by activated protein C. So it won't get inhibited by protein C. So you have factor 5 right there. So factor 5 is influenced by regulatory anticoagulant proteins, protein CNS. So it doesn't regulate this anymore. So this one is going to constantly convert 10A and 2 into 2A, which is thrombin. Activated 2 is thrombin. 1 is fibrinogen and fibrin. Okay. Decreased ability to inactivate factors 5A and 8A. Oh wait, no, I was here. That is resistant to degradation by activated protein C. Complications include a deep vein thrombosis, because now you have hypercoagulable state now, right? So the most common thing it causes is DVT in a hypercoagulable state. You'll have cerebral vein thrombosis or recurrent pregnancy loss. Why? Because it's gonna clot up the blood supply to fetus. If you have protein C and S deficiency, is similar, right? To factor 5 lean. So there will be decreased ability to inactivate factors 5A and 8A. There will be increase in risk of warfarin-induced skin necrosis. Together, protein C cancels and protein S stops coagulation. Okay, so why would this happen? Remember I told you what warfarin does? Warfarin inhibits activation of vitamin K, right? So that's gonna, if you don't have activation of vitamin K, it's not gonna make new clotting factors or so it's not going to make new clotting factors, right? And the clotting factors dependent on vitamin K are 2, 7, 9, 10, C and S, right? So if you're not making new one, eventually everyone's going to die off, right? They all have half-lives. However, 2 and
uh, 10, I think, have the longest half lives, and the shortest one is 7. And C and S are pretty short too. So what's gonna happen when you're giving warfarin? It's gonna reduce. Yeah, so C and S die off quickly. It degrades quicker than 2 or 10, I think, but definitely 2. So, and 2 is thrombin, right? So, or prothrombin. Uh, so then you turn out to have more clotting because you don't have clotting factors like C and S anymore because they have died off, and clotting factors have not died off yet. So that's going to cause thrombosis and then ischemia and then necrosis because of that. Okay, so you need CNS before clotting factor 2 dies off. Okay, so how do we take care of that? The clotting, we give heparin. It's called the bridging. So we give heparin to when we initiate warfarin to take care of the initial complication of this. Okay, prothrombin, G2021A0A mutation. Okay, this is a point mutation in 3' untranslated region. It leads to increased production of prothrombin, which leads to increase in plasma levels and venous clots. Okay, that's just 2 going to 2A, right? So mutation causes increased production of prothrombin, increase in plasma levels, and you'll get clots.
On to blood transfusion therapy component, dosage effect, and clinical use. Packed RBCs, increase in hemoglobin and O2 binding carrying capacity. So that's what it does. Increases hemoglobin and oxygen carrying capacity. Clinical uses: acute blood loss and severe anemia. Platelets are going to cause increase in platelet count, so increase approximately 5,000 per unit. Why? We use it to stop significant bleeding. So thrombocytopenia, qualitative platelet defects. You have fresh frozen plasma, prothrombin, complex concentrate. This is to increase coagulation factor levels. FFP contains all coagulation factors and plasma proteins. PCC generally contains factor 2, 7, 9, and 10, and as well as protein CNS. Okay. Plasma and prothrombin complex concentrate, or PCC, and FFP. These are used in cirrhosis and immediate anticoagulation reversal. Okay, so for what this means is we actually use it for warfarin, right? Because this is the one that has an immediate effect. Okay, and for delayed effect, we give vitamin K. Then you have cryoprecipitate. These are contain fibrinogen, factor 8, factor 13, 1 Willebrand factor, and fibronectin. Okay, so coagulation factor deficiencies involving fibrinogen and factor 8. Okay, again, this protects factor 8. Albumin, this to increase intravascular volume and oncotic pressure. Right, so increase intravascular volume and oncotic pressure. The clinical uses: post-paracentesis, therapeutic plasmapheresis. Okay. Blood transfusion risks include infection transmission, which is low, transfusion reactions, iron overload may lead to secondary hemochromatosis, and hypocalcemia. Citrate is a calcium chelator, right? And we use that to preserve the collected blood in the bag. And
hyperkalemia. So RBCs may lyse in old blood units, causing hyperkalemia. Okay. So this and uh, they both happen in old units. Okay, if the blood is used from an old unit. Okay, leukemia and lymphoma. Leukemia is lymphoid or myeloid neoplasm with widespread involvement of bone marrow. Tumor cells are usually found in peripheral blood. Lymphoma is discrete tumor mass arising from lymph nodes. Okay, it's in the name. Okay, leukemia, lymphoid or myeloid, and then you have lymphoma, which is going to be at the lymph nodes. Variable clinical presentation, for example, arising in atypical sites, and leukemic presentation. Okay. So there's Hodgkin versus non-Hodgkin lymphoma. One only happens at in one site, and the other one happens all over the place in all the lymph nodes. So this is contained to like a one lymph node, and this is contained in like this is spread out through all the lymph nodes. Okay, that's basically it. Uh, so Hodgkin and non-Hodgkin. Both may have constitutional B signs and symptoms. That's low-grade fever, night sweats, and weight loss. Uh, Hodgkin is localized single group of nodes with contagious spread. So state is strongest predictor of prognosis. Uh, Better prognosis with this one. It's characterized by Reed-Sternberg cells. This is another inclusion body that we need to know about. So that thing right there is Reed-Sternberg cells, and it looks like two eyes, right, in a mask, or maybe actual allies from CMV, but like two of them together. So it looks like Deadpool, baby Deadpool, maybe. Right? Like that. Yeah, so Deadpool right there. Okay, so when you see that, you think of Hodgkin's. Bimodal distribution, young adults, more than 55 years, associated with Epstein-Barr virus. This is important. This is what it's associated with. Okay. Then you have non-Hodgkin. Uh, both, again, sign and symptoms are low-grade fever, night sweats, and weight loss. You know, if there's weight loss, it's gonna have to do something with cancer, unless they're telling you it's about malabsorption, right? Multiple lymph nodes involved, extranodal involvement common, non-contagious spread. Worse prognosis with this one, obviously, because it's in more than one place, so it's spread out. Majority involve B cells, rarely of T cell lineage, can occur in children and adults, and whereas this one was bimodal, right? So if you had a Y and an X chart with age over here, and presence of Hodgkin's on this side, right? Hodgkin's on this side. Then you'll have in like 0 age over here to like say 18, right? And then you have 50 to above, right? So it's gonna be like a rise in Hodgkin, non-Hodgkin here, and then low again, and then high again, right? So this is called bimodal distribution. Sorry, not a non-Hodgkin, just Hodgkin. So this is gonna be bimodal, whereas this one, it can occur in children and adults. So it's gonna be like this, or actually, everyone's adult, so it's gonna be a flat line. Okay, so it can occur in children and adults. Non-Hodgkin may be associated with autoimmune diseases and viral infection. That's Epstein-Barr virus as well as HIV and HTLV. Remember, HTLV was also a retrovirus, just like HIV, I believe. Right, so HTLV and HIV both are retrovirus. Okay. Uh, Important to know this because they'll give you that this person is losing weight and he has a lymphadenopathy under the neck or in the axilla or something, and then they'll tell you that when it was biopsied, it had a reaction against antigens, labeled antigens for EBV or something like that, or like it had antigens for CD19 or CD20, so that's going to be B cell, right? Something like that. So Hodgkin's lymphoma, we'll learn about that. So this one is for CD15 and 30, and these ones are the non-Hodgkin ones. We'll do that later after this. So okay, so Hodgkin's lymphoma contains Reed Sternberg cell, Deadpool, or you can name that one Reed and that one Sternberg. Distinctive tumor giant cells, bilobe nucleus with two halves as mirrored images. Okay. Kin is family, right? So they're related to each other. So these two are related, Reed and Sternberg. So they're out of Hodge. When you see this, you need to know that this is Hodgkin's lymphoma. Like that's what this looks for. No, that's what this is used for. Okay, so bilobe nucleus with two halves as mirrored images, allies. RS cells are CD15 plus and CD30 positive. B cell origin. Two allies, 15 equal, 2 times 15 is 30. Subtypes and notes. So nodular sclerosis is most common type. Then you have mixed cellularity. This is eosinophilia seen in immunocompromised patients. And then you have lymphocyte rich, which is best prognosis. The rich have better bank accounts. And lymphocyte depleted, worst prognosis. The poor have worse bank accounts, seen in immunocompromised patients. Okay. So these are the subtypes for Hodgkin's. It could be sclerosis. So that's just hardening of the lymph node. Mixed cellularity. You have eosinophilia, seen in immunocompromised patients. Okay. So you'll have enlarged lymph node and you'll have eosinophilia and there will be weight loss. Okay. And they might tell you that they give you this or they give you this. Then you need to know because of this, it's the mixed cellularity type. Okay. And then if they're lymphocytosis, then it has a better prognosis, and if there's lymphopenia, it's worse prognosis. On to non-Hodgkin lymphoma. These are all the subtypes for this. Okay. Type occurs in genetics and commons. Neoplasms of mature B cells. Okay, B cells. Burkitt's lymphoma. It happens in adolescents or young adults. Okay. T8/14 translocation of C mice and heavy chain immunoglobulin. Okay, important to know C mice. That's the translocation that happens, and it happens between 8 and 14. Important to know that as well. You need to know the translocations between all of them, at least these. Okay, so 8/14, and it happens in adults and young adults. So I think of it like, okay, so people of aged 8 to 14, have Burkitt's. Okay. Starry night appearance, right? So why do they say starry night appearance? Because it looks like that, right? So for that, you need to know what starry night is. By Van Gogh, right? That's this painting. So it kind of sort of looks like this painting. So keep this painting in mind, okay, while we look at Burkitt's lymphoma. Okay, so starry night, right? Little stars curling over here and little faces. Okay. Okay. So you see this and you should think of Burkitt's lymphoma. That's what this pertains to. Like, you see this and that's all it can be. It can't be anything else. But you don't have to worry if you don't figure that out, because they will give you that there's lymphoma under the jaw, or like he has a lymphadenopathy under the jaw or something like that. So starry night appearance, starbursts, is sheets of lymphocytes with interpersed tangible body, macrophages, arrow in A. Okay, so those macrophages associated with Epstein-Barr virus. So this is important here as well, because it's associated with Epstein-Barr virus. We read that here as well. Epstein-Barr virus there, and this. Okay, it's C mice. Okay, because Starry Night, it looks like it's made in New York City, so instead of new, it's MYC, right? And UC NYC. Starry Night, Burkitt's, from age 8 to 14. Okay, and it's associated with Epstein-Barr virus. So when I say lymphadenopathy near the neck, I mean jaw lesion, right? Because this is what it looks like, and that's classic presentation for Burkitt's lymphoma, jaw lesion, and it's gonna be in someone immigrating from Africa, in endemic form in Africa, pelvis or abdomen in sporadic form. It could be someone who's immigrating from there, or it's someone who visited Africa and then came back and then they had a jaw lesion. Yeah. And when they biopsied it, they saw starry night appearance or starry sky appearance. Okay. Then there is diffuse large B cell lymphoma. This is usually older adults, but 20% in children, so that doesn't help. This one is always going to be someone young. This one, it can be anyone. All the other ones, actually. Okay, so diffuse large B cell lymphoma, it's mutations in BCL2 and BCL6. Remember, BCL means be clever and live, so it prevents apoptosis. So most common type of non-Hodgkin lymphoma in adults. Okay, so since be clever and live, so it prevents apoptosis, you'll have diffuse lymphoma, and you'll have large B cells, because they don't die off, so they get big and fat. So that's why it's large B cells. Okay, follicular lymphoma, adults. Again, this is going to be 14 to 18, right? So it's translocation of heavy chain and BCL2. This is important to remember. It's between heavy chain and BCL2, 14 to 18. Okay, and indolent course with painless waxing and waning. So if they tell you in the questions that it kind of hurts a little, but then after a while it stops hurting for a while, and then it starts hurting again, and then it stops. Something that, or they might just say waxing and waning type of lymphadenopathy. It's gonna be follicular, and follicular is 14 by 18 translocation. BCL2 normally inhibits apoptosis. Okay, so you have to remember that as well. Definitely remember it for this, but you have to remember it for all of them as well. But this is the most important one, 8 and 14. Like, the way I remember is that there are two of follicles like this, right? So it's two follicles. The inner diameter is 14 and the outer diameter of the follicle is 18. That's how I remember it. 14 and 18. The follicles. Then you have mantle cell lymphoma. Men is in the name. It's because it occurs mostly in men than it does in females. And this is 11 to 14. Okay. You need to remember this thing. It's translocation of cyclin D1 and heavy chain, which is CD5 positive as well. Okay. So 11 and 14 and CD5 positive. It's very aggressive. Patients typically present with late stage disease. So let's move this here. Okay. So this is very aggressive. Patients typically present with less late stage disease. So by the time they come to the hospital or the clinic and they tell you that it's this, and you check, it's already going to be in like stage 3 or 4, right? And it's going to be aggressive. So the patient's going to die within like some amount of time. So that's what the history will tell you. Or they might just give you that it's a translocation between 14 and 11 or 11 and 14, and they'll ask you what's that gonna affect. So it's gonna affect cyclin D1 and heavy chain immunoglobulin 1, right? 14 from here as well. It's a heavy chain. It's here as well, and it's here as well, right? So between C mice and 14. Okay. Then you have marginal zone. So the teen years. That's how I remember this one. It's between age 11 and 18, right? So the teens. That's the margin to be a teen. Okay. So it's associated with chronic inflammation, for example, Sjogren syndrome, chronic gastritis, and mild lymphoma may regress, but may regress with H. pylori eradication. Okay, so marginal zone, the margins to be a teen is 11 to 18. Okay, and we know what 18 is. That's BCL2, right? So it's between BCL2 and cyclin D1, because cyclin D1 is 11. So cyclin D1, 11, and then 18 is be clever and live to 2. Okay. The one where it's between 2, be clever and lives, it's gonna be 0 apoptosis. It's gonna get big and fat and large B cells. So that's diffuse B cell lymphoma. Okay. So done with that. Primary central nervous system lymphoma, adults. Epstein-Barr virus related, associated with HIV and AIDS. Okay. This one, they don't really test you on this one. They usually test you on these. from Burkitt's to marginal. But primary central nervous system lymphoma, adults, Epstein-Barr virus related associated with HIV and AIDS, is considered an AIDS-defining illness. Variable presentation, confusion, memory loss, seizures, CNS mass, often single ring-enhancing lesion on MRI. Okay. In immunocompromised patients, need to be distinguished from toxoplasmosis via CSF analysis or other labs. Okay. That shouldn't be a problem because remember, toxoplasmosis has actual rings in it. This doesn't really look like a ring. Okay. So that right there. See right there. Okay, I guess that does look like a ring. But this is going to be just a single one, okay? That's how you know that it's CNS lymphoma. Because in toxo, you'll have multiple. Okay, so that's one. And like you have some stuff here too. It's usually multiple. When they show it, there's like 1 and 2 and 3 like there as well. But yeah, I can see why it's the same. Usually they save this for toxoplasmosis. Okay. So if you see this, it's going to be toxoplasmosis. Unless they tell you that, it was negative for toxoplasmosis. Gandhi, right? So it's negative for that. So then you think of it this way. Okay, anyways. So you distinguish it via CSF analysis and other labs. Okay, so in CSF for toxoplasmosis, what do you get? You'll get increase in, you'll get increase in neutrophils, right? Let me see. There you go. So nope. It's a protozoa, so that's going to be eosinophils. Right. So serology, biopsy, treatment. They haven't given what the thing is going to be. But the history or the question stem is gonna pretty much clear it up. They're not gonna make you diagnose this just from the scan, so it should be easier after that. Okay, it is EBV related. So the main thing is you gotta differentiate between these. That's what the hard part is. Okay, now for Burkitt's lymphoma, it's gonna be a jaw lesion, something like this, and it's gonna be someone who is from or visited Africa. For translocation is between the ages of 8 and 14, right? So since it happens only in adolescents and young adults. Then you have mutation in BCL2 and BCL6. That's going to be, it prevents apoptosis, so B cell is going to get big and large, and you get diffuse. For this one, you need to know what this histiocytes look like, okay? And then follicles with diameters 14 and 18. Between 14, which is heavy chain, and 18, which is BCL2. It has the vexing and waning lymphadenopathy. That's important. That's the buzzword. Right. So when it's 18, it's small. It doesn't pain. When it's 14, it doesn't hurt, and then when it's 18, it hurts. So waxing and waning like that. Then mental has men in it, so it happens in men more common, and 11 to 14, you gotta remember that. How are we gonna remember that? Okay, 1, 1, and 1, 4. It has 3 ones in it. That's not gonna work because that's your 2. Okay. Just remember that somehow. Okay. 11 is cyclin D1 and 14 heavy chain immunoglobulins. Then you have margins, because margin of being a teen is 11 to 18. So that's the translocation. It's associated with mouth lymphoma, but it regresses with H. pylori eradication. And then you have primary central nervous system. It's associated with Epstein-Barr virus, and you have to distinguish it from toxoplasmosis. Okay. Then you have neoplasms of mature T cells. You have adult T cell lymphoma and mycosis fungioids. So adult T cell lymphoma, again retrovirus, right? So it's caused by HTLV, associated with IV drug use as well. Adults present with cutaneous lesions, common in Japan. So T cell in Tokyo. West Africa and Caribbeans, lytic bone lesions, hypercalcemia. Okay, so this one's gonna be someone from Japan or West Africa or the Caribbeans. Right. They'll have lytic bone lesions and hypercalcemia. And then you have mucosis fungioids. They might just give you a photo, something like this, and then you have to figure it out from that it's this. Mycosis fungioids is skin patches and plaques. Cutaneous T cell lymphoma, characterized by atypical CD4 cells with cerebriform nuclei and intraepidermal neoplastic cell aggregates. Portier microabscess may progress to Sézary syndrome, T cell leukemia. For this, they usually just give you the photo and then ask you something from here. This one, I haven't came across a question for this. Neither for this. However, they have asked a lot of these questions. Okay. Multiple myeloma, so plasma cell disorders. Characterized by monoclonal immunoglobulin paraprotein overproduction due to plasma cell disorders. Okay, so basically plasma cell increase in that, overproduction of that. So labs are going to be serum protein electrophoresis or free light chain assay for initial tests. There will be M spike, and that's usually what they tell you, that there is an M spike. Okay, so M spike on SPP represents overproduction of monoclonal immunoglobulin fragments. Okay, so M spike is going to be over one of them, and then it's going to be that one. For urine analysis, use 24-hour urine protein electrophoresis to detect light chains, as routine urine dipstick detects only albumin. Okay, so if they tell you that there was M spike or something, and then, or like they detected globins, I wonder how they asked that. So they'll say they detected globins or some kind of protein actually. Okay, so they say they detected proteins, and then when they did the urine dipstick, they didn't find any. So it's not albumin that they're detecting globins, right? You confirm with bone marrow biopsy. It could be multiple myeloma, it could be Wallstrom macroglobulinemia. Okay.
So multiple myeloma is overproduction of IgG, 55% of the cases, more common than uh, IgA subtype. Clinical feature is CRAB, that's hypercalcemia, increased secretion of cytokines, that's IL-1, TNF alpha, and rankle, and this is the reason, remember, that causes osteoclastic activity, because you have osteoblast and you have osteoclast macrophages, and then you have OPGs. So OPG uh, binds to the osteoblast rank L's, so rank L's over there. But now, since this one has increased our ligands, the OPGs only covers as many as it can, but then there's still going to be some left, right? So then this one is going to attach with rank on the osteoclasts, right? So and then the osteoclast comes here and then binds here, and then the activating signal is going to travel from here to here, right? And then osteoclastic activity happens, and yeah, you get osteoclastic activity increases, so crushing of bone or whatever, right? So when it reabsorbs the bone, what does it release? It releases calcium and phosphate, so you get hypercalcemia because of that, right? And then phosphate gets thrashed by PTH or not. I don't know. They didn't talk about that. They only talk about calcemia, so let's go with that. Increase in secretion of cytokines, for example, IL-1, TNF alpha, and RANKL by malignant plasma cells. So this leads to increase in osteoclast activity. There's renal involvement, right? Because that's the one that reabsorbs calcium or whatever, and gets rid of phosphates. Then you have anemia as well, and bone lytic lesions punched out on X-ray, which causes back pain. So that's what it's gonna look like. Okay. Usually it's gonna be in the back area, in the lumbar region, that they talk about. Okay, so 10%. Bone marrow analysis shows. Oh wait, no. Oh, here, back pain. Peripheral blood smear shows rouleau formation. So the rouleau formation is this. It's stacked like poker chips. Okay. So that's what's actually happening, and we see it like that. So in a diagram, it's gonna look like this. Okay, like that or like that. I mean, in the question. Okay. Like poker chips, they're on top of each other. Okay. RBC stacked like poker chips. During analysis shows Ig light chains on. This is also known as Benz-Jones proteinuria. We'll read about that in renal, but this is important because this is having they call it a cast, I think, or a Bax cast or something like that, and that only happens in multiple myeloma. So if they find this in the question stem, if they say this, or they say and there's like a cast of some kind that's translucent, it's gonna be multiple myeloma with negative urine dipstick. This is important because it could be albumin. So if they don't have this and there's proteinuria, it's because of this. Because there's a lot of light chain immunoglobulins. Bone marrow analysis shows more than 10% monoclonal plasma cells with clock phase chromatin. This is important as well, that you learn how to recognize this from this diagram. These are plasma cells, right? They're monoclonal plasma cells with clock phase chromatin and intracytoplasmic inclusions containing IgG. Complications include increase in infection risk and increase and primary amyloidosis, AL. Just we have looked at it before, but we'll look at it one more time. Right, so that's what multiple myeloma looks like. If you see a photo like that, it's going to be multiple myeloma. For that, we need to know what clock face is. Okay, so it looks like that, but the hour hand should be fatter. So I guess something like that, right? But like bigger. So that's what the clock face chromatin comes from. And intraplasmic cytoplasmic inclusion containing IgG. Okay. Then you have Waldenström macroglobulinemia. This was IgG. If it's instead of IgG, it's IgM, then that's what this is called. Waldenström. It sounds big, right? Big like a big like something out of Thor mythology. Right, Waldenström macroglobulinemia. So it's big. So it's going to involve the biggest immunoglobulin, and the biggest immunoglobulin is IgM. So overproduction of IgM, macroglobulinemia, because IgM is the largest immunoglobulin. Clinical features: peripheral neuropathy. Did I say Thor mythology? I meant Norse. My bad. So Norse mythology. Anyways, clinical features: peripheral neuropathy, no Crab findings. Okay, so Crab is this, so you won't have hypercalcemia or renal involvement or anemia or bone lytic lesions. So, but what you will have is headache or hyperviscosity syndrome. So headache, blurry vision, Raynaud's phenomenon, and retinal hemorrhages. Okay. Where do you find Raynaud's phenomenon? There are two other places you'll find that in. One is CREST, second is autoimmune hemolytic anemia, type IgM, right? I think. Let me make sure. Although you won't be tested on it, but I just want to make sure. Yeah, so it happens in there as well. Okay, so bone marrow analysis shows more than 10% small lymphocytes with intranuclear pseudo inclusions containing IgM. Here it was IgG. So lymphoplasmocystic lymphoma. Complication is thrombosis. Monoclonal gammopathy of undetermined significance. Overproduction of IgG type, usually asymptomatic, no Crab findings. Bone marrow analysis shows less than 10% monoclonal plasma cells. Complication is 1 to 2% risk per year of transitioning to multiple myeloma. And then you have myelodysplastic syndrome. This is important as well. You need to know about this. The duet cells, so that's this thing right here. It's stem cell disorder involving ineffective hematopoiesis. It leads to defects in cell maturation of non-lymphoid lineage. Bone marrow blasts less than 20% versus more than 20% in EML. It's caused by de novo mutations or environmental exposure, for example, radiation, benzene, chemotherapy, risk of transformation to AML, more common in older adults. Okay. So pseudo Pelger-Hewitt anomaly.
It's okay if you don't remember this. You gotta remember this. That's associated with this. Okay, and I guess bone marrow blast less than 20% versus more than 20% in EML. Okay, so myelodysplastic syndrome, you gotta compare it to EML, and you need to know the difference. Is this? Okay, so pseudo-Pelger-Hewitt anomaly, neutrophils with bilobed duet cells. So that's what that is. We'll look at more of those photos. Associated with myelodysplastic syndrome or drugs. Cool. Okay, so like that. So bilobed, 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 bilobed again, and bilobed there as well. Okay, so neutrophils with bilobed nuclei associated with myelodysplastic syndrome or drugs, for example, immunosuppressants. So with Dewitt, you remember Hewitt, and Hewitt is PP Hewitt or pseudo Pelger Hewitt anomaly. Okay,
On to leukemias now. Unregulated growth and differentiation of WBCs in bone marrow. This causes bone marrow failure, which leads to anemia, decrease in RBCs, infections because of decrease in mature WBCs, and hemorrhage because there's decrease in platelets. Right, so leukopenia, thrombopenia, and anemia usually presents with increased circulating WBCs, malignant leukocytes in blood, although some cases present with normal or decrease in WBC. Right, so leukopenia is decrease in mature WBCs, but it could be increase in immature ones. Okay, so yeah, although some cases present with normal to decreased WBCs. So leukemic cell infiltration of liver, spleen, lymph nodes, and skin, leukemia cutis possible. Okay, so there are these many types. So there's CML, AML, and CLL or ALL. Okay. Before we go on to this, let's look at dirty medicine. Right, so this is his video on this. Basically, if it's myeloid leukemia, it's going to be about these cells, and if it's lymphoid leukemia, it's going to be about these cells. Okay, M and L. So L is going to be about the B cell, T cell, natural killer. Myeloid is going to be about your erythrocyte, thrombocytes, and WBCs, leukocytes, right? So you draw a line like this, and then on this side you put the laterals at the lateral sides, or L's on the lateral sides. So okay, let's do that. So lateral and lateral. So here you will put the L's and L over here. So then you have medials over here. So that's going to be your M's and M's. Okay. Then so it's going to be L over here and L over here. So your lymphoids over here and lymphoid over here. And then you have myeloids in the medial side. So M and M here. And then you just remember AC, AC. Okay. So AL, CM, AM, CL. That's how you remember this. Why? Because this is a line that represents the age group. Okay, so this is going to be lymphoid. So lymphocytes are immature because it's acute. Acute means it's a lot of production, right? And since it's a lot of production, your ratio will be skewed, right, for immature to mature. So it's going to be a lot more immature lymphocytes than mature. So that's going to be lymphocyte immature. Myeloids are your neutrophils. So that will be your mature one. Here again, myeloid is neutrophil.
and but it's acute. So acute is going to be immature. So your band cells are, you're going to have band cells, right? So immature neutrophils have band cells or bands, right? So that, and then you have chronic leukemia. So lymphocytes here, uh, they don't make any new ones, but they have old ones and they don't die off. So that's going to be your lymphocyte, mature ones. So if you don't remember anything about them, remember these ages. So if it's approximately 10 years or younger, it's going to be ALL. If it's around 40 years or middle age, it's going to be CML. If it's more than middle age, it's going to be AML. And then if it's more than 80 or 80 plus around there, it's going to be CLL. Okay. The markers for ALL is TDT. Okay. Marker for CML is Philadelphia chromosome, and for AML it's myeloperoxidase or rods. And this is really easy to figure out, and they will give you a photo of that. So we'll look at that. And for this, there's no marker. So this one you figure out by ruling out all these three. So if it's none of these, it's gonna be CLL then. Or you can just remember that if it's around 80 or more. Okay. The treatment for this ALL is cytarabine or Arca-C. For CML, it's imatinib, and for this, it's vitamin A. Okay, vitamin A is the treatment for AML, but not for all the AMLs, only for the PML ones, right? And then for here, you don't have any treatment because treatment's gonna do more harm than the leukemia itself because they are already 80 years old. Okay. So this is what aorods look like. It's just a little crystal right there inside the cytoplasm. And if you see that, it's AML. And the treatment is vitamin A. Normally you don't have to tell them which type it is. Okay. But yeah. So CML can turn into AML. That's there's a 20% chance of that. And yeah, let's go read about it now. Okay. So lymphoid neoplasm. So this is ALL. Let's bring this here. Okay. So most frequently occurs in children, less common in adults, worse prognosis. T-cell ALL can present as mediastinal mass, presents as SVC-like syndrome. It's associated with Down syndrome. This should be easy to remember because T-cell is in thymus, right? And thymus is near the neck. And so it's going to press on the superior vena cava causing obstruction. So you get the SVC-like syndrome. Right? It's associated with Down syndrome. Peripheral blood and bone marrow have increase in lymphoblasts, right? It's L, so that's lymphocytes, and in acute is increase in lymphoblasts, basically immature lymphocytes, right? So that looks like A, like that, but that's not gonna help you. It could. It doesn't help me. TDT, marker of pre-T and pre-B cells, right? So that's the marker that you need to remember. TDT or TNT, like a blast, that causes a blast, right? So marker of pre-T and pre-B cells. CD10 plus, marker of pre-B cells. Okay. So you gotta remember that it's not only TDT, it's also CD10 plus. Okay, so there should be that over here as well. So
CD10, if you see that, it's going to be pre B cells, and if you see TDT, that's going to be T and B cells. And they do test you on this. You will remember this, but then you'll forget this because of this picture. So remember that CD10, it's going to be marker for pre B cells as well. It's the most responsive to therapy. So prognosis is pretty good. May spread to CNS and testes. So if it's a translocation, this happened due to translocation on 1221, then it's a better prognosis. But if it's Philadelphia chromosome, it has a worse prognosis. Okay. So it's usually going to be this one because Philadelphia chromosome, they usually ask for CML. They keep for that question. So remember 12 to 21. That should be easy to remember because it occurs in children, and you can just think of children between 12 to 21. Okay, and better prognosis is for that one. And then you have 9 to 21. It's a more range, so that's bad, right? If there's more range in it, so it has worse prognosis. Also 9 and 22, 9 by 22, you should know that it's Philadelphia chromosome. That's an important translocation because this is the one that they mention in genetics as well. Then you have CLL, right? That's on this side. So CLL, small lymphocystic lymphoma, age 60, more than 60 years. Most common adult leukemia, CD20, 23 positive, and CD5 and B cell lymphoma. Okay, often asymptomatic, progresses slowly. Smudge cells is what you will see. So these are the smudge cells. Okay. We'll look into that too. Okay, smudge cells, where'd it go? There. In peripheral blood smear, autoimmune hemolytic anemia, which leads to an autoimmune hemolytic anemia. Okay. CLL, crushed little lymphocytes. So if it's crushed, it's going to be a smudge, right? So smudge cells are seen in CLL. Richer transformation. That's from CLL or SLL, small lymphocytic lymphoma, into aggressive lymphoma. Most commonly diffuse large B cell lymphoma. Remember that one? It's the one between BCL2 and BCL6, so both alleles are affected, so no apoptosis arises, so B cell becomes fat and large. You get diffuse large B cell lymphoma. Okay. And BCL, B clever and live, BCL as well, B cell lymphoma. Okay, so before we move on, let's go look at what smudge cells are, or what they look like. Okay, crushed lymphocytes. I guess that thing right there. Let's see if it's a better one. Okay, so that is smudge cell. That's a smudge cell. That's a smudge cell. That's a smudge cell, right? Okay, I think that's good enough. Hairy cell leukemia. This is a easy one to remember. If you remember a story about a fly who got trapped in a chest hair. Why? Because trap is for this, and why chest hair? Because it's hairy. And I don't know. I probably heard it somewhere, and now it's stuck in my head. Hairy cell leukemia, adult males. That's why chest hair. Adult males, mature B cell lymphoma. Okay. Cells have filamentous hair-like projections. Uh, this is fuzzy appearing uh, LM on light microscope. Is it? No. Okay, so that's hairy cell leukemia. It's hairy, and it's called hairy because of the projections. Projections of uh, appearing on light microscope. Okay, it's filamentous. Okay, peripheral lymphadenopathy is uncommon. Causes marrow fibrosis. There's a dry tap on aspiration. This is an important thing to remember. There are not that many things that do this dry tap on aspiration, so this is a buzzword for hairy cell leukemia. Okay, if there's marrow fibrosis and you get a dry tap on aspiration, that means when you try to catch something like a biopsy or something, you're not gonna get any. So that's a dry tap. Patients usually present with massive splenomegaly and pancytopenia. Pancytopenia because there is no marrow left; it's all fibrosed. So that's why you have pancytopenia. And whatever was there, it's destroyed in the spleen, right? Because that filters it out, destroyed cells. So now it's filled up and is sequestered, so you get sequestered asplenia. Stains are TRAP or TRAP, tartrate resistant acid phosphatase, like trapped in a hairy situation. I remember it as trapped in a man's chest hair because it's usually found in adult males. So trap stain largely replaced with flow cytometry. It's associated with BRA F mutation. Remember BRA? It's like BRA, what the fuck? So an adult man will say that. Treatment, purine analogs. Remember purine analogs from when we did the biochemistry things between skids and stuff. It was in not sure if I have it here. This just so we can do a recall. Okay, I'll just do it on this. Okay, so we read it. No, this is email. Not that. Oh, yeah, right there. So when we were doing skid, right? So cladribine and pentostatin, they inhibit ADA right there, right? So it prevents formation of inosine from adenosine. Okay, back to this. Okay, so treatment is purine analogs, cladribine and pentostatin. Again, this is important that it stains with TRAP, and it's hairy cell leukemia because it has hair on the cell that are filamentous and it's hair-like projections. Okay. Remember another thing that has projections are like the Burr cells and the spur cells. So don't confuse that with this because that is RBC. This is B cells. Okay. And this is TRAP, and it's associated with BRAF. You get the buzzword dry tap on aspiration because of fibrosis, and not that many things causes pancytopenia. So if you see pancytopenia, you know it's this. If you see a decrease in RBCs, that's gonna be red cell aplasia, right? Or if it's T cell, it's gonna be your thymus. Something wrong with that, like DiGeorge or 22q11 mutation. Uh, if it's thrombocyte problem, that's gonna be increase in bleeding time. If it's B cells, you'll get all of these, or this, Hodgkin's and all that stuff, right? Burkitt's, I mean, or Philadelphia chromosome and all that. So you need to remember how to differentiate between them. So when it comes to pancytopenia, so pancytopenia happens because of this or because of radiation that causes bone marrow fibrosis. Okay. Next, on to myeloid neoplasms. So those are the middle ones. Okay. Acute myeloid leukemia. Let's do chronic before we do acute. So chronic, just like this one, it's associated with Philadelphia chromosome. This one is as well, and it's called APL, not AML. I think I said AM, or did I say APL before too? So AML has a subtype of APL, right? So that's M3 AML. That's what it was known for as before. So wait, I'm confusing myself now. I was talking about this. Sorry. So this one is also associated with Philadelphia chromosome. Okay. So it's not only this. It was not only this, and it's also this, right? And this is what it's known for majority of the time. Peak incidences 45 to 85 years. Okay. Mostly it's going to be around 40 in the question stem. Median age is 64. So I guess follow this one then, rather than this one. So follow this one. So question stem 64. It's defined by the Philadelphia chromosome, translocation between 9 and 22. That's BCR and ABL. And myeloid stem cell proliferation. So wherever you see this, this is called the Philadelphia chromosome. It causes myeloid stem cell proliferation, presents with dysregulated production of mature and maturing granulocytes. For example, neutrophils, metamyelocytes, myelocytes, and basophils. Okay, so there, it's not gonna help you, or it could. Doesn't help me. And splenomegaly may accelerate and transform to AML or ALL. Okay, it could go from that to this, or it can go to this. But this one is usually in a child, so it's usually gonna be this one. And you get blast crisis. So it responds to BCR-ABL tyrosine kinase inhibitors, which is imatinib, right? So remember tyrosine kinase inhibitor. Remember tyrosine kinase, actually, not inhibitor. I think it was in this. Another page that looked like this that I went over. I don't want to go looking for it anymore. But yeah, that's what tyrosine kinase was, and then imatinib. Oh, actually, we did it in endo. I'm looking at the wrong place. There it is. So this is tyrosine kinase, and so it inhibits this right here. And I think there was a photo that goes along with this. Let's have a look at that too, so we can recall. Or not. Okay, I guess we haven't done that one then. Back to this. Okay, so it responds to tyrosine kinase inhibitors for Philadelphia chromosome, which is BCR-ABL. Important thing to remember, it's associated with Philadelphia chromosome and the age. Okay, if the age is not around 64, it's not CMO, so don't worry about that. And especially if it's a child with Philadelphia chromosome, it's going to be ALL. Okay, on to AML. That's this one now. Right. Yeah. So median onset is 65 years. You'll have aerods, and this is uh, the important thing. If they give you this, it's AML. You don't have to worry about anything else. If you see these lines, it's AML. Save some time, click it, and then just move on. Myeloperoxidase positive cytoplasmic inclusions. That's what it is. They might give you a photo. If they don't give you the photo, they'll just say it's myeloperoxidase positive cytoplasmic inclusions. Okay, that's what they are. They are on cytoplasm and they're myeloperoxidase, made of myeloperoxidase. Okay, so myeloperoxidase or MPO positive cytoplasmic inclusions seen mostly in APL, formerly M3 AML. There's increase in circulating myeloblasts on peripheral smear, may present with leukocytosis. That's increase in leukocytes. Capillary occlusion by malignant non-distensible cells leads to organ damage. Risk factors is prior exposure to alkylating chemotherapy, radiation, benzene, myeloproliferative disorders, Down syndrome, typically acute megakaryoblast leukemia, formerly M7 AML, APL, translocation 15/17. So 15/17, if you see that, it's APL. Okay, that's what it is. The myeloperoxidase one, or APL. You need to know this because they give you this instead of giving you any other clues. They tell you that there's a translocation between 15 and 17 that causes APL. Okay. I would just, after we're done, just write down all the translocation on a page and then try to see which one it lines up with, or from memory just write down the disease name beside it. Okay, so 15/17 is APL. It responds to all trans-retinoic acid, vitamin A, and arsenic trioxide, which induce differentiation of promyelocytes. DIC is a common presentation. Okay. They don't give you that in a question stem. What they will give you is either this or the rods. Okay. Okay, so let's wrap it up now. I'll get rid of this. If it's ALL, it's on the laterals and it's in the beginning, so it's usually the children that have these. There are two markers. There's TDT plus or positive, or CD10 positive. If it's TDT plus, that's T cell and B cells. If it's just CD10, it's only pre-B cells. Okay. There's a translocation between 12 to 21. Then it's going to be ALL with better prognosis. If it's Philadelphia chromosome in a child with TDT marker. Remember TDT, TNT, right? So TNT is like a blast, what they used to blast stuff. At least that's what I learned from cartoons back then. So TDT is a blast, so T cell blast or B cell blast. Right? So yeah, and then Philadelphia is worse, 922 in a child. Okay, then there's CLL. So this is also on the lateral side, but the other side of the spectrum. So it happens in patients above the age of 60, or usually they're like above 70. Most common adult leukemia, right? It has CD20, 23, 5 positive B cell neoplasms. Okay, and it doesn't have a treatment because they're already, aged. So rather, the treatment is going to be worse than this cancer or leukemia. Sorry. There's crushed little lymphocytes or smudge cells. So smudge cells are in that. You can think of a old person with a cane stepping on cells with the cane, right? So it's gonna smudge it. Okay. Uh, see most commonly. So it's associated with this one, B cell lymphoma. Then we talked about hairy cell leukemia. Uh, a man with a hairy chest uh, has a fly trapped in it. So TRAP is for tartrate resistant acid phosphatase, right? It's a man, so it happens usually in adult males. Uh, and chest hair, so hair is for hairy cell leukemia. It has projection, hair-like projections from it, and that's literally how they're gonna talk about it. That there's some kind of fuzz on top, outside of the cell, or on the surface of the cell. It's it doesn't have peripheral lymphadenopathy, right? But what they will say is that there was dry tap on aspiration. Okay, that's the buzzword for uh, hairy cell leukemia. Okay, since it's myelofibrosis, you have pancytosis, cytopenia as well. And then we talked about CML, right? That's the second one. So, median age is 64. It's defined by Philadelphia chromosome 922, PCR, ABL, and it's inhibited by the tyrosine kinase inhibitor imitinib, or tinib, sorry. Uh, Proxamature, and yeah, that's it. And then you have this. So the marker is this, and the age that will give it away that it's myeloid leukemia. Also, what else tells you is they'll give you like whether uh, the increase in cells are myeloid stem cells from myeloid, like precursors of myeloid, or the precursor is myeloid or lymphoid, right? So if it's myeloid, it's going to be neutrophils increase, right? But if it's lymphoid, then it's going to be your B and T cells that are increased. Okay, so that will also help you zone into which one it is out of the four options. So you, if they tell you it's neutrophils increase and with Ben cells, at least you can the at most you can just cross out anything that's lymphoid related, right? Because it's not going to be that, and the middle ones are anyways myeloid cells, and the lymphoids are on the left lateral side of the spectrum. Okay. So we talked about that. Now, the last one we did was AML. AML, also known as EPL, that's the one we can treat with vitamin A. Translocation for that was 15/17. That's the most important thing you need to remember, and that you treated with vitamin A. You'll see aerorods, right, which are myeloperoxidase sticks in the cytoplasm, or MPO sticks in the cytoplasm, that are called aerorods. So they'll say that it's myeloperoxidase positive cells. So then that should also tell you that it's aerorods, and that's AML. And yeah, moving on to myeloproliferative neoplasm. Malignant hematopoietic neoplasms with varying impacts on WBCs and myeloid cell lines. Okay, so now we're going to talk about other ones that other than the ones we talked about. So myeloproliferative neoplasm, that means myeloid cells and proliferation of them, right? So increased myeloid cells proliferation. This is malignant hematopoietic neoplasms with varying impacts on WBCs and myeloid cell lines. Okay. Polycythemia vera. Just like iron, or hemochromatosis or whatever, you do phlebotomy here as well because you have increase in that. So I remember these by thinking about which ones would be good, which patients would make a good muse for a vampire. So a vampire can, have a muse who has polycythemia vera, because then it's like a mutual benefit right there. Okay, so this is one of them too. Another one was hemochromatosis, and there was another one as well we just went over. Actually, all you have to do is see which ones require this. Okay, so let's do that. This is just so we can do a recall to all the ones that require that. Right, so this was one. Porphyria cutanea tarda. That's the vampire one. Then it's this one, polycythemia vera. Iron poisoning. And hemochromatosis. Okay. Cool. Back to this. I think I'm getting distracted too much. Okay. Polycythemia vera. Primary polycythemia, disorder of increase in RBCs, usually due to acquired JAK2 mutation. Remember JAK2? We looked at that. May present as intense itching after shower. That's a buzzword. If there's intense itching after shower, that's what polycythemia vera is. So, buzzword. It's called echogenic pruritus. Its rare but classic symptom is erythromelalgia. That's severe burning pain and red-blue coloration. Okay. Severe burning pain and red-blue coloration due to episodic blood clots in the vessels of the extremities. Okay. Associated with hyperviscosity and thrombosis. For example, PE, that's pulmonary embolism or deep venous thrombosis, or Burke-Chiari syndrome. There is Burke-Chiari syndrome is the one where there is no JVD, right? So decrease in EPO versus, so there's decrease in EPO when you have polycythemia vera because you don't need more cells, so there will be no erythropoietin. Increase or normal, it's going to decrease. Versus secondary polycythemia, which is present with endogenous or artificially increased EPO, because if we supply EPO, I think it's like alpha erythro alpha or something like that for this. So if we supply that, it doesn't get regulated right by the kidney, because it's, even if we have enough EPO red blood cells, this doesn't decrease from the cell until it gets half-lifed out or excreted out or something. Treatment is phlebotomy, hydroxyurea, and ruxolitinib. That's JAK1/2 inhibitor. Then we have essential thrombocythemia. It's characterized by massive proliferation of megakaryocytes and platelets. Symptoms include bleeding and thrombosis. Blood smear shows markedly increased number of platelets, which may be large or otherwise abnormally formed. Okay, so like that. Erythromelalgia may occur. Okay, that's easy one to remember. It's just increased amounts of platelets, so megakaryocytes and platelets. Symptoms include bleeding and thrombosis. And blood smear shows markedly increased number of platelets, which may be large or otherwise abnormally formed. Then you have myelofibrosis. So this is similar to the dry tap one, but they won't use that for this. Atypical megakaryocyte hyperplasia. So there's increase in TGF beta secretion. This was anti-inflammatory, right? There's increase in fibroblast activity, obliteration of bone marrow with fibrosis. You need to know what this picture looks like because that's what they will use for myelofibrosis. They'll give you a picture of this. Not a picture of that. I guess something like this. Okay, and so you'll figure out that it's fibrosis, and they were talking about uh, decreased activity of the cells that are formed there. Okay, so obliteration of bone marrow with fibrosis, that associated with massive splenomegaly, right? Teardrop RBCs, we know what that looks like. And bone marrow cries because it's fibrosed and is a dry tap. If you have a dry tap, you know marrow is fibrosed, and then you just go from there. Okay. Okay. RBCs, WBCs, platelets, Philadelphia chromosome, and this. Let's put in a box. And we'll try to see if we can get them. Okay. So polycythemia vera, we know that's increase in RBCs. Essential thrombocythemia. It doesn't affect the platelets, right? Myelofibrosis, no, it's decreased. CML, chronic myeloid leukemia. So that's the Philadelphia chromosome one, and it causes myeloid leukemia. It could, I guess. No, it's not. Okay. See, just stick to what we know about CML. Don't try to overthink it. WBCs, it doesn't affect that, so it's going to be. Oh, it does. Okay. It's increased in polycythemia. Essential thrombocythemia, it doesn't affect that. Right, myelofibrosis decreased, or it's variable. Okay. And CML, no. Oh, wait. Yeah, ML. That's myeloid, so it increases this. I rushed into that one. Okay. Platelets, polycythemia vera doesn't affect platelets. It does. Okay, so it's increasing everything. Did I not pay attention to this? They only talked about EPO and this, but apparently it's everything, okay? Essential thrombocythemia, that's going to be increased. Myelofibrosis, not really variable. And CML, no. Oh, it is. So CML for this. Oh yeah, it is part of WBC. Okay. Philadelphia chromosome. You'll find it positive in this one. You won't find it here or here or here. Right? Yeah. Okay. JEXTAT2 mutation, that's only for polycythemia vera, right? We read that here, and not here, not here, and not here. Okay, I was wrong. It's for polycythemia vera, essential thrombocythemia as well, and myelofibrosis as well, 30 to 50%, but not here. Okay, go over that one more time so you remember it. Let's do it one more time now that we know about it, so we can retain it. So polycythemia vera increases RBC, WBC, platelets. It is It doesn't have Philadelphia chromosome, but it does have JAK2 mutation. Essential thrombocythemia, uh, D- RBCs, it doesn't affect it. WBC increases. No, it doesn't increase that either. So it's platelets is going to increase it. Philadelphia chromosome negative, JAK2 positive. Myelofibrosis, RBCs are going to be decreased, I guess. This was variable. This was variable. No Philadelphia chromosome and JAK2 positive. Right. And then you have CML and chronic myeloid leukemia. This is going to be decreased, but this is increased. This is increased. This is positive, and JAK2 is negative. Okay, so the ones you have positive for this, you will have negative for this, and vice versa. Okay. There's something called leukemoid reaction, and that has a similar presentation as CML, or chronic myelogenous leukemia. So leukemoid reaction and CML. Uh, Definition is reactive neutrophilia, so more than 50,000 cells. Neutrophil morphology is that it has a Dolly body, toxic granulation, and cytoplasmic vacuoles. LAP score is increased, and eosinophil and basophil is normal. Over here in chronic myeloid leukemia, you have myeloproliferative neoplasm positive for BCR, ABO. Neutrophil will have Dewitt cells, or PPH, or pseudo Pelger Hewitt anomaly. Lab score is going to be decreased. That's LAP enzyme decreases in malignant neutrophils. And then you have eosinophils and basophils. So it increases in CML. Because we saw WBC's increase in CML, right? Remember the morphology for this. You'll see Dolly bodies. Okay. Look at what that is. Okay, we read it over here. We read about the LAP as well. LAP is leukocyte alkaline phosphatase. Okay, that increases in this, but decreases in CML. Okay, because you need a mature cell. I mean, immature cell, I guess. By the time it's matured, it decreases it. Okay. And Dolly bodies, these are light blue. Remember, light blue ones. Peripheral inclusions. Okay. Polycythemia. So they have translocations here. We'll do that too with this. So let's not have a look at that yet. And we'll do one more over here. So we'll try to answer these again, and so we can retain it this way. We don't need that. Okay. I think I have 10 minutes left. Okay, we'll finish polycythemia. So relative, polycythemia relative. That just means when that again, same thing. If this was serum level, and this is this so if it's this many compared to this serum, this seems like it's low, right? But then when the serum itself is low, it's gonna be this. This seems like it's concentrated now, right? However, it's still polycythemia, right? But it just seems like it's it's still normal, but it seems like it's polycythemia because the serum is low and the RBCs are increased compared to the amount of serum. But if this was this normal serum, it's still the same amount, right? So that's what relative means. So plasma volume is decreased, RBC mass is gonna stay the same, I guess. O2 saturation is the same. EPO level is gonna be the same, I think. I don't know. So plasma volume is decreased, RBC mass is not gonna change, it's the same. O2 is the same, EPO level is the same, right? So only thing that happens is this goes down. Okay. Dehydration and burns. That's what that. That's what that's what causes relative polycythemia. Then if you have so there's something about called appropriate absolute polycythemia, where plasma volume increases, RBC mass increases, O2 saturation increases, EPO level decreases. Okay, plasma volume stays the same. I was wrong. RBC mass increases, O2 saturation decreases. Okay. Oh, okay. So it's because of this that this happens. Because you have low oxygen saturation, that causes appropriate absolute polycythemia. So in things like when you're up on a hill or something, high altitude, where there's low oxygen saturation. So if you stay there for a while, after you come back and you check your blood, you're gonna have polycythemia. So it's called appropriate polycythemia. It's physiological. EPO levels will increase then, right? Yeah. So it's associated with lung disease, because if you have lung disease, that means the gas exchange is decreased. So to overcome that, you have more blood cells to do gas exchange from the parts that are doing it, that are functional. So lung disease, congenital heart disease, high altitude, obstructive sleep apnea, right? We know this one increases EPO, so that should hint towards polycythemia. Okay, RBC mass increases because it wants to carry as much oxygen as it can, so that's why it gets fatter or increases storage. Then there's inappropriate absolute polycythemia. This is when there's a problem with EPO, I think. Plasma volume is gonna stay the same. RBC mass, what's gonna happen to that? Stays, increases. Yeah, increases. O2 saturation is gonna increase, or okay, it's staying the same. Okay, so it's gonna stay at 100%. That's why it's the same. And then EPO is the reason for this increase. So exogenous EPO, athletes misuse this, also called blood doping, androgen supplementation, inappropriate EPO secretion. So blood doping causes increased amount of oxygen supplied to the mitochondria, and if you have that, you have less lactic acid buildup when you're doing athlete stuff. Okay, so that's why they do that. Androgen supplementation, inappropriate EPO secretion. This is a malignancy, for example, RCC, because kidneys secrete EPO, or hepatocellular carcinoma. Sometimes when kidneys can't do it, liver does have capability of secreting EPO, so that's why in HCC there could be inappropriate EPO secretion. Then you have the polycythemia vera. Okay, blood volume is going to stay the same. Nope, it's increasing. Yeah, this is what I remembered. So it increases in this, and I said it increases in this, but it increases in this. Not this, sorry. Somewhere I said. I think it was in my head. So anyways, blood volume increases in polycythemia vera. The RBC mass increases a lot. So this is the reason why this happens. O2 saturation, okay, it stays the same, and EPO level is going to decrease, right? EPO decrease in PCV, polycythemia vera, due to negative feedback suppressing renal EPO production. Okay, translocation 8 to 18, that's kids age, Burkitt's. Burkitt's was translocation between sea mice, and 18 was, what was 18? Not 18, sorry, 14. 14 was why am I skipping all this? 14 was light chain, heavy chain, IgG, was it? Yeah, so IgG, heavy chain genes on chromosome 14. Okay, then you have T11 and 14, that's mental. Yeah, mental. And mental was, uh, yeah, this 11 to 14. Cycline, right? 11, 1 1 is 11, that's cycline D1. And 14 was again heavy chain. Then you have 11 18, that's the, how much time do I have? 3 minutes. Okay, I think we can go through this. 11 18 was margin for teens, so marginal zone lymphoma. 14 and 18, that's heavy chain, and 18 was what? Okay. Oh, this one is the 15 17 is the APL. 14 and 18 is not coming to me right now. So let's go to this Philadelphia chromosome, that's in CML, but it could be in ALL too, right? CML, ALL. Okay, so this was follicular, right? 14 diameter and 18 diameter is that. The immunoglobulin heavy chain gene on chromosome 14 are constitutively expressed when other genes, for example C-mice and BCL2, are translocated next to this heavy chain gene region. They are overexpressed. 2 minutes. Let's talk about that. So, the immunoglobulin heavy chain gene on chromosome 14 are constitutively expressed when other genes like C-mice or BCL2 are translocated next to this heavy chain gene. They are overexpressed. So whatever's attached to this, they're going to get overexpressed. Okay, and that's how you end up with diffuse large B cell lymphoma because of that. And for C mice, it's this one, Burkitt's lymphoma. That's why you have the whole buildup in your neck. Okay, that's it for now. And cell histiocytosis. This is what you will see in the electron microscope. Under the electron microscope, a tennis racket. And if you see that, it's Langer cell. These are the macrophages of the skin, I think. Collective group of proliferative disorders of Langerhans cells. These are antigen presenting cells normally found in the skin. Yeah. Presents in a child as lytic bone lesions. For example, this one right there, and skin rash, or as recurrent otitis media with a mass involving the mastoid bone. Cells are functionally immature and do not effectively stimulate primary T cells via the antigen presentation. Cells express S100. This is the important one. So this is the marker for it. So cells express S100 and CD1A. So these are the markers for Langerhans cells. You'll see Burbeck granules, tennis racket or rod shaped on electron microscope, and there are characteristics characteristic of this. Okay, so Burbeck granules, they look like tennis rackets. Then tumor lysis syndrome. This is an important concept as well. Why? Because when there's tumor lysis, when you give them treatment for this and all that stuff, tumor's gonna lyse, and when it lyses, it's gonna release potassium, so you'll go into hyperkalemia state. It's gonna increase phosphate, so hyperphosphatemia as well, and increase in uric acid. So then you have chances of gout and all that stuff, right? So uric acid crystals will lead to acute kidney injury. The phosphate will cause calcium phosphate crystals. This will also cause acute kidney injury. Since there is increase in phosphate, there will be decrease in calcium. Why? We'll read about that here. And increase in potassium causes muscle weakness and arrhythmias. All right, and ECG changes. Okay, so oncology emergency triggered by massive tumor cell lysis, seen most often with lymphomas and leukemias, usually caused by treatment initiation, but can occur spontaneously with fast growing cancers as well. Release of potassium will cause hyperkalemia, release of phosphate will cause hyperphosphatemia. So if they give you a lab result of in a question stem and you see that there's increase in potassium, increase in phosphate, and decrease in calcium, uh, and they're going under some kind of treatment, it's because of this. Okay. So it's hypocalcemia due to calcium sequestration by phosphates. Okay. Okay, because they're combining with calcium right here to cause the crystals, and that's causing acute kidney damage. Increase in nucleic acid breakdown will cause hyperuricemia, causing acute kidney injury. Prevention and treatment include aggressive hydration, allopurinol, and raspberry case. Remember this one? We looked at that when right under the xanthase oxidase, right? So xanthine oxidase is right here, so it prevents formation of uric acid. And if it becomes uric acid, you give raspberry case to make allantoin then. So we don't want uric acid, but if we do have uric acid, we can give this to get it to turn into allantoin, or we can just inhibit the formation of it with allopurinol or fiboxazat, because it inhibits xanthine oxidase. Okay. Done with that. On to pharmacology. Heparin. That's an anticoagulant, right? Okay. So there are two types, right? One is heparin by itself, and another one is low molecular weight heparin. Okay. So we're going to talk about both of them. So mechanism of heparin, it activates antithrombin, which decreases. Remember that little diagram we looked at up here? This thing. Right, so heparin attaches to the antithrombin, and then that inhibits the thrombin, right? So it activates antithrombin, which decreases action primarily of factor 2A. Okay, that's what thrombin is, right? 2A and 10A as well. Short half-life. Clinical use is immediate, so it has a short half-life, this heparin. Okay, that's why we use it to bridge between when we are doing therapy with warfarin. So clinical use: immediate anticoagulation for pulmonary embolism, acute coronary syndrome. So we use that for this to break it down, and it's pretty quick. Acute coronary syndrome and myocardial infarction, deep vein thrombosis as well. It's used during pregnancy because it does not cross placenta. This is the main benefit of it. That heparin doesn't cross the placenta, and its low molecular weight does cross it. So give this instead of those. Okay, you monitor PTT for this. Okay, so this is plate table tennis. These are the intrinsic factors, right? Thrombin is intrinsic and common pathway. Adverse effect is bleeding. Reverse with protamine sulfate. This is the antidote for heparin. Protamine sulfate, very important. Remember that. Heparin induced thrombocytopenia. This is HIT. It's osteoporosis with long-term use. Drug-drug interaction. And type 4 renal tubular acidosis. There's this HIT. We're going to learn about that now. So HIT 1 and 2. HIT type 1 is mild. Platelets are more than 100,000. Right? Normally it's like around 150 to 400, I think, thousand. So transient non-immunologic drop in platelet count that typically occurs within the first 2 days of heparin administration, not clinically significant. Okay. HIT type 2, development of IgG antibodies against heparin bound platelet factor 4. That typically occurs 5 to 10 days after heparin administration. Okay, so IgG antibodies against heparin bound platelet factor 4. That. Okay. Antibody heparin PF4 complex binds and activates platelets. This causes removal by splenic macrophages and thrombosis. So that's how you have decrease in platelet count. Because once you have antibodies attached to heparin is going to be attached to. This thing is going to activate platelets, and then platelets are going to get eaten up by the macrophages. So that decreases platelet count. Highest risk with unfractioned heparin. So treatment is discontinue heparin, start alternative anticoagulant like egratroban. Right, tro was for thrombin, so you can think of it that way. Fondaparinux, safe to use, does not interact with PF4. Okay, so for HIT, this is important. Let's see if there's a diagram. You have PF4 platelets, they get bound to this, then it triggers the B cells, then they have IgG against the PF4 heparin that attaches to the platelets again, right, and then it consumes the platelets, so that causes platelet aggregation, microparticles, thrombosis, and that leads to thrombocytopenia. There's another one here. This one. Okay, PF4 plus heparin coming off of the platelet. Then with the platelet and this IgG, anti-PF4 antibody sensitive, comes together, aggregates, and then you have suspected hit for T scores. We don't need to worry about that. Okay. So with type 1, it was transient non-immunologic drop-in. So there's no immune component in this. Okay, that typically occurs within this 2 days of heparin administration. Notes: low molecular weight heparin, for example, enoxaparin, dalteparin, act mainly on factor 10A. Okay. This is important. We looked at that too up there. Right, so fondaparinux, it acts directly on 10A. So low molecular weight heparin, enoxaparin, right there, enoxaparin and dalteparin act mainly on factor 10A. Fondaparinux acts only on factor 10A. Okay, important. They have this over here too, but majority of time it acts on this instead of this. Both are not easily reversible. Unfractioned heparin used in patients with renal insufficiency. Low molecular weight heparin should be used with caution because they undergo renal clearance. So it should be used. Used in patients with this. Okay, so in renal insufficiency, you use unfractionated heparin, because with low molecular one it gets renal clearance. So if you don't have kidneys working, you'll have buildup of that or and toxicity. Okay, on to warfarin. What does warfarin do? We know it inhibits vitamin K epoxide reductase by competing with vitamin K. Inhibition of vitamin K dependent gamma carboxylation of clotting factor 10 clotting factors 2, 7, 9 and 10 and protein C and S. Metabolism affected by polymorphism in the gene for vitamin K epoxide reductase complex. That's a long ass name that I'm not going to remember. In laboratory assay has effect on extrinsic pathway and increases PT. Okay, because of factor 7. Long half-life. Okay, so this thing has a long half-life. So basically this thing is gonna prevent formation of this or synthesis of this, right? So whatever is left over now after starting this in the body, that's all the body is going to use. So while it uses those up, the half-life also has its effect on them, right? So the half-life for this is the shortest, right? So factor 7, and the longest is 2. So factor 2 will outlive all the other factors, and this is still a clotting factor, right? That's prothrombin, and activated this is thrombin. So that will cause coagulation, and there is no protein CNS to regulate it, right? So that's why you get the adverse effect that we'll talk about. Clinical use is chronic anticoagulation, for example, venous thromboembolism, prophylaxis and prevention of stroke and atrial fibrillation. That's what we use it for. But for this, you have to make sure that it's not, it is because of a thrombus and not some kind of hemorrhage that this happened. Because if it's hemorrhage, then it's gonna be, you're making it worse. Because now, even if something is trying to plug the leakage, warfarin is gonna prevent that from happening. Or if there is already leakage happening and that got clotted, warfarin is gonna reopen those wounds and cause bleeding again. Okay, so you gotta be sure about that. Then stroke and arterial fibrillation, right? Not used in pregnant patients because warfarin, unlike heparin, crosses placenta. You monitor PT and INR for warfarin. Okay. You play war. You have war outdoors, right? It's outdoors, so extrinsic. That's why you do PT. And heparin, that's inside, so that's why it's you monitor PTT for heparin. Because hippies like to stay inside, right? They like to stay inside and smoke, so you play table tennis inside as well. So that's intrinsic. And you have war outside, so extrinsic, so you monitor PT for warfarin. Okay, and INR as well, because it's an international war. Adverse effect is bleeding, teratogenic effects, skin tissue necrosis, drug-drug interactions metabolized by cytochrome P450, CYP2C9. Initial risk of hypercoagulation. Why? Because protein C has a shorter half-life than the factor 2 and 10. Existing protein C depletes before existing factors 10 and 2 deplete, and before warfarin can reduce factors 2 and 10 production, it leads to hypercoagulation. Okay, so this is way better explained than I was explaining it, although I butchered the reading that, but basically you should have the idea of this and not forget that if you see something like this and the person is going through some kind of anticoagulation therapy, it's usually going to be warfarin. And if you start seeing these happening, it's because of this effect. So, skin tissue necrosis within the first few days of large dose believed to be due to small vessel microthrombosis. Okay, so how do we prevent that? It's called heparin bridging. Heparin frequently used when starting warfarin. Heparin's activation of antithrombin enables anticoagulation during initial transient hypercoagulable state caused by warfarin. Initial heparin therapy reduces risk of recurrent venous thromboembolism and skin tissue necrosis. For reversal of warfarin, give vitamin K. For rapid reversal, we give FFP or PCC. Okay, for immediate relief, we give this. Okay, remember that this is what we give. We don't give vitamin K, because normally when you need to give something, it's going to be something in emergency condition. So FFP and PCC is what you remember. This is for delayed effect. It has a delayed effect, so recovery, it's going to be a slow recovery with this one, but this is going to be immediate. So remember FFP and PCC. Okay, heparin versus warfarin. So we'll look at the differences and similarities. Route of administration: heparin is parenteral, IV or subcutaneous. Site of action is blood. Onset of action is rapid, rapid in seconds basically. Duration of action is for hours. Monitoring: hippies love inside, so intrinsic, so PTT. It crosses placenta, no. For warfarin, it's oral instead of parenteral. Site of action is liver instead of blood. Onset of action is slow, limited by half-lives of normal clotting factors. Instead of rapid. Duration of action is days, whereas this was hours. Monitoring, PT, because you fight the war outdoors, which is extrinsic, so PT, and international war, so INR. It does cross placenta, so it's considered teratogenic. Okay, now direct coagulation factor inhibitors. Okay, so drug mechanism, clinical use, and adverse effects. We have bivalirudin, agratroben, and dabigatran. Right, so with this one, it bans thrombin. Right, so there's tro in it, so that's for thrombin. There's TR in this, so and AN, so again this also bans thrombin, and then thrombin is rude, I guess. I don't know. But remember that these ones, usually it's this one that shows up, agratroben. So it bans thrombin. Thrombin is factor 2A, right? Factor 2 is prothrombin. So directly inhibits thrombin, activated factor 2. Clinical use is venous thromboembolism, arterial fibrillation, can be used in HIT when heparin is bad for the patient. Let me bring the diagram again. So 2A, that's these ones, right? That act on thrombin. So direct thrombin inhibitor, agratroben, bivalirudin, and dabigatran. So when do you use this? It's when you can't use heparin or in HIT, right? And also for venous thromboembolism or atrial fibrillation. Adverse effects are bleeding. Reverse dabigatran with idarucizumab, and dabigatran is the only oral agent in class. Do not require that monitoring. Then you have XA, so XA inhibitors, epixaban, endoxaban, and rivaroxaban. So that's these. Directly inhibits factor 10A. treatment and prophylaxis for DVT and PE, stroke prophylaxis in patients with atrial fibrillation. Okay, bleeding reversed with andexanet alpha, oral agents that do not usually require lab monitoring. This is usually the one that shows up, epexaben. And then there's anticoagulation reversal. So now the antidotes. So for heparin, we know it's prudamine sulfate. For warfarin, we know it's FFP and PCC for rapid, and then vitamin K for slow. For dabigatran, it's adarucizumab, and direct factor 10A inhibitor is andexanet alpha. This is an important one. Because I don't remember this and I get the question wrong every time. But it has XA in it. Right. The notes for heparin is that it's positively charged peptide that binds negatively charged heparin, prudamine sulfate. For this one, it's monoclonal antibody Fab fragment, right? AB, there's MAB in it, so that's antibody, right? Adenex alpha, Adenexet or net alpha, that's recombinant modified factor 10A inactive. The ones you need to know about is heparin and warfarin. But remember, if there's big, then you eat the I don't know, that's how I remember it. You figure out how you're gonna remember it. Okay. Antiplatelet all work by decreasing platelet aggregation. So you have aspirin. This irreversibly. So remember the platelet one. Let's bring that one too. Okay, so aspirin irreversibly blocks COX, right? So that's this bit right here. So making of thromboxane E2. So irreversibly blocks COX, which leads to decrease in thromboxane E2 release. Okay, thromboxane is known to cause thrombosis or it's involved in making clots. Right? Acute coronary syndrome, coronary stenting, a decrease in incidence or recurrence of thrombotic stroke. That's what it's known for. Adverse effect is gastric ulcer. That's the main thing about this. Remember, it caused peptic ulcers. Tinnitus, allergic reactions, and renal injury. Clopidogrel, prasugrel, ticagrelor, ticlodipine. I hate that one. Block ADP. It blocks ADP, right? So these ones. And then receptor, ADP receptor. Decrease in ADP induced expression of this GP2B and 3A. So remember that it decreases the expression of this, right? So it blocks this so that it doesn't convert into this, right? Don't confuse this for this, right? Because this one actually blocks the GP2B 3A, right? It actually blocks this. It doesn't block the conversion of this. Okay. So clopidogrel, same as aspirin, dual and clinical uses same as aspirin, dual antiplatelet therapy. Adverse effect is neutropenia because of ticlodipin, and TTP may be seen. Thrombotic, thrombocytopenic purpura. Then you have epcizumab, eptifibatide, tirofiban, block GP2B and 3A. There's fibinet, so that's fibrinogen receptor, right? So these are the fibrinogen receptors because it connects through the fibrinogen. On activated platelets, abscizumab is made from monoclonal antibody fragments. Unstable angina, percutaneous coronary intervention, and adverse effect is bleeding and thrombocytopenia. Okay, celestazole and dipyridamole. These block phosphodiesterases, decrease in CAMP hydrolysis, and increase in CAMP in platelets. It's used for intermittent claudation, stroke prevention, cardiac stress testing, prevention of coronary stent restenosis, nausea, headache, facial flushing, hypertension, abdominal pain. It blocks phosphodiesterases. Okay. Where else have we seen this? I'm just trying to recall it. Right, over here. In Pharmac, it was a platelet inhibitor and increases CAMP inhibition of platelet aggregation. So only due to coronary vasodilation. So celestazole is a PDE3 inhibitor like this, but its indication is that it's used as a platelet inhibitor together with pyrimethamine. That's why it's here. Is a specific PDE inhibitor leading to inhibition of platelet aggregation. It also prevents adenosine reuptake by platelets, increase in extracellular adenosine, which causes vasodilation. Okay. Okay, on to this thrombolytics. Alteplase. So these are all TPAs. Alteplase, reteplase, streptokinase, and tenecteplase. Right? So it converts plasminogen from plasmin to plasmin. TNK TPA. So mechanism is directly or indirectly aid conversion of plasminogen to plasmin, which cleaves thrombin and fibrin clot. There's increase in PT, increase in PTT, no change in platelet count. Because it's part of the, it's not that it's part of it, but it's involved in coagulation cascade, because it breaks it down. So this part right here. Too far. Okay. So adipase, TPA, that's adipase, streptokinase, tenecteplase, right? It directly or indirectly aids conversion of plasminogen to plasmin, which cleaves thrombin and fibrin clots. So that's these, and makes it fibrin degradation into D-dimer. It increases PT and increase in PTT as well. There's no change in platelet count though. Okay, so when there's no change in this. How do you know that? It's because bleeding time is normal, and then you have increase in this and this. So something's wrong with the coagulation cascade. Why? Because the clot is taking a longer time to form. Why? Because even if it's formed, it's getting broken down. So they'll give you increase in D-dimers or something if they were hinting at this. Clinical use is early MI. Oh, see. So we do check for D-dimers in this. Okay. Early ischemic stroke. Because last time when we were reading this, I said MI, and then when we looked it up, it didn't show up, so I thought I was wrong. But we use it for MI, early ischemic stroke, direct thrombolysis of pulmonary edema, embolism, pulmonary embolism. So adverse effect is bleeding, contraindicated in patients with active bleeding, history of intracranial bleeding, recent surgery, known bleeding diathesis, or severe hypertension, non-specific reversal with antifibrinolytics, for example, amino caproic acid and tranexamic acid. Uh, Platelet transfusions and factor corrections, for example, cryoprecipitate, FFP, and PCC. This is what they take during uh, periods. The girls do. For the guys, the girls probably already know about that. Okay. Platelet transfusion and factor correction, for example, cryoprecipitate, FFP, and PCC. And now we're on to cancer therapy. Okay, so cancer therapy cell cycle is this is cell cycle, and then we have each one, all of these drugs acting on each stages of these cell cycles, right? So if it starts from GO, it goes into G1 phase through this, right? This is the gatekeeper, the RB and P53, and then from after it goes through the gatekeeper, it there's elongation factor and all the replication and all that happens, and then we go into synthesis phase. So synthesis happens. After synthesis, there's a proofreading here, right? So double check repair stage, and then it goes through mitosis, and that's where it splits, and then so cytokinesis. What that means is cytoplasm is split into two. That's what cytokinesis means. Okay. So mitosis, our microtubule inhibitors act on that. Okay, so M for M. For now, just remember that, and then we'll go through all of these while we keep this on the side. Okay, so cancer therapy targets. Okay, so cancer therapy targets. Let me make this a little smaller. Nucleotide synthesis. Okay, so that's over here. Not the synthesis. So methotrexate and 5-FU. It decreases thymidine synthesis. You have thiopurines. They decrease de novo purine synthesis, and hydroxyurea, which inhibits ribonucleotide reductase. Then comes the DNA. These ones act directly on the DNA. Okay. So you have bleomycin acting on the DNA strand breakage, right? You have alkylating agents, platinum compounds, right? That's this one right here, alkylating agents and platinum compounds on the cell cycle. Independent drugs, DNA, right? So cross-linked DNA, and then you have erythrocycline, dectamycin, DNA intracalators, etoposide and tenoposide. We remember this from biochem. Sides there are always two sides to everything, so this is going to act on topoisomerase 2, and when you drink soda, you only drink one can, so that's going to be topoisomerase 1. So irinotecan and topotecan, it inhibits topoisomerase 1, and etoposide or tenoposide inhibits topoisomerase 2. Okay, and then RNA happens. RNA then goes into ribosome to make protein, and then proteins, there's cell division after that. So cell division is inhibited by vanco alkaloids. It inhibits these microtubules, right? So these are the microtubule ones, and for mitosis. Taxanes inhibit microtubule disassembly. Okay, cool. If you remember Sketchy, or if you've done it, it's the one with the Tarzan story. The tubules are the vines, and then they have taxanes and alkaloids represented by something else. Okay. Don't need that. Antibody drug conjugates. So you have conjugate drug antibody right here.
right? And then it goes here, attaches to this. Receptor mediated endocytosis goes in, lysosomal degradation, drug release, cytotoxicity. Okay, so this is how they usually do it. They attach the drug to an antibody, and then the antibody detects the surface marker, so it attaches to it. Then it gets phagocytized, or just endocytosis happens. After that happens, the whole globulin gets, I guess, degraded by the lysozymes and all its enzymes. So then it splits, the drug gets split, and then the drug goes and does its action, which causes cytotoxicity. Okay, so formed by linking monoclonal antibodies with cytotoxic chemotherapeutic drugs, selectivity against tumor antigens allowed targeted drug delivery to tumor cells while sparing healthy cells. This leads to increase in efficacy and decrease in toxicity. For example, adotrastuzumab, ementancine, or TDM1 for HER2 positive breast cancer. Okay. Bleomycin, so that's on this one. Okay. Bleomycin, okay, so anti-tumor antibiotic. All are cell cycle non-specific except bleomycin, which is G2 M phase specific. So it acts on these two phases, G2 and M phase. Okay. And the way you remember the side effect for this is actually, sorry. This thing right here. So we'll just look at this when we're doing that. Okay, so bleomycin is right here, the lungs, right? For bleomycin and pulsifin, it causes pulmonary fibrosis. And since there are two, that's how you remember that. What do you want to remember? I forgot. So it induces free radical formation, breaks in DNA strands. There's testicular. Sorry. Alright, so since it's two, it's used in two phases. That's what I was talking about. I don't remember it that way. I never remember drugs. That's why I'm going through it so fast. This is like my first thing. So, bleomycin induces free radical formation, breaks in DNA strands. Okay. If nothing else, definitely remember the side effects, and this really helps you do that because that's mostly what they test you on, right? So, clinical use is testicular cancer and Hodgkin lymphoma. Adverse effect is pulmonary fibrosis, skin hyperpigmentations. Okay. Then you have dectinomycin, intercalates into DNA, and it prevents RNA synthesis. It's used in Wilms tumor, Ewing sarcoma, and rhabdomyosarcomas. Effect is myelosuppression. Anthracycline, or that's okay. These are important. Doxorubicin and daunorubicin. Okay, so that's this D right here because it causes dilated cardiomyopathy, so cardiotoxicity. Okay, dilated cardiomyopathy, often irreversible. Prevent with dexrazoxane, and it causes myelosuppression. This is usually going to be a lot of them because that's how we deal with cancer. We suppress the immunity as well. Okay, so how do you remember that? I remember it like so there's dawn, so like dawn is dawn, right? And doxo is just dox dawn or Dr. Dawn.
I'm trying to connect it to this, but I just remember that it's Doxa and Dawn are like two partners in crime, and what they do is they try to steal. They steal rubies. Okay, and rubies look like free radicals, right? So when they're stealing, they beat up the person who has it, and they're usually innocent, and they have, they're beating up the heart. So just connect it to that. Okay. So Doxo and Dawn steal Ruby for free radicals, and they beat up the person, so they cause dilated cardiomyopathy. Okay, generate free radicals. They intercalate in DNA, break in DNA, and cause decrease in replication. It inhibits topoisomerase 2. Okay, there are two of them, Doxo and Dawn, and they inhibit topoisomerase 2. Okay. Solid tumors, leukemia, and lymphomas. That's what it's used for. But the adverse effect is the important one. So it causes dilated cardiomyopathy. It's often irreversible. Prevent with dexamethasone, and myelosuppression also happens because of this. Okay. So we talked about dactinomycin, busulfan, and anthracyclines. Okay, these are called ankylosing agents. That's anthracycline, busulfan, dactinomycin, nitrogen, mustard. We're going to talk about these, but we talked about these three so far. And these are cell cycle independent, so they don't have an action on the cell cycle. Okay. Now we're talking about S phase specific. Okay, so this is S phase. So antimetabolites. We'll talk about clotrimine, citarabine, 5-fluorouracil or 5-FU, hydroxyurea, methotrexate, pentostatin, and thioprines. Okay, we're at 48. How many pages to go? So metabolites, that's these things, right? All are S phase specific except for clotrimine, which is cell cycle non-specific. So that can happen anywhere, but it has a similar effect. That's why it's grouped up with antimetabolites. Okay, so you had thiopurines, right? Azathioprine or 6-mercaptopurine. We saw that in biochem, in the pathway, the salvage pathway, right over there, right? 6-mercaptopurine, it's a prodrug of azathioprine, inhibits de novo purine synthesis, and yeah. So we have so mechanism is basically purine or thiol analogs. It decreases de novo purine synthesis. Azathioprine is converted to 6-mercaptopurine, which is then activated by AGPRT, right? Remember, this was Lesch-Nyhan syndrome. Deficiency of this causes self-mutilation, uricemia, gout. P was for something, R and T. Rheumatoid arthritis. It's used for rheumatoid arthritis, IBD, SLE, ALL, steroid refractory disease, prevention of organ rejection, weaning from glucocorticoids as well. Adverse effect is myelosuppression, GI, liver toxicity, 6-mercaptopurine, is inactivated by xanthase oxidase. So it increases toxicity with allopurinol and or febuxostat. Okay, that's important. It's inactivated by xanthine oxidase. So if you give allopurinol or febuxostat, it's going to inhibit xanthine oxidase, right, from converting uh, uric acid to not uric acid, from xanthine to hypoxanthine or whatever. So these are not going to be utilized anymore. So you'll have more xanthine oxidase. So that will make 6-mercaptopurine, the drug, inactive. So then you have, you know, decreased efficacy then. Uh, Clozapine and pentostatin, so purine analogs, leads to multiple mechanisms. For example, inhibition of ADA. We read about these two right already. For example, inhibition of ADA and DNA strand breaks. It's used for hairy cell leukemia. This is important. Hairy cell leukemia. It causes myelosuppression. Then you have cytarabine, urbinofuranolcyl cytidine. So pyrimidine analog leads to DNA chain termination. It inhibits DNA polymerase. Leukemias, AML, and lymphomas, myelosuppression. Okay, cytarabine. So DNA termination. So everything's going to be something to do with this, right? It either breaks the DNA, stops its synthesis, or terminates its synthesis or termination. Right? So 5-fluorouracil pyrimidine analog bioactivated to 5-FDUMP. Right, that was that one. So that's 5-uracil and capecitabine, inhibiting thymidylate synthesis. And in folate deficiency, thymine reduces its apoptosis. Okay. Decrease in DTMP. Okay. Decrease in this because of that, which decreases DNA synthesis. Capecitabine is a prodrug. Colon cancer, pancreatic cancer, actinic keratosis, basal cell carcinoma, effect enhanced with addition of leucovorin. So that's what the uses are. Myelosuppression, palmar-plantar erythrodysesthesis, and foot syndrome. You have hydroxyurea, inhibits ribonucleotide reductase, decrease in DNA synthesis. Myeloproliferative disorders, for example, CML, polycythemia vera, sickle cell disease, and increase in fetal hemoglobin. And this is why we use it in sickle cell, right? Because there's increase in fetal hemoglobin. That's where we read about hydroxyurea. It causes severe myelosuppression and megaloblastic anemia. Methotrexate, again, right there. It inhibits dihydrofolate reductase, right? Folic acid analog that competitively inhibits dihydrofolate reductase leads to decrease in DTMP, which decreases DNA synthesis. It's used in cancers, leukemia, like ALL, lymphomas, choriocarcinoma, sarcomas, non-neoplastic, ectopic pregnancy. This is the one they do test you on out of all of these. Methotrexate. So the action of methotrexate is to inhibit DNA synthesis. Okay, so that's going to be the answer. Which drug would you give? A drug was given to terminate pregnancy. Which of these would be the mechanism of that drug. So they won't tell you it's methotrexate, but it was used in ectopic pregnancy, and then you need to know that it was the one that stops DNA synthesis. Okay. Ectopic pregnancy, medical abortion with mesoprostol, rheumatoid arthritis, psoriasis, and IBD and vasculitis. So it can adverse effects are myelosuppression, reversible with leucovorin rescue. That's what it's called. Sorry. Hepatotoxicity and mucositis. Mucositis. For example, mouth ulcer. Pulmonary fibrosis, folate deficiency. That's the important one. And this is teratogenic. That's why. And nephrotoxicity. Okay. Alkylating agent. Okay, back to these, and now we're going to talk about the other ones that we haven't talked about yet. All are cell cycle specific. We talked about bleomycin and now busulfan. It's similar. It causes pulmonary fibrosis as well, and that's the most important thing about that. Gotta remember that. Okay, what does it do? It cross-links DNA. Used to ablate a patient's bone marrow before bone marrow transplantation. So we give this before bone marrow transplantation. Okay, to suppress its, to prevent rejection. So adverse effect is severe myelosuppression in almost all cases, pulmonary fibrosis, and hyperpigmentation. Okay, this is an important one. And if they give you this, it's this one, because in bleomycin you don't get hyperpigmentation. Nitrogen mustard, cyclophosphamide, ifosfamide. Again, cross-links DNA, requires bioactivation by liver. It's used for solid tumors, leukemia, lymphomas, rheumatic disease, for example, SLE, granulomatosis with polyangiitis. Myelosuppression, Ciad-Fanconi syndrome, ifosfamide, hemorrhagic cystitis. This is an important one, and it's given over here too, cyclophosphamide in green, because it causes hemorrhagic cystitis. Okay, and basically the only thing that will prevent this is Mesna, and you give Mesna. So you give Mesna for hemorrhagic cystitis that's caused by a cyclophosphamide. And so it can cause that and bladder cancer. So prevent these with Mesna. Nitrous urea, carmustine, and lomustine. That's cross-linked DNA, requires bioactivation by liver, cross blood-brain barrier, CNS entry. Brain tumors, including glioblastoma. Put nitro in your Mustang and travel the globe. Doesn't really help. I don't think I remember these. So CNS toxicity, convulsions, dizziness, and ataxia. Okay. Procarbazine. The only ones I remember are the ones here. So those ones I did. And usually that's what's asked. Besides methotrexate, methotrexate, and all the ones where we did these ones I remember. I remember the ones that we have came across, but not all the cancer ones. Okay. Procarbazine, mechanism unknown, weak MAO inhibitor, Hodgkin lymphoma, brain tumors, myelosuppression, pulmonary toxicity, leukemia, disulfiram reaction, temozolomide, DNA methylation, glioblastoma multiforme, and myelosuppression. So basic thing is just remember that everything is used for treating cancer. So even if you don't remember the mechanism of action, just try to take a guess with what can help with that, right? So breaking DNA or stopping splitting of cells or something like that. Okay. Even if you don't remember all of them, that's okay. These are the ones that you do need to remember.
given here. And the thing you have to remember about them is their adverse effects, because that's what they usually ask. Besides methotrexate, they ask everything about that. Platinum compounds: cisplastin, carboplatin, and oxaliplatin. Okay. Uh, that's I think. Okay, let's see. It cross-links DNA cells. Oh, there you go. Platinum compounds right there. So non-specific. Cross-links DNA, cell cycle non-specific. Clinical use is solid tumors. For example, testicular, bladder, ovarian, GI, and lung, and lymphomas. Adverse effect is nephrotoxicity. Okay. For example, Fanconi syndrome, prevent with emifosfine, peripheral neuropathy, and autotoxicity. So autotoxicity is the important thing here. You gotta remember that one. So cisplastin and carboplatin, they're platinum compounds, and you see the ears here making the C for cisplatin. So that starts up there, and over here too, right? It's the two C's. So they cause nephrotoxicity and autotoxicity. Okay. Then you have microtubule inhibitors. That's these ones up here, texins and Venka alkaloids. All are AMP-phase specific. Drugs, mechanism, clinical use, and adverse effects: texins, docetaxel, and paclitaxel, right? And Venka alkaloids, vincristine and vinblastin. These are the important ones. These ones are the texins. They hyperstabilize polymerized microtubules, prevent mitotic spindle breakdown, and that's how it prevents splitting of the cells. Okay, so prevents mitotic spindle breakdown because it requires that for staying apart. So if it stabilizes them, it's not going to split. Clinical use is various tumor, for example, ovarian and breast carcinoma. Adverse effects are myelosuppression, neuropathy, hypersensitivity, Texas stabilized society. Venka alkaloids are vincristine and vinblastin. Bind beta tubulin and inhibit its polymerization into microtubules. They prevent mitotic spindle formation. Okay, inhibit polymerization into the microtubule, prevent mitotic spindle formation. So this one doesn't even let it build up the spindle, right? So again, it won't split. Right? So its microtubule inhibitors are taxins and Vinca alkaloids, which are vincristine and vinblastin. So clinical use is solid tumors, leukemias, Hodgkin, and non-Hodgkin lymphomas. Vincristine crisps the nerve, so it's neurotoxic. Okay, so UCV, vincristine, it causes peripheral neuropathy. That's important for that. Crisps the nerve, so neurotoxicity, axonal neuropathy, constipation, including ileus. Vinblastin blasts the marrow, so it causes myelosuppression. Okay, Christine crisps the nerve, blasts the marrow. And topoisomerase inhibitors all causes increase in DNA degradation, resulting in cell cycle arrest in S and G2 phase. Okay, S and G2, so it affects both of these, S and G2, like bleomycin affects G2 and M. Okay, so you have drug mechanism, clinical use, and adverse effect for irinotecan and topotecan. You only drink one can of beer, or you drink one can of Pepsi or Coke. Inhibit topoisomerase 1, decom 1. Right? Clinical use is colon, ovarian, or small cell lung cancer. Adverse effect is severe myelosuppression and diarrhea. The important thing is mechanism for these. Remember that. It's used for almost all the cancers.
so they won't ask you for that. This is also, it's going to cause myelosuppression. We already know almost all the cancer drugs do that. And diarrhea is very non-specific, so this is the thing that they would test you on. Etoposide and teniposide inhibits topoisomerase 2. That's what they're going to test you on. There are two sides to a coin. Testicular small cell lung cancer, leukemia, lymphoma, myelosuppression, and alopecia is a different one. So I guess you can remember that one. Tamoxifen mechanism is selective estrogen receptor modulator, also known as SERM, with complex mode of action. Okay. So SERM with complex mode of action, which is antagonist in breast tissue, partial agonist in endometrium and bone. Okay, so that's actually a good thing if you are trying to, prevent osteoporosis and all that stuff. So it has a agonist action on bone and endometrium. It blocks the binding of estrogen to ER and ER positive cells. Okay. Clinical use is prevention and treatment of breast cancer, prevention of gynecomastia in patients undergoing prostate cancer therapy. Okay, so this is useful in men. Prevention and treatment of breast cancer, prevention of gynecomastia in patients undergoing prostate cancer therapy. Then you have adverse effects: hot flashes, increased risk of thromboembolic event, and endometrial cancer. Important adverse effect. Also, clinical use is pretty important for tamoxifen. That as well as raloxifene, that we might be doing in pre-pro. Okay, so anti-cancer monoclonal antibodies work against extracellular targets to neutralize them or to promote immune system recognition. For example, ADCC by NK cells, eliminated by macrophages, not cleared by kidney or liver. Agents are ilimtuzumab, target is CD52, chronic lymphocytic leukemia, multiple sclerosis. Adverse effect is increase in risk of infections and autoimmunity, for example ITP. There is bevacizumab. This is an important one. Why? Because it targets the VEGF. It inhibits blood vessel formation, right? There are two things that cause blood vessel formation or angiogenesis. It was VEGF and FGF. Alright, fibroblast growth factor. It's used in colorectal cancer, renal cell carcinoma, non-small cell lung cancer, angioproliferative retinopathy, adverse events: hemorrhage, blood clots, impaired wound healing. Cetuximab and penituzumab, or EGFR, is the target. It's used for metastatic colorectal cancer, wild type RAS, head and neck cancer. Adverse effect is rash and elevated LFTs and diarrhea. Rituximab is Ritu is like a girl who's 20-year-old, right? So Ritu, someone you know, is that, and she's 20-year-old. So remember that. This is an important one. Rituximab, CD20. Okay, it's used for non-Hodgkin lymphoma, CLL, rheumatoid arthritis, ITP, TTP, autoimmune hemolytic anemia, multiple sclerosis. Infusion reaction due to cytokine release following interaction of rituximab with its target on B cell. Okay, important thing here is that it acts on CD20. This thing. Okay, trastuzumab. This is another one that causes dilated cardiomyopathy. You'll see it over here between the T, between the D. You see a T, right? HER2, trust her. It's used for breast cancer, the HER2 type, and gastric cancer as well. Okay. because remember HER2 was this, and I told you that you'll remember breast cancer, but you'll forget gastric cancer. So it's used for this as well. Dilated cardiomyopathy, often reversible. Okay, this is the death ligand one, or ligand. Was it? You know. And this thing that we went over. So so pembrolizumab, or this, it attaches to PD-1, right there, right, and then you have all of these that attach to PD-L1. Okay, that's over there, and this is ipilimumab, or it attaches to the costimulatory one, or CTLA4. Okay, what's this? These are the tumor cells that have these PDL1 or death ligand inhibitors. That's what they're called. They attach to PD1 on T cell, and they exhaust the T cell action, right? So then T cell doesn't function like it's supposed to. So that's how tumor cells avoid or escape immunity. Okay, so what do these things do? They block either this, or they will block this, or they block the costimulatory. So tumor can't influence the T cell activation. So it blocks their influence on it. So then T cell gets activated, right, and it destroys the tumor cells then. Okay, so various. I don't think you need to remember these names because they won't show up. They'll just explain what's happening, and then you have to figure out if it was PD1 or PDL1 or CTLA4 that's happening, or its action. The action is that it increases neutrophilic action and T cell action and all that stuff. When tumor cell attaches to this, it decreases that stuff. It suppresses T cell synthesis and action. Various tumors, for example, non-small cell lung cancer, or renal cell carcinoma, melanoma, urothelial carcinoma, that's what it's used for. There's increase in risk of autoimmunity, for example, dermatitis, enterocolitis, hepatitis, pneumonitis, and endocrinopathy. None of this is important. What's important is that you remember this and this thing right here. Okay, let's go over it. The binding of PD-1 to PD-L1 downregulated the immune response by inhibitory cytotoxic T cells. It's cytotoxic T cells, that's CD8 cells, not CD4. That's important to remember as well. That's CD8 cells. Many types of cancer evade immunodeletion by increasing expression of PD-L1 on their surface. Monoclonal antibodies against PD-1 by they upregulate the T cell response and promote tumor cell apoptosis. Okay. Okay, don't need that now. So anti-cancer small molecule inhibitors. These are alectinib, crizotinib, target is ALK. Actually, I'm not going to bother going through these because I'm not going to remember them, and they don't get asked either. And if they do, it's just 1 mark. Just take a guess and move on. Because none of these actually get asked that much. I would like do this. This looks easy, but I haven't came across any questions that involve any of these. So, moving on. Chemotoxicity, amelioration. Okay, that's the one we need to know about is dexaroxazoxane. This is iron chelator. So cardiotoxicity for anthracyclines. Let's go through all of them. So Amifostine, this is free radical scavenger. Nephrotoxicity toxicity from platinum compounds. Okay. Then from dexaroxane, because since it's an iron chelator, causes cardiotoxicity from anthracyclines. Leucovorin for the leucovorin escape. This is THF precursor. Uh, Myelosuppression from methotrexate. That's what it's used for. Uh, oh wait, no, never mind. It doesn't cause that. Okay, I read that wrong. Sorry. Yeah. So it's drug mechanism clinical use. So amifostine is free radical scavenger, and it's used for nephrotoxicity from platinum compounds. Okay. Dexrazoxane. This is iron chelator. Cardiotoxicity from anthracycline. That's what it's used for. Okay. These were the platinum compounds. Okay. That's what this is used for. Myelosuppression from methotrexate, leucovorin rescue also enhances the effects of IFU. Mesna is an important one because it's used for hemorrhagic cystitis from cyclophosphamide or ifosfamide. How? Sulfurhydryl compound that binds acrolein, toxic metabolite of cyclophosphamide and ifosfamide. There's raspberry case. So raspberry case is recombinant uricase that catalyzes metabolism of uric acid to allantoin. Uh, tumor lysis syndrome. That's what we use it for. Ondansetron and granisetron. This is 5-HT3 receptor antagonist used for acute nausea and vomiting, usually within 1 to 2 hours after chemotherapy. Prochlorperazine or metoclopramide D2 receptor antagonist. Acute nausea and vomiting, usually within 1 to 2 hours after chemotherapy. Aprepitant and fosaprepitant, that's NK1 receptor antagonist. Delayed nausea and vomiting, chemoreceptor, more than 24 hours after chemotherapy. So, yeah. Fletristine and sargramostim. Recombinant GM CSF, neutropenia. Apotin alpha, recombinant erythropoietin, and anemia. So it's apotin alpha, not erythropoietin alpha. Okay, it's recombinant erythropoietin is used for anemia. Key chemotoxicity, so cisplastin and carboplastin is autotoxic and nephrotoxic. Vincristine causes peripheral nephropathy because it crisps the nerves. Bleomycin and busulfan causes pulmonary fibrosis. Doxorubicin and daunorubicin, they beat up the heart. So cardiotoxicity. Trastuzumab is you trust her, right? And cardiotoxicity. That's what it causes. Cisplastin, and we did that. Cyclophosphamide causes hemorrhagic cystitis, and you give Masna for that. Non-specific common toxicities of nearly all cytotoxic chemotherapies include myelosuppression, neutropenia, anemia, thrombocytopenia. GI toxicity is nausea, vomiting, and mucositis, alopecia. Okay, and we're done.